Good morning. I request all of you to please occupy the seats in front. Please occupy the seats in front.
Good morning, everyone. All the presenters are requested to submit their presentations at the AV behind the stage. Thank you so much.
Good morning, everyone. A very warm welcome to all the eminent experts, esteemed guests, and cherished members of the institution to EFICON 2025. May I now request the President of EFI, Dr. Umesh Kapil, to accompany the chief guest for today, Dr. M. Srinivas, Director, All India Institute of Medical Sciences, on the dais. I may request the other dignitaries, Secretary EFI, Dr. Pradeep Agrawal, Dr. Ashok Bhardwaj, Vice President, Dr. VP Srivastav, Treasurer, and Dr. Gagandeep Singh, Organizing Secretary, to please come on the dais. A very warm welcome to all our esteemed guests to EFICON 2025. It is a proud moment for all of us that we are celebrating 150th anniversary of our national song. So today's programs proceeding, we'll be starting with Vande Mataram. I request all our guests and eminent experts to kindly rise for Vande Mataram.
Vande Mataram, Vande Mataram, Sujata Sugara, Vajasi, Satya Shyamala Mataram, Vande Mataram. Jyotsna pulakitayamini Pullakusumita Pullakusumini Suhasini Madhurabhashini Suprabham Varadam Mataram Vande Mataram
Thank you, everyone. Please be seated. I once again welcome all our esteemed guests and eminent experts and dignitaries to the EFICON 2025 6th Annual National Conference of Epidemiology Foundation of India. And to deliver the welcome address, may I now request Dr. Gagandeep Singh, Professor Microbiology and Organizing Secretary EFICON, to please come and welcome our guests.
Thank you. Good morning, distinguished guests, respected colleagues, and dear participants. It is my great pleasure to welcome you all to EFICON 2025 at AIIMS New Delhi. This conference brings together clinicians, researchers, and public health professionals to share ideas, discuss new evidence, and strengthen collaborations in public health and clinical medicine. The nation, as you know, is at the crossroads of innovation and tradition, and EFICON stands as a testament to our collective commitment to excellence in science and patient care. I also take this opportunity to sincerely thank our director, Dr. M. Srinivas, whose vision and encouragement have made this event possible and whose leadership continues to inspire the entire fraternity. I wish all participants a highly productive and enriching conference. Thank you so much.
Thank you, Dr. Gagandeep Singh. The Epidemiology Foundation of India has been set up to initiate, encourage, promote, and assist, stimulate, and sponsor programs related development of epidemiology and measures in rural as well as urban areas that aims at improving the quality of life through promoting social, environmental, and economical well-being. कहते हैं असंभव भी संभव हो सकता है अगर मन में हो विश्वास, बशर्ते ठान लिया जाए और इसके लिए निरंतर किया जाए प्रयास. The Epidemiology Foundation of India is continuously working for the betterment and the encouragement of people and to prevent the diseases. As we are talking about One Health, the PM's initiative of One Health that is focusing on preventing health and making people aware of the health conditions So this organization is working for the same. May I now request to tell us Dr. Pradeep Agrawal to kindly brief about the vision of Epidemiology Foundation of India. Please put your hands together for Secretary EFI, Dr. Pradeep Agrawal.
Good morning, everyone. On the behalf of Epidemiology Foundation of India, I just would like to inform we started in 2018. It is just over 7 years that currently we are having our global presence in more than 50 countries, having more than 7,000 members, and all practicing epidemiology. We always ensure making members is a part of not only our epidemiology and our medical science. We want to include everyone to contribute scientifically and academically towards the Epidemiology Foundation of India. Moreover, Epidemiology Foundation of India is having a main crux theme and a foundation of practicing evidence-based medicine. The latest global best practices, which are epidemiologically, scientifically sound, should be practiced by each and every member and any other in the field of health and science. Lastly, I would like to bring to your knowledge that we are having our own journal, that is quarterly journal, index journal, Journal of Epidemiology Foundation of India. I look forward for your active participation and contribution in the activities of JEF. Thank you.
Thank you, Dr. Pradeep Agrawal. कहते हैं शिक्षा अंधकार से प्रकाश की ओर ले जाती है और प्रकाश जो हमारे जीवन की सभी समस्याओं को दूर करता है। तो आज के कार्यक्रम की शुरुआत भी हम करेंगे दीप प्रज्वलन के साथ। And may I now request all the dignitaries and special guests for the lighting the lamp ceremony. May I request the chief guest, Dr. M. Srinivas, Dr. Umesh Kapil, President, EFI, Vice President Dr. Ashok Bharadwaj, Dr. VP Srivastav, Treasurer, Dr. Gagandeep Singh, Dr. Pradeep Agrawal. To accompany them, please put your hands together for lighting the lamp ceremony.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव।
Our chief guest and the dignitaries for this lighting the lamp ceremony. हर कार्य को करने के पीछे उसका जो उद्देश्य है वो बहुत महत्व रखता है। So EFI is also working and the objectives of this really matters. May I now request to highlight the objectives of Epidemiology Foundation of India. I request the Vice President EFI, Dr. Ashok Bharadwaj, to share with us the vision and objectives of EFI.
Respected Director AIMS, Dr. Srinivas, our most energetic President, Dr. Umesh Kapil, the Secretary, Dr. Pradeep, Dr. Srivastava, esteemed faculty of the dais, students, colleagues. So the main objective of EFI was said or told by Dr. Pradeep Agrawal initial comments. We are here in EFI to promote evidence-based medicine and health practices by all health professionals, health providers, be it academician, be it researchers, be it program managers, be it policy makers, be it field workers, and faculty working in various training institutes. So our aim, the aim of more than, I will say more than 8,000 member is to promote health of the society, be it urban areas, be it rural areas. So we have to promote through EFI, we are promoting research for taking action and making policies for the health of the population. So EFI aims to bridge the gap. We want to bridge the gap between the human and nature, between the clinics and community, and between research and real life. So we promote, we align with Government of India's programs and policies for implementing those in the community. So we have to work for it, and new initiatives which are brought by Government of India, the EFI stands by it and promote it. So the biggest example is One Health. So we have to have one health, one nation, and one world, and EFI stands for it. So with EFI in our mind, as members of EFI, we will promote everything related to the well-being of our society in India. Thank you very much.
Thank you so much. One Health Mission is Honorable Prime Minister's policy for holistic management of diseases. WHO has emphasized on the importance of integrated surveillance and laboratory strengthening within One Health framework to improve early detection, outbreak response, and control of zoonotical diseases. Specifically, EFI is also working for the same if we talk about leptospirosis. To highlight the scientific program of EFICON 2025, I would request Professor Umesh Kapil, President EFI and former professor and head Department of Gastroenterology and Human Nutrition, All India Institute of Medical Sciences, to tell us more on this. Dr. Umesh Kapil.
Thank you very much, Ms. Kiran. I'll just briefly mention about what are the different component of the scientific program. We have state-of-art presentations from different government and non-government institutions. We have state-of-art presentation from ICMR, UNICEF, World Food Program, Ministry of Health and Family Welfare, NCDC, NIRI, that's Nagpur, National Institute of Occupational Health. We have from Global Health Advocacy Institute, Public Health Foundation, many development partners, and the faculty from many aims like institution or aims in the country. What we have done, we have taken the state of art topics of national importance and requested each of these institutions to come out and make a presentation over here so that all of the participants and the faculty get benefited. The main emphasis has been epidemiological basis or how the epidemiology evidence can be utilized for the development of health of the people. So our main aim has been to improve the health of the people through epidemiological based intervention. If you recall, even during the COVID period, every state secretaries, every minister was requesting for funds for different things based on the scientific evidence. So the scientific evidence is gradually picking up in almost all circles of our society, be it scientists, be it bureaucrats, be it general public. So we have put down state of art presentation, and my humble submission is we had about 800 registrations, and because of the last night episode, we had a lot of cancellations. But all I request you most humbly that please come tomorrow morning at 9 o'clock. We have some important sessions, and you will be learning a lot from these sessions, right? So thank you very much for coming over here. I am personally grateful to you. Thank you very much.
थैंक यू सो मच डॉक्टर उमेश कपिल. कहते हैं व्यक्ति श्रेष्ठ साधन से नहीं साधना से होता है, भवन से नहीं भावना से होता है, और उच्चारण से नहीं उच्च आचरण से होता है. There are leaders and then there are visionaries, the ones who don't just manage institutions but transform them. Under his dynamic leadership, and reputed National Institute has scaled up new heights, setting benchmarks of excellence and innovations. His vision became the roadmap, his dedication became the driving force, and his perseverance became the foundation of success. Ladies and gentlemen, please join me in welcoming the man whose leadership has inspired hundreds and whose commitment has shaped futures, the distinguished director, All India Institute of Medical Sciences, Dr. M. Srinivas. Please give him a big hand.
Good morning, Namaskar. The introduction which he was giving, I was thinking about Professor Umesh Kapil. Give a big hand to him first. He has been our teacher, and I was exactly when he stood up, it was in my mind, and what all she was saying is directed to me. But actually, respected Professor Umesh Kapil, Professor Ashok Bharadwaj, Professor Pradeep Agarwal, Dr. V.P. Srivastav, and our own colleague, Dr. Gagandeep. And there are luminaries here, the peoples from National Institute of Virology, various senior faculty members, directors, chiefs, and everybody. This is something which reminds us that, epidemiology is a holistic science. Suddenly I think about my own community medicine way back in 1980s, 84, when we took the park. I thought it's a encyclopedia, that truly an encyclopedia. And today I still feel that the encyclopedia is there, and the people who are shaping this encyclopedia is here. I think organizers should be given a big hand that they brought all here. And definitely, sir, the 700 people will join you. Don't worry. छोटा सा पटाखा होता है, कोई फर्क नहीं पड़ता है. So it's a privilege to welcome you all to the All India Institute of Medical Sciences. You all know that, AIMS New Delhi, NRF rankings #1 with the Trinity mission of patient care, teaching, learning, research, administration, good governance, policy, advocacy, and now the honor of EFICON. Again, truly honored and humbled that, you chose us, this venue for the AIMS New Delhi. And to each one of you, that's the beauty of this organization and this conference, the epidemiology subject as such, that, you have everyone, you have medicine, epidemiologist, public health specialist, clinician, scientist, administrator, student, you name it, anybody who is connected to the prevention, disease, control, everything. And sir was telling about bureaucrats, budgets, evidence-based. So everything in toto, I think the entire 5.5 years of MBBS course is compressed into epidemiology. I think you have done that, and you brought all these people, the big accolades to you that you have brought the people here. And the people have been talking about One Health now. This is the thing which we always believed. If you look back into our centuries of knowledge which we had, we always talked about One Health. And now again, the science has come back to the One Health, and the government and the commitment which came from this podium just now, that, how the interplay of everything is working, and then why we need to look into the epidemiology and One Health as one thing. And I've been told that there are 7,500. See, being a pediatric surgeon, when I registered as a pediatric surgeon in this country, I was 376. Maybe now we are 1,000. Thousands of people looking at the country and looking at the things, how best we can shape not only the country, but the mankind, and then role model to the rest of the world. That's what the COVID has shown, that, there are people who are the experts in COVID here from the NIV Pune. The entire world has learned from us. That's where the strength of epidemiology, strength of the experts in the field in this country and that gets a recognition. What sir was saying, not just the ministry. I think it is beyond the thing. We look into the thing. The whole world looks at us now. How we did work on the COVID and what kind of epidemiological processes we kept in, and what kind of challenges we have, and what kind of solutions we are going to give it to the rest of the world, including the themes of One Health. That's where we stand here. And what has been said, that it is not just an academic gathering. Yes, it is not just an academic gathering. The most important thing I see, and especially the youngsters, that please, it's an opportunity for you to meet the people who are the experts in the domains. Very rarely you get all these people in one platform. We may see them in the newspapers, we may see in the TV, we may see it on a textbooks as an author, but you have an opportunity to network with these people now. I think utilize this time, discuss with them, not just for your career progression, not just for your knowledge, but how best we can look into the problems facing the nation, and the solutions which we give are going to be solutions for the entire world, the global south. See, because any solution which comes from here is the solution for the entire Africa and the South America and the entire global south. And that's where, I urge all of you that, please use this opportunity, the youngsters and the people who are into the epidemiology, various departments, please explore this and connect with these people and network with these people, and see that, you best utilization of the time which you are going to spend here. And then I'm very happy that, AIMS has been chosen for this. And once again, thanks to sir that, and when you are here, you go through the thing, not only the department of Professor Umesh Kapil, the human nutrition, the community medicine, our own Ballabgarh center, the where way back 3-4 decades back, the community health, how the epidemiology shaped in the Ballabgarh, Today, I think, that was the only center. See, we talk about Framingham study and all this and all that. Go to Ballabgarh, at least. If the time permits, I think they should be given a chance, or somebody will give an example of how our community medicine adopted a particular hamlet of the villagers. And today, everything is on a desktop, on the data, that who are the people, how many are there, what is the sex ratio, what kind of immunization they have gotten, what kind of disease they have. All that has been captured over a period of 30-40 years by our teachers and teachers and teachers. That is something, there's a living example of how an epidemiology will shape the policy and advocacy. You name the policy advocacy of this country, whether it is iodization of salt, whether it is ORS, small things, I'm just quoting some of the things. All that has been tested, validated in this institution. And that's the befitting recognition that the organizers have chosen this institution. And my request to you is that please build the team, because epidemiology, unlike the most of the things, every science has become a teamwork now. Being a pediatric surgeon and neonatal surgeon, surgery, we also know that, I had to network and get along well with the anesthesiologists, nursing care, post-op and all that. But yours is a huge numbers. Everybody is involved: doctors, nurses, health assistant, epidemiologist, nutrition, you name the thing, everybody is connected to that. That's where your team spirits and your networking will work. And this is that you have to the brand ambassadors. We have to the brand ambassadors. When you go back to your institutions, tell them that, you saw this best example of a successful model, maybe here or there, wherever it is. And why it is successful? Because the people have built the team. The team has the leaders in every aspect of the entire spectrum of epidemiology. That's something which we have to give. That's when you go back to your institution, please tell them. And also the importance of One Health, which is being spoken to about it. And then I just wanted to share with you that AIMS is also committed for this science as of epidemiology. And then just to share with you, sir, there are a lot of discussions in our own institution for public health institution. I'm very confident that, we will go through that. And evidence-based medicine department as a separate department is also happening, because it has gone through some of those statutory requirements in our institution. And we will be, maybe the next year when you have the EFICON, then you say that, AIMS was discussing about it, and then they have committed and they come out with these two wonderful initiatives at AIMS New Delhi. On behalf of the AIMS, once again, I welcome all of you, and then really looking forward for an intellectually stimulating, professionally rewarding, and personally enriching. And the most important thing, which I urge you, that you are the team members, you are the brand ambassadors. When you go to your institution, please tell them that, we need to build a team team of which components of the members. That's where you will see here the success story of the people. The leaders who have achieved is because of the teamwork. That's where you need to reinforce that particular ethos, and then of course carry forward the whatever the learnings which you have interacting with the people here. And then, as we say, One Health, I think one more theme which we need to carry forward, that whatever we achieve in this institution, in this country, through the EFICON, it is a global South solution for the entire world. Thank you very much. Jai Hind.
Thank you, Dr. M. Srinivas, for that motivating and insightful address. किसी भी काम को करने से पहले या करने के लिए 3 बातें हमेशा दिमाग में रखनी चाहिए। पहला, लक्ष्य क्या है? दूसरा, कुछ भी असंभव नहीं होता, और तीसरा, मेहनत कभी बेकार नहीं जाती। All India Institute of Medical Sciences and Epidemiology Foundation of India has been continuously and sincerely dedicatedly working for the betterment of masses, and as we talk about preventive health and One Health. To deliver the vote of thanks, may I request Treasurer EFI, Dr. VP Srivastav, to come on the podium, please.
Lot of has already been talked about EFI. Everybody knows that without epidemiology, our medical science is incomplete. So honorable dignitaries on the dais and off the dais, I am very grateful to the authorities of AIMS, especially Professor Srinivas, for giving opportunity to organize this national conference at this Apex Medical Institute. I must thank Professor Gagandeep, Professor Kiran Goswami, I think she has not yet joined, and their colleagues for organizing this academic feast. I must also thank Professor Kapil, the president, for taking lead along with Professor Bharadwaj, vice president, and tireless efforts of Pradeep Agrawal, secretary, along with organizing committee members. I am also sure the delegates would be benefited by the rich scientific session and deliberations by eminent speakers, and also enjoy our hospitality. Thank you.
Thank you, Dr. Srivastav. I request everyone to please rise for national anthem.
जय गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 जय।
Thank you, everyone. I once again thank all our guests and dignitaries for joining in for EPICON 2025. Thank you, everyone.
Very good morning, everyone. I would like to request all the speakers to come up front. I request all of you to please be seated. We'll be starting with the sessions very soon.
Once again, good morning and welcome to this EPICON conference. We are starting with the first technical session, and I invite Dr. Nivedita Gupta. She is head of the communicable diseases at ICMR headquarters. Dr. Nivedita Gupta, please come. And she is going to give a talk on overview of the National One Health Mission. As all of us know that the government is now particular about integration of human efforts, animal and environmental interaction so as to control epidemics before as a proactive measure. And she is going to give us an overview of the National One Health Mission. What is the National One Health Mission and what are the important components and how it can help us in controlling and managing pandemics. Thank you so much. Dr. Nivedita Gupta, please.
So very good morning to all the esteemed dignitaries who were on the dais and off the dais as well. And my special gratitude to President Epidemiology Foundation of India, Dr. Umesh Kapil, Vice President Dr. Ashok Bhardwaj, Secretary Dr. Pradeep Agarwal, and Treasurer Dr. VP Shrivastava, as well as all the other organizers of this very important event. And special thanks to Director AIMS, Dr. Srinivas, for hosting this and inviting us to this very valuable meeting and discussion. So we've been talking about One Health since morning, since this program started. So I will give you an overview today of the National One Health Mission, which has been launched by the Government of India under the aegis of the Principal Scientific Advisor to the Government of India. So I'll tell you what this program is and what all work is ongoing under this program, under various ministries, departments, and how we are planning to come together. So all of us do understand now, especially after the COVID-19 pandemic, and I would say even before that, that there is a complex interrelatedness of health among the human, animal, and environment sector. So what we have been doing till now is we always have worked in silos. The human health departments work in their own vertical, the animal departments work in their own vertical, Ministry of Environment, Forest, wildlife and climate change, they have their own vertical, and so on and so forth. But now, after repeated spillovers of zoonotic infections, particularly during the past 2 decades when we witnessed Nipah, we witnessed MERS, we witnessed SARS, then H1N1 swine flu, then Ebola, and then Zika and SARS-CoV-2. So we all now deeply understand that unless we start working together and look at health together, and not work in silos. We have to have an integrated approach for looking at health of humans, animals, and environment. And then only we can actually be prepared and protect ourselves from future pandemics. So this discussion also happened at the highest level within the Government of India in way back in July 2022, wherein it was discussed that India should have its own national One Health mission. And this came out as a recommendation of the Prime Minister's Scientific Technical Innovation Advisory Council. So after that, the work of the mission started, and it was the PSA was entrusted with the job because each department has its own complexity of working with the other one. So that's why PSA was entrusted with this task of making this mission. And this is the glimpse of the mission. There are 16 different departments and ministries who come together under the National One Health Mission, and they execute several functions. And the state governments, as well as the other national and international bodies, like, for example, Epidemiology Foundation of India, Association of Microbiologists, Virologists, we are trying to loop in everyone who can propagate this mission and contribute to the mission. So this is how it looks like. And fortunately, the Department of Health Research and the Indian Council of Medical Research is the secretariat of the One Health Mission. So we are entrusted with the responsibility of implementing various tasks that are decided under this mission, also monitoring and funding them. And to this effect, there is an institute in Nagpur, which is known as the National Institute of One Health, which is being built now. And my colleague, Dr. Pragya Yadav, who's here, she is the director in charge of this institute right now. So this institute was initially envisaged as a small center of ICMR, a satellite center. But moving on with the creation of the National One Health Mission, this institute will anchor the activities of the mission. And it has a very important role that it does not belong to a single department or ministry. It is everybody's institute. So whosoever is a part of the, I would say, NOHM, National One Health Mission, is now has a space within this institute and would be expected to function partly from this institute whenever it comes up in near future. Now coming to the objectives of the National One Health Mission, which was actually approved as a standing finance committee document of Government of India in October 2023. Since then, the activities have been executed, though the institute is still in its making, but we have already started the work of the mission. So there are 6 different objectives of this mission. First is integrated R&D across sectors for early detection of epidemics and pandemics, then building frameworks of disease surveillance across human, animal, and environment sectors. Then also make a roadmap of targeted R&D for fast-tracking medical countermeasures, that is vaccines, therapeutics, and diagnostics, and genomic tools for pandemics. Coordinate research, data, and information systems for decision making, and also create a cadre of trained professionals for R&D, joint outbreak response, and analytics. And the 6th objective is to foster global linkages. Now, I will be taking you objective by objective what is happening under the National One Health Mission. So when we talk about holistic R&D, conduct of holistic R&D, it means that money has been allocated to ICMR, but it does not mean that ICMR will use the entire money of the NOHM. We are inviting regularly projects from other departments, the 16 departments that I showed you in the earlier slides, and we are actually reviewing them and funding them, where there are at least 2 to 3 different partner departments working together to actually nurture the idea of One Health. So these projects do not belong to a single department. They are generally projects where 2, 3, 4 partners are working together. The other very important objective that we are executing is to do integrated surveillance, and there are quite a few things that we have initiated under this objective, and I will take you through that. So first of all, what we thought, particularly at ICMR, that if we want to be prepared for the next pandemic, what should be our first step? How do we understand that a disease has started transmitting? What do we do to understand that? So we first of all took a decision through several deliberations that first of all, we should actually launch a syndromic surveillance program. Right now, what we do is this is a dengue suspect patient. So we will test the patient for dengue, chikungunya, maybe 2, 3 illnesses, and then leave the patient. But we don't offer a comprehensive syndromic testing or even syndromic surveillance for that matter. Now, I will tell you what is the importance of syndromic surveillance in subsequent slides. First of all, it gives us a very broad coverage. We are able to look at multiple pathogens which present with a similar kind of syndrome. It helps us in early detection of outbreaks because we are testing with an open mind. We are looking for different pathogens in one go. So we have a possibility of actually detecting a pathogen. There is more probability of detecting a pathogen and also detecting an outbreak in very early stages. Then this platform also helps us to detect novel or unknown pathogens because all the syndromic surveillance platforms are backed by metagenomics, next generation sequencing platforms, where even if by a battery of tests we are not able to detect a pathogen, we are at least able to do metagenomics and find out whether there is something new that is emerging here. Also, it helps us to do real-time monitoring of several diseases together. Now, this is how, unfortunately, I do not have a pointer, but I will try to explain it. Like whenever a disease is detected, and in this slide in red, you can see that we have actually prioritized 4 major syndromes of infectious diseases. That is acute encephalitis, respiratory illness, fever, and diarrhea, the one shown in red. So in these syndromes, which cover a multitude of infectious diseases, we have already launched syndromic surveillance. And whenever we find a patient who has a particular syndrome, which I'll be showing you in the subsequent slides, that how do we do this testing? So the 4 syndromes that I have listed in red on this slide, whenever there is a patient who's presenting with any of these syndromes, the sample is collected, it is subjected to a battery of tests for infectious pathogens, and at least 20% of the unknown samples, the samples where we could not detect any pathogen, we subject to metagenomic analysis and we try to find out what is it. Because that's the only way we can find a novel pathogen or a new pathogen and be ready for the next pandemic. So this surveillance we are doing in clinical settings, And if you see the other part of the slide, we are also doing this surveillance at animal-human interface. We have launched projects at interfaces where we are trying to understand what are the spillovers that happen when humans work in close proximity with animals, what are those diseases, and how frequently they spill over. So for actually doing the syndromic surveillance, we undertook an extensive pathogen prioritization exercise. The 4 syndromes that I showed you in the previous slide, we really wanted to understand that what pathogen should be tested in each of those 4 syndromes. So we did this prioritization exercise by setting up multiple working groups, doing many meetings, and having a lot of microbiologists, almost 40 microbiologists, 25 clinicians on board from different parts of the country, and doing prioritization by extensive literature review, as well as personal experiences or professional experiences of these clinicians and microbiologists, because there is actually a paucity of published data in this area. So we actually did whatever we could have. And we also created a layered system of approvals. For example, the working groups created a list, then the expert groups reviewed it, and then DG ICMR also looked at it. And then finally, we have these lists vetted and up on ICMR website. We have shared all these lists with the IVD manufacturers in India, because unfortunately, the multiplex kits that we use for syndromic testing in India are not India specific. For example, the acute encephalitis panel that we use in India does not have Japanese encephalitis, which is such a glaring gap. We don't have scrub typhus in the panel. So there is no customized panel for India. So the entire exercise was meant at having these panels customized. So these are quickly, I'll show you the lists of priority pathogens that we have developed, and they are there on the ICMR website. Priority 1 is something which is very common in clinical settings, 2 is less common, and 3 is least common. So at least for priority 1 pathogens, we really want to have adequate testing capacity. I won't take time on this. You can check all this on the website of ICMR. Now, the structures that are involved in the syndromic surveillance are our virus research and diagnostic lab network, which is a 165 lab-rich network across all parts of India and is competent of testing viruses of routine infectious etiology as well as high-risk viruses. And I will just give you a glimpse of what kinds of syndromic surveillance we are doing currently. So this is our syndromic surveillance of respiratory viruses at 73 sites in India, wherein we are testing influenza, SARS-CoV-2, RSV, HMPV, and Nipah virus in patients who present with acute respiratory infection as well as severe acute respiratory infection. So first one is in community settings and SARI is from hospital settings. So it's a tiered network of several labs now with NIV Pune sitting at the top, mentoring, hand-holding, providing quality. So this is an interesting graph, which is again there on the ICMR website. So this is a graph actually which depicts the trends of the prevailing respiratory viruses in India week by week. So you can check on the website of ICMR every week and see which virus is predominating in terms of transmission and which viral infection is going down. So this gives you a glimpse, and the earlier in June 2025, when we had a COVID-19 upsurge, our surveillance could pick up this upsurge. And similarly, the recent upsurge was due to H3N2. So this surveillance keeps on telling us what is new and what is prevailing. And it also tells us we were also able to detect spillovers of avian influenza from poultry to humans through this network. There have been 3 spillovers that we have been able to detect in the recent past. So this network is very useful and we keep on sequencing and looking at data over time. We have similar surveillance for acute encephalitis syndrome, wherein we are testing for more than 30 pathogens and we are able to understand the seasonality, the trends of the prevailing encephalitic viruses, or in fact, not viruses, but pathogens here, because we are testing for all. And it also, whatever is negative, we are subjecting it to a metagenomic analysis to understand that what is that which we are not able to detect in the routine clinical settings. We have a similar surveillance for acute fever at 38 sites in India, wherein we are testing almost 10 pathogens in patients of acute undifferentiated febrile illness. So is the case with diarrhea surveillance. So these are the 4 surveillance programs which we are running. The later two we have not, I do not have mature data to show at this point in time, but they have been rolled out, and probably in a year or so, we will be able to see some data trickling. We also launched a similar project to detect the cause of etiology of Chandipura virus disease, which was again a multi-sectoral One Health project, wherein all the relevant departments have come together and working in Gujarat to find out what is the etiology of Chandipura and what are the animal reservoirs, what are the transmission dynamics, because it's a disease about which we hardly know anything. So that's also going on. I would not go into great details of the animal-human interface projects because my colleague would be speaking later in the day. But these are very interesting projects that we have launched at the interface. We are working in 11 slaughterhouses, 16 bird sanctuaries, wherein we are trying to see that the humans who work in proximity of animals who are slaughtered and birds that migrate, what are the pathogens that spill over? And we are trying to create a repertoire of those pathogens so that we are actually able to focus ourselves to developing countermeasures for those as well. And through this surveillance system, we also are monitoring the antimicrobial resistance trends in wastewater across 60 different hospitals in India through our VRDL network. And this is again a project in collaboration with one of the institutes of Tata Foundation. And we are trying to see that what are the AMR genes that we see in wastewater and whether they corroborate with the antibiogram that the hospital develops. So how to correlate those patterns, this project will tell us. And another very rich network that we are upscaling and developing. So initially we had 165 VRDLs, which were only working on viruses. But now ICMR has gone ahead and we have actually upgraded 10 of our VRDLs to holistic infectious disease diagnostic laboratories, IRDLs, and just in order to support syndromic surveillance, because in syndromic surveillance, we are not only looking at viruses, but we are looking at other pathogens as well, bacteria, fungi, and parasites. And also these IRDLs would be very important to store relevant clinical material and give it to the industry to make in vitro diagnostic assays for the syndromic surveillance, as I have explained in the previous slides. This is a very rich infrastructure that we were able to accomplish after the COVID-19 pandemic. Our networks within the VRDL system has now 18 BSL-3 labs, 52 NGS sites, and the 3,300 molecular testing labs that were created. We are also trying to redeploy them for this kind of pandemic preparedness programs as well as TB testing, I would say. And very interesting initiative that we took was to also have an indigenous mobile BSL-3 laboratory during the pandemic. This is such a fine, I would say, innovation that you can take this mobile lab anywhere, even in rural settings, in forest fringe areas, station it there and test the samples very quickly where the outbreak is happening. So as far as developing medical countermeasures is concerned, which is the third objective, I already referred to the point that we are working with industry and we have given them the list of priority pathogens to develop medical countermeasures, be it diagnostics, vaccines, as well as monoclonals, which are specific to the needs of our country. So this is a regular interaction that we are doing with the industry. And to aid the industry, we have created biorepositories. We have also created the IRDLs for testing, and we are doing many, many things. Many of our VRDLs are now also getting ISO 17025 certification to become validation laboratories for the industry, because currently, even if they make kits, there is hardly anybody who can validate them. So we are trying to build that end-to-end infrastructure. And the very important point was that when we have to validate a test kit, then there has to be a standard clinical validation protocol, clinical or analytical validation protocol. So ICMR has stepped into that space also because we were requested by the CDSCO to do so. And we have very recently launched 39 standard performance evaluation protocols for various IVD kits that will be that are coming to the Drug Controller General of India. And this is a work in progress, and we will keep on upscaling this work, making more and more protocols to have our IVD sector placed in very strongly and have more and more diagnostic kits available. There are several vaccines and monoclonals which are being developed under the National One Health Mission. There is a vaccine for Kaiser forest disease, totally indigenous vaccine. Nipah monoclonal is under development, and Zika vaccine is also under development. And very recently, we also partnered with the industry to develop H5N1 vaccine, which can be used in humans because we are seeing it as a big threat. There is also work which is carried out by NCDC under the Objective 4 of data integration. As you all know that IHIP portal currently receives data from multiple sources, but now the VRDL and the IRDL data that I showed you, the Virus Research and Diagnostic Lab Network data, is also being religiously fed into the IHIP portal. The NCVBDC also has taken conscious steps to actually give the data to IHIP. And this will also become the center stage data entry portal as far as the National One Health Mission is concerned. Now, when we talk of laboratory strengthening, training, and outbreak investigation, which is also a very important objective of the One Health Mission. So under the National One Health Mission, a very important step has been taken that there is now a national network of biosafety level 3 labs, BSL3 labs. And this network has been mandated that even if like my lab is working in human space, if I have a sample from an outbreak, an animal sample and an environment sample, besides the human sample, it is now my mandate to test all three kinds of samples. So being a national BSL3 network lab, I cannot say that my mandate is not testing samples of animal origin. If I'm a national lab, I have to test all kinds of samples. So this is a pluripotent structure, I would say. And all the labs, whether they are working in the human or the animal space, they have been empowered to actually work on all kinds of specimens. So there are 22 different labs in this network, and they are not only from ICMR, but DBT, CSIR, DAHT, ICAR, and DRDO is also joining this network now. And for this network to make it actually outbreak testing ready, we have a comprehensive list of 40 human and 15 animal pathogens for which they have been trained to test on. They have the kits reagents with them. They have the SOPs, and also a BSL3 assessment tool has been developed to see the readiness of these labs. And these labs and the entire network is subjected to mock drills repeatedly to make them ready for any outbreak that happens in future. So just for representative purpose, these are the lists that the pathogens for which the testing is available at these labs now. And this is the glimpse of the compendium of SOPs for all kinds of testing across human, animal, and environment compartments that have been formulated and being used by these labs. They are available at a common point. Another very important step taken by the Health Ministry is that the Ministry of Health and Family Welfare under the National One Health Mission have notified a national joint outbreak investigation team. So basically, this team comprises not only of officials from NCDC and ICMR, but there are officials from Department of Animal Husbandry, Indian Council of Agricultural Research, Ministry of Environment, Forest and Climate Change, FSSAI, and Jal Shakti Mission. So these, whenever an outbreak of any unknown origin happens, these teams together go to the field and investigate these outbreaks. So that's the beauty of it, that none of the departments is going in silo. Everyone is going together and investigating outbreak 360 degrees. And to assess the readiness of the National Joint Outbreak Response Team, as well as the BSL-3 network, the state governments, and the mission itself, there are regular mock drills that are conducted. And the first mock drill was conducted in Ajmer, Rajasthan in 2024 August. And very recently, we have concluded another mock drill in Madhya Pradesh, wherein in the first one, we simulated an outbreak of avian influenza spilling over to humans. And in this outbreak, very recently, we simulated a situation where a Crimean Congo hemorrhagic fever outbreak happened and spillover was detected from livestock to humans. So these mock drills give us very, very insightful observations in terms of what are the glaring gaps, what are the pieces which we really need to bridge to make this National One Health Mission and NJORT very, very viable. These are the review and advisory committees under the mission. I would not go into the details. They deal with medical countermeasures, with the lab network, the surveillance and data. And these are the metagenomics hubs that have been created under the mission, along with several other departments. NIV Pune is definitely there, but in addition to NIV, now there are several other hubs which are being sensitized to handle the human samples. There have been a series of trainings which we are conducting under the mission to sensitize people, to bring them on board. They relate to biosafety, bacteriology, parasitology, biorepository establishment, immunology, sequencing, and bioinformatics. And there's a long list which includes outbreak investigation, research methodology, etc. And very recently, an initiative has been taken to engage the youth under the National One Health Mission, for which we are conducting hackathons across the country. And you can see that this was very recently released and was on all the social media platforms, where we were encouraging the youth, the students of the country, to participate in the One Health Mission by contributing ideas and innovations. And similarly, this has been also adopted by the Veterinary Council of India. They are also doing similar activities to engage with youth. The whole idea is that government can't sit in every nook and corner of the country. It's the youth, it's the people of the country who really need to be vigilant, who really need to pick up early warning signals of anything unusual happening with the animals, with their neighbors, with the environment, and report it to the public health authorities so that an early intervention can be taken. And we are also reaching out to schools to sensitize the school children about the National One Health Mission and how they can contribute to the mission. So these are all activities. IAPSM is also involved. And this is all from my side. The last point I would like to say that ICMR DHR has recently released I would say, a podcast, which is on One Health, which is available on YouTube, which tells you in detail about the activities of the mission, what we are planning, where we are planning to go. And anybody who's interested can visit the YouTube and look at that One Health podcast. So that's all from my side. Thank you very much for the opportunity.
Thank you so much, Dr. Nivedita Gupta, for giving us an overview of the National One Health Mission, covering all the different aspects very comprehensively. I'm very sure that this will be very useful for us. And as she mentioned, if you want to have the details, we can always refer to NAM's website, ICMR website. Our next speaker, again, we have a distinguished speaker, Director, National Institute of Epidemiology, Chennai, Dr. Manoj Murhekar. And sir is busy, but he has kindly agreed to join us online. He's going to share his experiences on management of leptospirosis outbreak and how this One Health Mission approach was followed. So over to you, Dr. Manoj, please.
Hello, good morning. Can you confirm that my slides are visible and they are in full screen?
Yes, sir. Yes, sir. We can see you and as well as your slides. Please carry on, sir.
And they are in full screen mode, sir. Are they in full screen mode?
Yes, sir. Yes, sir. Please proceed, sir. We
Okay,
can see
thank
your
you.
Indian slide. Yes. Sir.
Okay, thank you very much, sir. And at the outset, I want to thank Professor Umesh Kapil, President of Epidemiology Foundation of India, for inviting me to give this talk. And today I'll be talking about One Health approach in leptospirosis outbreak investigations. I will be covering three important areas. First is I'll talk about why One Health approach is required in while dealing outbreaks of leptospirosis. The secondly, then I'll talk about the status of One Health approach in leptospirosis outbreaks that have been investigated in the past. And the third, I'll talk about how One Health approach is useful during leptospirosis outbreak. So very briefly about leptospirosis, we all know it is a zoonotic disease caused by Leptospira species. And the natural reservoir of Leptospira include more than 160 species of animal. And these animals, they spread the infection mainly through urine, and thereby they contaminate waterways and soil. Humans are incidental hosts, and the clinical spectrum in human range from subclinical infection to mild disease, which presents as fever, headache, and myalgia, to severe disease presenting as jaundice, renal failure, hemorrhages, and meningitis. Leptospirosis outbreaks are frequently reported after heavy rains or heavy floods. And the primary reason for that is that a large proportion of population is exposed to contaminated water, water which is contaminated with Leptospira. This slide basically shows the transmission cycle of Leptospira. And if there are some animals such as rats, mice, and hedgehogs, which are also called as maintenance host. These animals are asymptomatic. They don't get Leptospira infection symptomatic. They are asymptomatic in nature. And these animals spread Leptospira infection to domestic animals, to wild animals, as well as contaminate water and soil. Humans acquire this infection primarily either through direct contact with the infected animal, or or indirectly through contaminated water and soil. And the bacteria enter via breaches in skin or penetrating conjunctiva and mucous membrane. And human-to-human transmission is practically nil in leptospirosis. And since the transmission involves both environment and environmental contamination as well as infection in animals, adopting One Health approach, especially during outbreaks, Leptospira outbreaks, is crucial for effective control. So why One Health approach is necessary or important in Leptospira outbreak? As I mentioned, this transmission involves environmental contamination as well as infection in animals. And One Health approach is useful in several ways. It helps in identifying the source of infection and modes of transmission during an outbreak. One Health approach is key for coordination of cross-sectoral surveillance as well as response, and also instituting guided targeted interventions. And in long term, ensuring preventive and control measures, One Health approach is very key. Coming to the second area in which on which I am going to talk is the status of One Health approach in investigation of leptospirosis outbreak. And for this, what we did was we did a quick systematic review after I got a call from Dr. Kapil that I had to make this presentation. So we searched PubMed database from its inception to October 2025. And we identified basically identified published papers which had a keywords such as leptospira, leptospirosis or Wills disease, and outbreak and epidemic, and which occurred in India. Our eligibility criteria were the publications pertaining to outbreak investigations, and we excluded prevalence studies, reviews, and opinions. And we defined One Health approach as an approach or investigations which covered more than one component, either human, animal, and environmental investigation. So this graph basically shows the distribution of our studies. We identified a total of 43 studies, and of these 32 were excluded either because they were not relevant, 9 were not outbreaks, and one full text was not available. And finally, we included 11 outbreaks in our analysis, and we abstracted data from these 11 publications. And this slide basically shows the distribution or the use of One Health approach in this investigation. And all these 11 outbreaks, since they were in humans, they had human component investigations among human. 4 had investigations among animals to find out the source of infection, whereas only 1 had investigations on water samples or environment to identify the source of infection. Very briefly about the characteristics of the study included in our review. And the first 4 studies talked about the investigation done among animals. Interestingly, these investigations were either done in Andaman, Nicobar Islands or from Chennai. In the first study, they collected samples from several animals, including dogs, rats, and bandicoots. They tested this serum samples as well as urine for MAT as well as dark field microscopy, and they found high positivity in these animal samples. The second investigation was in Andamans during an outbreak of leptospirosis. Here again, they collected a variety of animal samples, blood samples, as well as kidney samples from rat, and they found high MAT positivity, high microscopic and agglutination test positivity in these samples. In the third outbreak, they in fact isolated leptospira from cattle, and and there is no isolation from pigs. Whereas in the last outbreak, again it involved the investigation involved collecting blood samples from the cattle, and high positivity was found during the outbreak of leptospirosis in human. And the only outbreak where environmental investigations were done, only leptospira outbreak where environmental investigation were done was again in Chennai. The outbreak was in a nurse's hostel, and they did a PCR test and water samples, and they found a presence of leptospira in water sample. So this quick review basically indicated that at least the published literature had a very low involvement of One Health approach or different sectors other than health sector in investigation of leptospirosis outbreak. So having talked about this, now let us look into what needs to be done as part of One Health approach while investigating a leptospirosis outbreak. So the typical outbreak scenario for leptospirosis would be that there is a cluster of acute febrile illness with jaundice and myalgia. And as I mentioned earlier, these outbreaks are very common, very frequent following heavy rains and flooding. During flooding, there is increased interaction between humans, carrier animals, and reservoirs. And there are favorable conditions for thriving leptospira in the environment. And these are some of the outbreaks, big leptospirosis outbreak that have been published in India, that have been reported from India following flooding events. First, for example, in Mumbai in 2005, there was a 44 millimeter of rain in 24 hours resulted in 8-fold rise in number of leptospirosis cases compared with previous 4 years. Again, in Orissa in 1999, there was a super cyclone, and following super cyclone, a large outbreak of leptospirosis occurred in several districts, and studies conducted by the Regional Medical Research Center at Port Blair indicated about 20% of the subjects in flooded villages had evidence of leptospirosis infection. The next 2 outbreaks, again large outbreaks, were reported from Kerala. First was in outbreak in 2002 following flood, and again the leptospirosis cases peaked after 7 to 10 days of flood. And the last outbreak was in 2018, where nearly 3,000 suspected cases and 100 deaths due to leptospirosis were reported from the state. So I'm sure you would have looked in, or you would have seen these 10 important steps in investigation of any outbreak. And I'm really not going to go into all these steps, but I'll talk about some important steps, especially which cover about One Health approach. These steps cover talk about confirming or determining the existence of the outbreak, confirming the diagnosis, and generating the hypothesis by doing good descriptive epidemiological study, testing the hypothesis by an analytical study, and then conducting additional investigation among animals as well as environment to find a source or vehicle of transmission. So the first step, as I mentioned, is preparing for field work. And as was mentioned by Dr. Nivedita Gupta, the first important step in outbreak of leptospirosis would be establishing a joint outbreak response team where there are team members from human health side, including clinicians and microbiologists and epidemiologists, from animal health, like such as veterinarians, and environmental health side, such as water or sanitation side, and entomologists. The second important step is confirming diagnosis. And very briefly, I'll talk about the methods for diagnosis. So leptospirosis can be detected by direct or indirect means. And the boxes above basically shows the weeks after the onset of symptoms. Direct diagnosis involves demonstrating the presence of pathogen by either culture or its genomic material through PCR. Dark field microscopy also has been used by some of the labs, but it has very low specificity. Indirect diagnosis involves detecting the immunological response against pathogen. Early IgM response can be detected by rapid diagnostic test or ELISA. The microscopic aggregation test or MAT is a gold standard test for leptospirosis, for diagnosis of leptospirosis. It basically requires a paired sera obtained at least 1 or 2 weeks apart to demonstrate clinically relevant or fourfold or greater rise in antibody titers. And this slide basically talks about the performance of performance of various diagnostic tests for leptospirosis. And as mentioned here, for dark field microscopy, it has very low specificity, and it can be useful in early stages. The commercial ELISAs, the sensitivity and specificity is fairly high, more than 90% sensitivity, and specificity ranges between 88 to 95%. And PCR again has a very high specificity, 90 to 100%. The next important step in investigation is generating hypotheses, and for that one need to define a case, search for additional cases, and collect information about time, place, and person from these cases. And there are several standard definitions for this purpose, several standard case definition, and this is one example of a case definition given by World Health Organization. Here, suspected case is defined as a case presenting with clinical signs or symptoms consistent with leptospirosis that includes abrupt onset of fever, chills, conjunctival suffusion, headache, myalgia, jaundice, cardiac or renal failure, and pulmonary hemorrhage. And often there is a eukaryotic epidemiological context such as flooding or heavy rains. A probable case is a one that is a suspected case, and when there is a presence of Leptospira IgM in one acute sample, whereas a confirmed case is a suspected case and lab confirmation either by MAT or ELISA in terms of seroconversion or fourfold rise in antibody titer, or a positive Leptospira DNA, positive detection of Leptospira DNA by PCR. And based on the descriptive epidemiology, one would then generate an hypothesis, and it can be tested through analytical study. And let me give one example of a leptospirosis outbreak which happened in Middle Andaman in 2022, not 22. Sorry for this typo. There was an outbreak of leptospirosis in Middle Andaman. And during this outbreak, about 114 suspected leptospirosis cases, as per WHO definition, were admitted to Community Health Center Rangat. And about 55 of them were lab confirmed by MAD. So investigators decided to do a case control study to identify the risk factors for leptospirosis. And they did a match case control study. They included lab confirmed cases in this case control study. And for every case, they selected 3 age, sex, and locality match control. And they collected information about the environment in terms of proximity to water bodies, ownership of agricultural land, also collected information about contact with animals in the previous 2 weeks, as well as behavioral and occupational factors. And this slide shows the findings of the conditional logistic regression analysis. And as you can see, they identified several risk factors, including presence of cattle in the house, stream as a main source of drinking water, walking barefoot, and working in water. Although this study indicated that okay, some of the environmental factor or contact with animal as a risk factor, but it doesn't give any direct evidence of infection in animal or environment. And for that, what is really required is we need to conduct additional investigation in animal as well as environment. So what are the objectives for this environmental as well as veterinary investigation? So environmental investigation can help us understand environmental condition favoring survival and spread of leptospira. It also helps assessing the contamination of water, soil, or surfaces by leptospira. On the other hand, veterinary investigations can help us identify potential reservoirs and maintenance hosts such as rats or mice, and also understand animal-human interface which are contributing to the transmission. So how it can be done? Environmental investigations could be done by doing simple field survey, identify and map suspected exposure sites and the cases that have been reported. Collecting samples from water and soil and testing for leptospira by PCR or culture, and also doing environmental assessment. Veterinary component on the other hand can be done by establishing surveillance in animals, examining livestock, dogs and rodents in affected areas, collecting their blood sample, testing for serology or by PCR. So let me now give some of the examples where One Health approach, examples of the outbreak where One Health approach was used. So this is the outbreak of leptospirosis which happened in Kelantan following a flooding event. So Kelantan is is one of the states in northeast of Malaysia. And this graph on the right hand side, leptospirosis basically is endemic in this area. And as you can see in this blue graph, which indicates leptospirosis cases, even before the flood, which happened during 17 December 2014 to 8 January 2015, leptospirosis cases have been reported in that state. But following flood, there have been several fold increase in number of leptospirosis cases reported in the state. In fact, for this spatio-temporal analysis, investigators considered 3 time periods. One is 3 months prior to flood, the 2-week flood period, and 3 months after flood. So they during this about six and a month, they detected about 1,300 leptospirosis cases. And about 30% of the cases were prior to leptospirosis, prior to flooding, and about 60% of the cases were after the flooding. Then they did a spatio-temporal analysis, and the left-hand side graph basically shows the incidence of leptospirosis 3 months before flooding. And as you can see, leptospirosis is endemic in the entire state, but some of the districts, especially the eastern districts, the incidence is very high. But if you see on the right-hand side graph, there are districts where the incidence was lower earlier. We could see a very high incidence post-flooding. Then they also did a hotspots analysis. They basically identified hotspots of leptospirosis, and also plotted the garbage cleanup sites in the area. And as you can see, the leptospirosis hotspots were around around the garbage cleanup sites in this particular state. So what important lesson that was from this outbreak was understanding the spatial distribution and associated factor of leptospirosis can help improve future disease outbreak management following floods. Let me give another example where animal investigations were done to identify the source of infection. So this was the outbreak in Israel, which was because of contaminated water bodies. So this outbreak was notified on 9th of August 2018. And about 15 cases of acute febrile illness consistent with leptospirosis were reported from different hospitals across Israel. And a multidisciplinary outbreak investigation team was constituted. And as I mentioned, this is the first important step while investigating an outbreak. And based on the descriptive AP data, they quickly concluded that there was a common exposure to all these cases. Exposure in terms of recreational activities. All the cases had a history of water rafting or kayaking in some of the water bodies about 3 weeks prior to illness. And these water bodies are heavily attended by public, especially during June and August month. And in Israel, there is routinely all public water bodies are monitored for fecal contamination. So they, as a part of outbreak investigation, they followed these steps in terms of they did active and retrospective as well as prospective surveillance was established. They followed leptospirosis case definition as defined by CDC. And they also did media announcement about outbreak, and individuals meeting case definitions were requested to come for medical care. The public health microbiology response was very important to note. So what they did was they increased the frequency of recreational water testing, water quality testing. It was made 2 to 3 per week. It was 2 to 3 times per week it was made. And they considered fecal coliforms as a surrogate marker for animal derived contamination of water. Because as you know, the fecal coliforms on account of human origin is virtually nil in Israel. They also established microbial threshold for closing water bodies. And if the fecal coliform count is about 10,000, such water bodies were closed. They also started RT-PCR testing for water. And they also deployed microbial source tracking strategy for detecting the fecal contamination source, the source of fecal contamination. So this slide basically shows the results of their investigation. A total of 619 suspected cases were identified, 33 of whom were lab confirmed and 3 were probable. And you can see a point source outbreak or a common source outbreak basically. On the right hand side, you could see that a spatial representation of 7 water bodies which have been implicated for acquisition of leptospirosis. And in fact, all these 33 lab confirmed cases and 3 probable cases had linkage, had exposure to these water bodies. Then this slide basically shows the findings of environmental investigation. And these are the 7 water bodies on the left hand side, 7 water sources. And this is the contamination level, fecal coliforms per 1000 ml at different time points. And so this, you can see that from August onwards, the fecal coliform counts were found to be high in these water bodies. And they also, as I mentioned, they also decided that if the coliform counts is more than 1,000, such water bodies were closed for public, for recreational activities to public. As a part of MST of
Sorry,
initial...
sir, due to time constraint, please conclude, sir.
Yeah, just give me 5 minutes. 4 initial water sources were identified to be heavily contaminated. So they also conducted sero surveys among grazing cattle herds in cattle farms and wild boars, and they also identified the seroprevalence was found to be very high. So the one important lesson from this was the leptospirosis outbreak resulted from contamination of local bodies with urine of infected grazing cattle. I think in the interest of time, I will skip this, the next investigation, but only directly switch to the last step, that is control measures. And the control measures include interventions at source of infection, at transmission route, and at human host. The control measures at source of infection and transmission route are often challenging, and that include the interventions at source of infection include reduction in certain animal reservoirs such as rats, keeping areas around animal habitations clean, separation of animal reservoirs from human habitations, and immunization of dogs and livestock. The intervention and transmission route include wearing protective clothes, especially boots and gloves, and washing and showering after exposure to urine or contaminated soil, washing and cleaning wounds. And the interventions at human host include raising awareness, case management, and antibiotic prophylaxis. So to sum up, leptospirosis transmission involves interaction at human, animal, and environmental interfaces, and therefore One Health approach is critical for effective outbreak response. Environmental and veterinary investigations provide crucial clues about the source as well as reservoir of infection, and they are key for prevention and control strategy. And sustained intersectoral coordination prevents recurrence after flooding and natural disaster. Thank you very much, and thank you.
Thank you, sir. Thank you, sir, for sharing your experiences for management of leptospirosis epidemic involving various experts from health sector, veterinary sector, environment sector. Thank you so much, sir, for joining us. May I request all the speakers, because we are running short of time, so please reduce your presentation from 30 minutes to 25 minutes so that we can have lunch in time. So next I invite Padma awardee, Dr. Pragya Yadav. She is a director of National Institute of One Health, and I am proud to say that she was the recipient of the NAMS Women Scientist Award for the 2024, and she's going to tell us what is the current status of One Health mission in India. Welcome, ma'am. Over to you.
Thank you, sir, for kind introduction. I would like to thank Dr. Umesh, sir, and the team for inviting me and setting this new agenda of One Health, which just started in India, as Dr. Nivedita has explained that how Government of India is giving high priority. For your kind information, we are also organizing a One Health conclave in this month in Bharat Mandapam on 20 and 21st, where we are inviting a larger stakeholders, and we are going to percolate down this program even to the children, as Dr. Nivedita has already informed you. So Dr. Nivedita has talked on the National One Health Mission. I am going to a little bit explain. Many times we think that One Health aspect was not there in India, but that's not the true. And I'm going to give an example of NIFA, as we are talking different disease in this session today. So I'm going to take NIFA as an example. And we all know that in India, we have many laboratories across the country. And during the COVID pandemic, now we have more better and improved infrastructure across the country. But what challenges we faced in the past, what lesson we learned, and how we are on path of a better country, which we call as a Viksit Bharat 2047, and that's the dream for everyone in the country. As it is EFICON, we all know that we are talking in a great detail on the outbreak investigation. And as Dr. Murekar was explaining about that, in any outbreak, and in pandemic, we also learned that if we talk about the pandemic preparedness, we have to always work on anticipations. We have to work in preventive mode, prepare the country, and when it happens, we should be able to detect very quickly, respond it, and then we should able to control such outbreaks. There were many such examples, but we also need to remember the outbreaks is always not natural. They can be also be man-made, and it can be bio warfare and so on. So the country has to prepare better for detecting not only the pathogen, but also the hospital infrastructure and other mode. That's how now we not only protect the human but also animal and our agriculture, so that we can be prepared to deal with any crisis. Pre-COVID pandemic, there were many viral and bacterial pathogens which cause diseases, and there are some of them are having high risk, we call as a high risk group of pathogen. For them, we don't have any treatment, we don't have any vaccine, and if you get infected, people can die. So these diseases, so there is a one example is Nipah, and the second example is Crimean Congo hemorrhagic fever. But 21st century is also called a century of emerging diseases, which has a major example. If we remember, in 2003, we have SARS coronavirus, then we have Ebola, which actually spread in many continents. Then we have recently monkeypox and SARS coronavirus, one of the great example that how an infectious disease can spread from one place to another place, and it's very difficult for everybody to control it. If we talk about these diseases, I just quickly tell why I'm talking about the Nipah disease, because Nipah is a disease which can be presented as encephalitis, it can be presented at ARDS, and it was only initially, it was recorded in Malaysia, presented at AES with the confusion of J, and after long of efforts from CDC, it was detected. And then later on in 2001, it appeared in Bangladesh and also in India. In the first outbreak, when it happened in India, we could not even diagnose. We didn't have the capacity, laboratory, infrastructure that we can diagnose this disease. And it took many years, it took 5 years, and CDC helped us to diagnose Nipah disease. Then we didn't know how this disease is emerged in the country. People kept speculating, and in 2012, when we detected the first time Terpus bad positivity, we came to know that in India also Terpus is the responsible. Similarly, Bangladesh came with the hypothesis that palm sap is the responsible force, which they could never prove. That palm sap, you never get positive if you test it. But because of the close proximity and the cycle of ecology of bat, they could correlate that maybe the bats infected fruits and infected palm sap may be responsible for the Nipah disease. In India, while we are focusing on West Bengal to know more about bats, and in the meantime, the next and bigger outbreak happened in Kerala, and from that 2018, now we are having annual outbreak in Kerala. But the difference, what difference is now, that initially in the first outbreak, we have 68% mortality. In the second outbreak, we have 86% mortality. But now we can detect the index case as soon as the outbreak is there, and it is always stop at maybe just one case or two case. So that is the success of the journey from a bigger outbreak to just one or two sporadic cases, and that show the success story of India's journey of not only the infrastructure but also public health awareness, state response, and so on. So I can keep going on this, but this is the summary that how we have started from a bigger outbreak, and we can detect very quickly with our infrastructure. If I summarize the outbreak of Siliguri, some of members who are sitting in this audience may be aware when this outbreak happened, so nobody could understand how the disease is spread from hospital. So many doctors, nurses died, and it took long time. People were thinking maybe food, maybe fish, maybe vegetables, and there was no clue what kind of epidemiology must be there with such a deadly outbreak where so many people are dying. And then it spread from one hospital to another hospital. The second outbreak happened in 2007, where 5 people died, and there was no clue again that how these people died, what must be reason how they spread. It was so quick that whoever came in a close contact for even very short time, they got infected and they died. And it's that time we had testing reagents available in NIV, and we could test and declare this a Nipah outbreak. In the meantime, we started working to understand. We set up a surveillance in not only the West Bengal, but in the Northeast, in a different bat species, because CDC came in picture. They said maybe bats are responsible, because it was a hypothesis in Malaysia proven that bats, pigs, and human, these are the relation where they could actually trace it back to the Nipah disease. In India, we focus on 4 main species of Pteropus, and after doing a long studies, finally we end up in finding Pteropus bat positivity in West Bengal. And these studies, as you must be knowing, the field studies are very tough to do, especially if you're working on high risk pathogen, which is very deadly and can cause 100% of mortality. So it really requires a lot of training, understanding, and how to do these works. Then we continue this setup to know more, and we started focusing on Assam, West Bengal, and we could reveal that in many areas the bats were positive. And that is this kind of a signature that yes, theropods bat are positive in India, and that they could lead to, and we know that bats are present everywhere. You go to any corner of Delhi, UP, Bihar, bats are everywhere because they are living with us for I don't know how many thousands of years with us, and they are adopted with us. And these actually, but the same time when we tested the pig samples across these areas, we never found any pig positivity or seropositivity. So it means that cycle is not here with us. So bats is there, human is getting positive, but we are also not getting any some relation between and we don't have that cycle of palm saps hypothesis. So the next outbreak come in a bigger form in 2018 in Kerala, where 22 people get infected, 18 people die in that outbreak. And that outbreak actually awake India's entire community, especially medical community, and all the epidemiologists, that what must be happening wrong. And we that time we didn't have even protocols how to do burial, how to dispose the bodies, or how to take care of infected people. We didn't have SOPs, we didn't have PP, and it was a very, very chaotic situation in India in 2018. And we are talking after the Ebola outbreak, which happened even far before in 2015-16. We did preparedness, we did training, but we were still not ready. And this is the story which I'm telling you because before COVID, what happened? How much we were not prepared to handle a COVID pandemic. And after this outbreak, we have to really act fast with the state, central government, and we found out what is missing in the system. We didn't have POC, we didn't have early detection system, we didn't have training of the healthcare workers, we were not ready with PP, and we were not ready for so many things, and there were many challenges to handle such high risk group of pathogen outbreak. The first thing which we learned with the Nipah outbreak, that we have to work together. And I think that was the first proof that One Health exists in our country. And it was a first time exercise. All the stakeholders came together. They worked together with the state centers, different division of the government. Okay, let's resolve this problem. There is a problem, how to do it. So I think that was a very good beginning in a high risk group of pathogen as part of One Health in India, which we can say. Then we started very systematic survey, and during this outbreak, when we did a bat survey, there was a 25% bat positivity, which is so far highest positivity in the world, where you can see in the bats. Then we started systematic survey of bats, and every year we not only got the seropositivity, but we got positivity in different specimen of bats that include liver, spleen, it could be rectal swab, throat swab. And we could see that whenever the outbreak happened, if you go to that area, do the survey, bats are definitely positive. And we could correlate that they have exposure, the people are living around the area where the bees, bats are positive. Then there was a many hypotheses. Maybe it could be airborne, it could be human behavior, it could be other host. And we are still working on. If you say that, do you have answer? I will say no, we are still working on it. But for sure, we know that bats are positively constant in Kerala and in the southern India and so on. So we decided to do a country-wide survey where we can see if bats are there. It could not be only West Bengal or Assam, or it could be just Kerala. Let's look at beyond. So we also did many other study to find out the hypothesis, does this palm sap hypothesis work or not? And we are doing this study. It's a 2 year, and we have no such evidence or proof that palm theory is actually working in Kerala. The next was to find out if the other part of the country is having positivity in Nipah, and we set up a country-wide survey. We did this survey 5 years across the country, and we found out that many states, not only they are positive for antibodies in bats, but they're also positive for viral RNA. And it could be the state, maybe you have a state like Bihar, UP, and so on. So there are many states which you can see in the map they are positive for viral RNA, they are positive for IgG antibodies. So yes, there is a risk and it can spill over, can happen to any time, anywhere, and we don't know when. So these are the some of the study that we did a genomic sequencing study across these bad positive samples, different outbreak, and we find out that in India we have two different genotypes circulating. One which we get in UP, Bihar, West Bengal, they are very close to the Bangladesh. But in the southern India, especially in Kerala, we are getting a different kind of genotype, which we call as a I genotype. And this genotype is circulating in southern part of India. Moreover, after doing all, you can ask what we achieve. So now we have indigenously make point of care test. We have PCR, LAMP, and these are all commercialized. They are approved by DCGI. Now we are working. So initially in 2018, when the first outbreak happened in Kerala, we went ahead and we collaborated with Council and we imported the MABs. And MABs was given so for 3 individuals who are got sick, and they are all living, but not in a very good clinical condition, but they survive. That's what the positive outcome you can say. But that was not sufficient. How much we can borrow? So we initiated indigenous Nipah monoclonals project, which we are working with the JIDUS, and we also working with the THSTI, and now we have some very, very good preclinical data which prove that they are going to be very effective. So now we have monoclonals antibody. We are also collaborating with, already we are working with the CEPI and also with the Genova to make a vaccine in India, indigenous vaccine, and that project is also moving. So we will have these in hand very soon. So this is a One Health approach for Nipah disease, which we utilize that included detection, integrations, community awareness, vaccine surveillance, case study, healthcare system, and so on. But lot to learn more. We have to do more efforts. And the state government of Kerala is continuously doing, and the success is that we can detect that every time the case happen, index case is detected. So that's a very good success story. But now we come to the COVID-19 response. We all know that how COVID is spread across the world, and India was one of the country who suffered the most. You all know very much about the COVID. But what I want to emphasize here in today, while we are talking, that when we talk about such pandemic, these are the one of the example that how India can be better ready when the next pandemic come. And that's this one entire One Health concept came in the picture because India wants to be pandemic ready. And we all know that how it impacted our livelihood, our human health, government security, and also most importantly, our economic infrastructure. During the COVID pandemic, we have seen that India expanded its laboratory. We have very good COVID app. We have could deploy the vaccine across the country. We could not only support our country, but we could also spare to other countries. We initiated INSACOG genome surveillance for SARS coronavirus and many digital and AI platform which was initiated. But the best part of out of all these was to have lot of startups in the country. We have now many industries who are interested to do work with academia, produce the kits indigenously, and I think that is the best outcome of these entire exercise. There is another very good output of these challenges that we have multiple platform available in India. You talk about the vaccine, you talk about diagnostic, you talk about antivirus, and they are ready to work with you, ready to deploy, ready to deliver very quickly within the country. But while we were dealing with this pandemic, do you think the other viruses are bacteria? They were sleeping? No. There were multiple outbreaks kept going in different part of the country and including India that include Crimean Congo hemorrhagic fever. There was outbreak on Nipah during the pandemic, and there was Kerala was doing double action, one with the COVID and second was with the Nipah. Then there was a Zika outbreak. We detected Zika in 16 states during the pandemic, which was, we always thought just a random disease, sporadic cases are happening. So Zika has spread across the country now. It is the presence has shown. We detected first avian influenza case in human in Haryana, and then we have detected more cases this year and last year. So now more cases are detected for avian influenza. Monkeypox outbreak, which is initiated in 2022, and it is spread across a different sector. India is also reported many cases of monkeypox, including the latest clade 1B, which was supposed to be very highly pathogenic. Ebola was also spread in many countries. Fortunately, we didn't have any Ebola cases so far in India, but that is another very deadly disease. And due to COVID initiative, now we have Ebola vaccines available, which was done ring vaccination recently in outbreak. So these kind of efforts, this kind of initiative really help to save a lot of life, not only to the well economic country, but also in the poor countries where there was no access in the past. These efforts also lead to prepared better. So when now in 2022, when the monkeypox cases started, India was ready within 2 weeks with 34 laboratory across the country. We can detect it, we can declare the clads, and we can also have the guideline for treatment and what to do to be done. So very quickly, all these efforts come in the picture. Not only that, we have now we did validation with the mini monkeypox kit, and now we have 3 commercial kits available for test, which you can buy in India market, and you don't have to go abroad to bring the kits or keep waiting for it. So I think there is a lot of efforts. At the same time, also there is a lot of efforts on monkeypox vaccine. Serum is making one, and we are working with them. And there are some they also imported from other countries to produce in the countries. The same time, the kit validation, which was one of the very good initiative in the COVID, help us to have the indigenous kit available in the market. Government of India, ICMR, DCGI, together they initiated, it's called MedTech Mitra, a platform which actually helping and promoting industry academia collaboration with the help of DCGI to fast bringing different technologies of medical requirement, either it's diagnostic kit or anything, and you can go to register to the portal, you can quickly adopt, and you can take all possible help. If we talk about a pandemic, there were 3 very key things which we emerged: that gaps in One Health knowledge, need for enhanced surveillance, and the linkage between different sectors, which Dr. Nivedita has actually addressed very nicely. But there's another aspect to it, to how you detect biothreat while you are taking care of biosecurity, biosafety, and how much we are aware of the risk which we are handling. Then integrated capacity, and how we are going to do the biosurveillance, and how together these information can be used for intelligence and biosurveillance. So these were some of the other factors which continue to be addressed. And there were in the past, there were many guideline, document, individual efforts was done by DBT, ICMR, but we also learned that lesson. But in the same country, we cannot have different policies. So now we have merged all the guidelines from the DBT, ICMA, so we can have one particular guideline which can be utilized either for making a containment facility or for how to do valid certification of any laboratory, validation of laboratory, and we should keep speaking the same language so it's easy for everyone to follow. Then there was also awareness program which was initiated across the country, how to inform people that what is a risk group, how the risk group look like, what we call as it is group 1, 2, 3, 4, and how we can handle in biocontainment facility. To understand this, the level of biocontainment was defined by a DBT guideline, and that was endorsed by ICMA's effort together, bringing all the experts. Now we have a guideline how to make a biocontainment facility, and especially for BSL-3, which was missing for a very long time. We mostly follow Canadian other guidelines, and these guidelines actually help us to guide how to make the facility. So if simply I say that BSL-1 laboratory is like your PJ laboratory, where you have very simple structure, you use very simple PP, including gloves and mask. The second is BSL-2 facility, biosafety level 2 facility, where you have biosafety cabinet, you have a closed facility, you have biohazard signs, and you have access to autoclave. The BSL-3 level laboratories are those where you have unidirectional flow with the negative pressure, and you utilize a very specific kind of clothing, which we call as a personal protective equipment, and all the waste which generate in the facility goes to a very dedicated autoclave for all the waste treatment. When we call about BSL-4, which is a high level of containment facility where you can handle all kind of highest pathogen, you can do preclinical study, you can do all animal work, and they can help you in handling, safe handling of any pathogen that should not leak, release, or go to community and create any outbreak out of these campuses. We work on 4 main components: personal, air, solid material, water, waste. And to manage, there is an engineering component theory, and we manage that's how. So there are 4 main component to it: the personal protective equipment, workplace practices, administrative controls, engineering controls, and all together we manage such kind of laboratory with the training and protocols. Fundamentals of a biorisk management system is also being taught to these laboratory who work under this. And we also now try to make everybody understand that how to manage these biorisk by training, by understanding the requirement. And we have seen that how biobanking is a problem for India. Transportation of samples is a problem, and all guidelines were issued during the COVID pandemic to accessing everybody. With this, now we have multiple layer of the laboratories, and we also came up with the mobile BSL-3 facility during the COVID pandemic, which can be deployed in any outbreak in any place. And we are coming with the 4 zonal NIV-like structure, which will have all the facility BSL-3, and they will be working on these outbreaks. We also coming with the nation one Institute of One Health, which Dr. Nivedita has described in Nagpur, which will actually anchoring with different ministry. A number of training on biosafety, biosecurity, how to work in these laboratories are organized. We are constantly working with these biosafety laboratory network, and multiple trainings are going every month so that we have a better trained system. We also created a framework by including many experts with the discussing Dr. Nivedita. We had team, and we have now made a tool which can evaluate each laboratory when the sample arrive to the reporting is sent. And this included, we put a quantitative marking on each, how you perform. So it's like we all know about NABL accreditation system, but this has become more easier, handy tool for, especially for the biocontainment, because we didn't have any tool for these kind of laboratory. Vishani Abhyas, which we did last year, where we have multi-stakeholder. This was the first India's national mock drill, where all the stakeholders work together for the mock drill. So that really surprised to me as well. This is the first mock drill when we did last time, and that included many stakeholders from state to central, and we brought all the stakeholder of One Health Mission to work together, and we become friends. Now I have more friends than ever in the past, because I work with 60 ministry. So that leverage give you to work in a bigger infrastructure setting. We have back-end team who set up this outbreak. Then we have front-end team, which is led by always NCDC, and they come and do the outbreak. And then there is an independent observer team, which monitor and give scoring what we did good, what we did bad. And based on that, what lesson we learned, there was a debriefing, and this briefing was taken to highest level, and we did corrective actions as well. So every time when we do this exercise, I think we are going to better prepare for the future, not only outbreak, but also for the pandemic. With this, all the efforts, I would like to thank all of you for listening. And I think the good food smell is coming to everyone. But lunch is little away from this, and I would like to thank Professor Ajay Sood sir, Dr. Rajiv Bahl, for giving me this opportunity to work with the National One Health Mission, and NCDC Director and DGHS, and my colleague Dr. Nivita, with whom I work from many years, and I think we learn so much while working in this field, and it's a very interesting field, and that inspires us every day to do more in this field and for this country. And I would like to thank all the stakeholders who work with us tirelessly. It is a new field, it's require a lot of dedication and everybody putting to it. And with this, I would like to thank once again the organizing team for bringing this One Health topic as a priority during this EFICON. Thank you.
Thank you, madam. I think all of us as Indian feel proud about the role which the ICMR played during COVID vaccine. And Dr. Pragya Yadav has a very important role in the isolation of the virus and also for the lab development. So thank you so much. And I think all of us have seen the movie also. It is available on the YouTube. And especially the young epidemiologist sitting at the back, if you can go through the book of Dr. Balram Bhargava, the former DG ICMR. That book is available on Amazon. It is very, I think, very interesting book written in the form of a story covering all the concepts of EPICON. Thank you so much for being with us. We really appreciate. Next, we have another important session because we have been discussing about the integration of health with veterinary environment. So next two speakers, we are from the National Engineering and Environmental Engineering Research Institute in Nagpur, which is a very famous institution. And the first speaker, we have Dr. Krishnamurthy Kanan. Sir is Chief Scientific Advisor, Scientific Officer, and he's heading the Department of Toxicology. And he is going to discuss how we can integrate animal surveillance with the health sector under one health mission. Over to you, sir. And kindly stick to the time, sir. We are short of time. Kindly try to finish in 25 minutes.
I will try.
Thank you.
Good morning, everyone. So, since the topic which the organizers have suggested, it is animal, but I'm working on environmental aspect, so environmental epidemiology. So, I don't have to go into introduction on epidemiology because all are learned audience over here. So, I'll straight away go to my talk. So, environment, like air, water, soil. So, majorly, we are focusing on air environment. So, air environment, you can see, like there are pollutants, that is transport sector, industrial sector, domestic, and as well as power generation. So, its health impacts are majorly from CO, carbon monoxide, CO2, SO2, and the particulate matter. So, particulate matter is more important. So, which cause, apart from the contaminants, other like biological origins like aerosols, bioaerosols also. So which my colleague Dr. Sadanand will be elaborating on. So there are other than CO, CO2 gases, there are metals like lead, cadmium, hydrogen sulfide gas, and ozone and particulate matter. So this causes some of the diseases. So how much we intake pollutants in the form of inhalation. So an average adult resting person inhales about 7 to 8 liters of air per minute, or almost 11.5 cubic meter per day. And among other pollutants, PM is a mixture of tiny solid particles, dust, smoke, soot, salt, soil, mineral, pollens, and even aerosols. The health effects of polluted air, actually it aggravates cardiovascular and respiratory illnesses, stress, heart and lungs that must function, and it even damages cells in the respiratory system. So air pollution is a killer, we all know that, and it is having a accelerated of aging in lungs, then loss of lung capacity and decreased lung function, then development of diseases such as asthma, bronchitis, emphysema, and possibly cancer. So it also shortened the lifespan, that is year of life with disability, YLD and YLLs. So most susceptible persons to ill effects of air pollution are the pregnant women, outdoor workers, and older adults and elderly, and even children under the age 14, and also the athletes who exercise vigorously outdoors. So I'm going to talk about the case studies which we have done on environmental health. So 3 case studies I'm going to talk. So one is the coal dust particle and its damage of health impact as well as agricultural damage. So this study we conducted in a city just near to Nagpur. So around 130 kilometers from Nagpur towards Chandrapur, there is city called Vani. So where the coal particles are, coal have been collected by the private vendors. So they stack it on the roads. So you can see these are the stacks. So the blue parts are the coal stacked on the roads side. Okay, and this is the monitoring we have done for the Vani city. So we did 5 areas of monitoring, including that coal area, the road, which goes to city, from the rural to city. So we kept 5 monitoring stations. So from coal stockyard, where it is being loaded onto the train. And here in the city near here, there is a stock of coal that is being loaded onto the trucks by road transport. And these have been transported. So because of this, the dust emerged, which caused immense health effect. And this is the control area where Arni city, which is around 50-60 kilometers away from Bani. So it is also in same district, Yavatmal. So there was a PIL raised in NGT. Because of this coal dust, there are health effects caused by, witnessed by many of the village population. So they made a PIL. So accordingly, NGT has directed MPCB, Maharashtra Pollution Control Board, to conduct a study. So MPCB has contacted us. So we have done this study. And you can see the ambient air quality in Vani and Arni. So you can see Masjid area where it is the peak of PM 10. And in Arni, you can see it's almost within the limit prescribed by CPCB. So Vani particulate matter has raised beyond the CPCB level. Then PM concentration in Vani during October 16, May to October 16, we found there is an increasing trend of both PM10 and 2.5. And similarly, the Arni also, it is showing, but it is not higher level. And similarly, there were metal contents we have measured. So we measured about arsenic, cadmium, cobalt, chromium, copper, nickel, lead, and zinc. So they were within the limit. In Bani, we got arsenic as higher level. So epidemiological study we carried out, extracting secondary health data and as well as primary health survey. We found like asthma and bronchitis and skin disease and respiratory disorder. So we are having significantly higher compared to Arni. Then we did a case control study. So we brought samples from different areas. Like this is secondary health data we collected from the hospital and primary health centers. And this is primary health survey as well as biomonitoring also we did. So in biomonitoring, we found there is a level of increase in CC16. I'll come to. So CC16 is a 16 kDa protein secreted by Clara cells in the tracheobronchial tree. And it has been proposed to play an important protective role in the respiratory tract against oxidative and inflammatory response. And decrease in CC16 is an indicator for lung function decline. And similarly, we found the case control study where adjusted and unadjusted with the confounders, we found 10.89 was the control and exposed was 6.99. So which shows there is a tremendous impact. And similarly, we found we collected blood and urine samples. We studied arsenic level was higher in Vani, arsenic and chromium, whereas in Arni, the metals were within their limit. The average PM10 2.5 in Vani were significantly higher. That was significantly P less than 0.05. And heavy metal analysis of PM10 2.5 samples indicated that chromium, manganese levels were higher than the US EPA reference because we don't have reference level of metals in urine. So we have to refer to US EPA. As my earlier speaker, Dr. Pragya Madam has mentioned, there are many things we are lacking. So we have to follow with the Western world only. Then arsenic was detected at the coal stock yard site of Vani, and all the investigated areas were showing, and it was above the NAQS acceptable limit. And hospital admission data also indicated higher occurrence of asthma and respiratory diseases in Vani compared to Arni. And this odds ratio when we did, so Vani was higher than the Arni, and the average CCM16, CCL16 was lower in Vani as compared to Arni participants. And that indicates higher frequency of potential lung dysfunction in Vani as compared to Arni. And in summary, this study revealed inferior air quality, complaints of respiratory and other illnesses, higher urinary range of certain heavy metals and lower serum level of CCl60 in bunny as compared to Arni. And these findings show an increase in health hazard at bunny compared to Arni. So this was one study. In case study 2, where we studied diesel particulate matter and its impact on health. So where we conducted a survey in 4 mine areas which are located near Nagpur. So among mine 1, mine 2, mine 3, mine 4. So we studied air monitoring, and this is the dust from the areas which are the areas dust are generated. And PM, we have monitored PM 10, 2.5, and we did also OCEC, means organic carbon and elemental carbon. So this ratio, elemental carbon, is if it is higher than organic carbon, so that indicates the vehicular pollution is more, means it's combustion. And similarly, these are the some of the areas we monitored PM10 2.5, and ratio of PM10 2.5 also indicates the combustion and non-combustion source. And we did health studies collecting secondary health data, primary and biomonitoring. So also hospital data we collected from 2014 to 2018. So it shows there are diseases apart from cancer, diabetes, hypertension, ischemic heart disease and COPD were prevalent. So similarly, increasing trends in diseases of mines, you can see from 2014 to 18, you can see the increasing trend. And similarly, risk of respiratory illness due to PM exposure also in mines, different mines, like the odds ratio of unadjusted and adjusted ratios you can see are showing above 1. Means it is showing that there is a risk in this population due to pollution. And similarly, we when we did air monitoring using the different tools, so we used Citus cascade impactor with high flow sampler pump from SKC, and the flow rate was 91 ppm, and 4-stage respiration, that is PM 2.5 to PM 0.5 and 0.25. So even we are now we are going to work on PM particulate matter 1. So actually, as per the CPCB norms, they have stipulation of up to PM 2.5 only. So they don't have any rules for less than PM 2.5. So however, we observe there are health impacts due to the less than PM 2.5 particles. So keeping in mind, so we have proposed one project on PM1 and its health impact. So to ANRC, and we have been awarded, like we are likely to get the project on which we will be working on PM1. And in another project where we are working with working on One Health aspect. So like we are going to work on environmental aspect. Then there is one institute in Nagpur, MAFSU, that is Maharashtra Fisheries Animal Fisheries University. They are working on animal aspects, and there is one hospital called SIMS. So they are working on human aspect. So we are working together. So which again, Dr. Sadanand will be elaborating on little bit on that aspect. And these are the stages, like stages A, B, C, D. So which are showing PM less than 2.5, PM less than 1, and PM less than 0.5, and PM less than 0.25. So these are ultrafine particles. So they may enter into the bloodstream and causes diseases. And we've profiled GCMS profile of these particles, and we found there is one nitropyrene and PAHs. So as all you know, PAHs, polyacyclic aromatic hydrocarbons, are carcinogenic. So it is IARC established class 2 carcinogen. So when we get exposure to this carcinogen, means nitropyrene, so we are likely to develop a disease, even cancer. So similarly, we found there is quadrupole GCMS showing mines, different mines, and their level of compounds and different compounds, like which are the nitropyrin, benzoypyrin, PAHs, the higher molecular weight PAHs and low molecular weight PAHs. So here we found measure of higher molecular weight PAHs in the air samples. And similarly, when we did HPLC for showing one aminopyrin, means one nitropyrin when we get exposed. So in our body, it is converted, metabolized to one aminopyrin. So one aminopyrin is not that toxic compared to one nitropyrin. So it is a product, but we wanted to see what is happening in the population when exposed to PAHs. So apart from the markers, so we did exposure effect markers, like effect markers, 8-hydroxy-deoxyguanosine. So this is a DNA damage marker. So we found there are impacts, higher level of 8-OSDG in all the 4 mines except mine 2. We found level lower. And similarly, we did correlation of diesel particulate matter exposure with the health status. So we found, taking into the consideration of the age and the exposure and BMI, then level of aminopyrin and the DNA marker 8-hydroxy-deoxyguanosine. So you can see the p-values. BMI shows higher level, and similarly age also shows a significant level, less than 0.001, and aminopyrin was not that significant, whereas 8-hydroxyguanosine effect biomarker shows significant impact, and behavioral aspects also not that much. And similarly, effect of one nitropyrin and one aminopyrin. So we compared both with nitropyrin and aminopyrin level, and we found the p-values in mines 0.05, less than 0.05, one mine is there, and second, 3 mines showing significance value out of 4. And similarly, effect of one nitropyrin with one hydroxy-deoxyguanosine, means exposure biomarker with effect biomarker. We found there is only one nitropyrin in mine 1. That too, it is not significant. All are not significant. And scatter plot showing relationship between hydroxydeoxyguanosine and aminopyrin levels at overall site. So you can see the scatter plot showing different values. And in summary, this ratio signifies the amount of dust emanating from combustion activity. So as I mentioned earlier, organic carbon versus elemental carbon, and PM 2.5 versus PM 10. So we will be able to find out whether it is the source of just dust particle or the combustion source. So because of the burning of the particles, coal or some other particles. So it is based on the finding dust here. It is based on the combustion. So we found there is a significant impact due to the burning of particles, coal. And also air quality assessment at various locations of 4 mines, we found PM level 378 to 362 microgram per cubic meter at time of its viewpoint locations of one mine. And similarly, the prescribed limit of new mines where it is 250 microgram per cubic meter. So it is exceeding the prescribed limit. So all 3 locations of mine 3 showed more than 2-fold increase in average PM10 concentration than the standard limit. And in the health risk assessment, we did prevalent diseases such as COPD, cancer, ISD, as I mentioned earlier. So it was increasing in trend, and the 3 mines also showing the higher occurrence of COPD. Then cross-sectional primary questionnaire survey data underlined the prevalence of respiratory illnesses around 13%, and eye irritation around 19%, and skin problem of around 6.4% among the workers of mines. And it was observed from the study that one nitropyrin level, a prominent combustion product of diesel, was found to be significantly higher across all the sites. So indicating the highest concentration in mine 3 and having a risk. And there are variability also. The half-life and excretion of 1-aminopyrin in the urine was reported to be of maximum of 5.5 hours. So still there is a risk of like non-cancer risk is there in the mines which are located near Nagpur site. So in case 3, where we studied in Vizag, there was a styrene leak incident occurred. So there we surveyed the leak incident and its impact on environment and as well as human population. So environment, air, water, soil, as well as the human population. So we did air monitoring study. So we studied around in May 10 the tank M6 where the styrene was stacked. So it was styrene level was 12.8 ppm and at ground level M6 tank 7.3 and inside the LG plant, that is the where the styrene was stored, that plant had 4.9. So in residential area near that areas 1.2, 2.3 and 2.7 each. And similarly, MSDS data shows the Section 8 exposure controls and personal protection ingredients with work exposure controls parameters. US also shows time-weighted average value of styrene is 20 ppm. So whereas we got higher level of styrene on day 1, and when we surveyed it for 15 days, so after 15 days the level was subsided. And water quality monitoring, we did water quality of area or surrounding areas of 5-kilometer area, where we collected water samples from dugwell, borewell, as well as surface water. So there was one lake located near that LG plant, Mahadri Gadda. So where it is, the level was 1.74 milligram per liter in water samples, and lake near to lake 3.76, and dugwell it was 0.73. So US EPA level was 0.1. It should be less than 0.1, but some of the one area it is increasing. In lake Magadri Gadda it was increasing. And similarly, other surrounding area. So where we did 5-kilometer area, 5-kilometer radius, we collected all the water samples. We analyzed and found in the initial period, May, there was a higher level of styrene, and in October, so the levels were normal. And similarly, you can see the trends like BIS limit and ICP detection limit for metals. So there are different metals, arsenic, chromium, iron, and all were within the limit. And in styrene found to be present in dugwells, reservoirs which are near raw water sources for drinking purpose, except the lake water, that is Navarakota River, that is used for fishing. And the spillage sample, however, did not reveal presence of styrene. This may be attributed to the phenomena of styrene transforming into polymerization products, and due to increase in temperature resulting in exothermic reaction, and storage tank got prior to the incident. And samples from dugwells near the Apparao village, which is affected, Venkatapuram is the village which was affected most, where around 20 people died on this same day of incident. That was that has happened on 7th May 2020. So soil quality also we did, and we found, this is the coordinates showing the different areas. And similarly, we found styrene levels ranging from 318 to 5,950 milligram per kg in soils. So, and the soil remediation criteria is 0.01 mg per kg for agricultural use and 50 mg per kg for industrial. So, at industrial site also we found October 2020. So, all the levels were within the limit, 50 as per the industrial limit. And saline findings also, styrene was found to be in the soil samples at all the areas collected and analyzed, and concentration of styrene exceeding the CCME guideline of value of 0.1 gram per kg for agricultural soil and 50 mg per kg for industrial soil respectively. And they are found to be quite above the toxicity causing concentration of 9 mg per kg. And the styrene levels in lake sediments could not be carried out since the team had to travel on emergency situation. The styrene level and other contaminants in sediments could not be carried out and ascertained for its water quality standard levels. And we did primary health survey immediately after the incident. We found there are 5-10 villages surrounded by the industry. Among them, there are like symptoms like neurological, headache, skin, breathing problem, eye irritation. So these are the perceptive given by the participants, primary health survey. And health survey of one village, Nandamuri Nagar, there also prevalence of these complaints were major. And the health study at SCBC colony of that surrounding area also higher. And this is the most affected village, Venkatapuram, which is just surrounded by the campus of the industry, compound wall of the industry. So where we had observed highest level of problems. And similarly, we found the secondary health data from the hospital data. We found Venkatapuram was the highest, having the throat irritation, eye irritation, vomiting, abdominal pain, and skin diseases. And in summary, like soil quality was analyzed in soil samples immediately after the gas leak on 8th to 14th May, and after 5 months, that is 28th to 30th October, where we found natural attenuation was occurred. Then the styrene concentrations were very high, that is 109 to 5,950 milligram per kg. And styrene could be detected in only 2 samples at very low concentrations during October. And the health data, as I mentioned, the Venkatapuram village is the most affected one. And this is the WHO standard limit for the PM particulate matters, PM10, ozone, nitrous oxides. So in order to achieve this, we need to have prevention and control of air pollution. So such as containment, preventing atmospheric release of toxic substances by enclosure, ventilation, and air cleaning, and as well as replacement, substitution of fossil fuels and firewood by alternate wind, solar and tidal power, dilution, then legislations, having stricter legislations, and international actions. And I acknowledge my team, Dr. Saravana Devi, Chief Scientist, Dr. Amit Bafna, Senior Principal Scientist, Dr. Anirban Midday, Principal Scientist, Dr. K.V. George, again, is heading Air Pollution Control Division, is again Chief Scientist, and Dr. Asha Lalwani, she's a statistician, and Dr. Atul Daivile. So he has carried out the study in Bani, and now he is in NIH USA. And Dr. Dinesh Vadikar and Ozer Farooq, they were the project associates. So I acknowledge with the thank for the audience. Patience hearing.
Thank you, sir. Thank
Yeah.
you so much for sharing your experiences on various markers for surveillance of the environment. We are grateful to you. So there is another eminent speaker from the same institution, Dr. Sadanand, who is going to discuss again in little bit more detail about the markers for the environment surveillance and how it can be useful to the health professional. So please, sir. So kindly stick to the time, sir. My request.
So, good afternoon. So we don't have much of the data, but just I will go through quickly about the how the environmental surveillance is important. So this is our CSR laboratory, National Environmental Engineering Research Institute, where we do diverse research in environmental research, biodiversity research, and health aspects and the toxicological studies. So in this study, okay, I will go through quickly. I will talk about the global challenges in disease monitoring, then identifying the gaps in surveillance and diagnostics, and the present at the One Health framework for response, and the recommended practical steps. And I will give some of the our ongoing projects related to One Health. So as we know, the global challenges in 21st century, we are facing biodiversity loss because of the extinction crisis. This leads to several problems such as climate change, the global warming, and then the human threats, and the pandemics, and some non-communicable diseases. Then some of the emerging zoonotic diseases coming from wildlife also, what we experienced in during the COVID-19. And then AMR, which is very big challenge and very silent pandemic. And by 2050, it is projected to around 10 million deaths will be happening by 2050. So these are the various challenges in 21st century. This is just again to give brief how the biodiversity loss results into several complications. So how to link these global challenges through One Health? So One Health is a integrated and unified approach, as we know, that recognizing the health of humans, animals, and environment, which we shared, which are interconnected. So it cannot be simply working in the isolation. So it is the holistic approaches linking all this human, animal, and environmental health. And it is now recognized by World Health Organization of World Health Organization, Animal Health, FAO, WHO, and Office International Epizootics also, and UNEP. So this is very critical for preventing future pandemics and also the AMR spread. So this is the same showing how this One Health is very important in addressing the or mitigating various pandemics. So as we know, leptospira is a very highly infectious zoonotic disease, and it transmits through contact with contaminated water and soil containing the urine of infected animals like rodents mostly, and even also this can be transmitted through livestock and other dogs or cats also. And this is how the risk factors are involved for the transmission of leptospirosis. And this shows in the environment the sample, the leptospira, how it is spread through the environment through the contaminated urine. That's why there is a very it is very important to study the or monitoring the environmental prevalence. And this is again to show the urban leptospirosis, how it is transmitted through the rodents and also the animals, especially during the floods. There's contaminated urine is spread, and it is transmitted to humans. So again, this is very important. So when we study the epidemiology, the in India mostly it is underreported, especially if you talk about the leptospirosis and the hotspots in coastal and flood-prone areas. They are less studied, and this is seasonal peaks during monsoon and flooding, and recent local outbreaks and advisories highlight the diagnostics delays, mostly because of the surveillance problem. So these are the different surveillance system, and these are the different surveillance gaps which are very important to address. And then these are different diagnostics which we know: microscopic, bacteriological, immunological, molecular diagnostics. And most of the tests are available, but it requires very specific molecular biology laboratories or some definitive and rare practical routine diagnosis is challenging. So when we monitor the environment, because this disease, especially the leptospira, spreads through the contaminated soil and water. So there is a very important issue to address of environmental monitoring. So eDNA, environmental DNA, which is like it's a new tool for improving our ability to effectively measure biodiversity in environmental samples. So this eDNA analysis, the leftover the shaded DNA of organisms or even the microbes in the environment, and it has been very valuable in the recent past. And it is very cost-effective tool for monitoring the biodiversity as well as the microbes in the aquatic system as well as in the terrestrial system. So there are other tools are the like artificial intelligence, where they use acoustic monitoring, camera trapping for monitoring the organisms, and that is especially for the mammals. And the other tools like tools for biotic and abiotic factors such as um, plant monitoring and other things. And also there are some remote sensing technologies. So I will talk about the eDNA. So this is a emerging technology where we collect the samples, soil samples or water samples, and even the sediments can be collected. And then we isolate the DNA, environmental DNA, which contains all the microbes. And then we'll go for this is the layout where we collect the samples, and then the DNA is extracted and it can be used for metagenomic sequencing. So this helps in identifying various, not only particular limited DCS, but it can also detect the cryptic species which are unknown to us, and also explore new some novel species which are likely to um, uh, which are likely to miss likely to come in the in near future. So when I talk about our ongoing projects, we have some AMR surveillance, as Dr. Krishnamurthy sir has already mentioned. We have in One Health approach, we have AMR surveillance in animal farming, and then some of the work has been done by our student, where they have monitored the air samples, and using air sampling we identified many pathogenic bacteria and the fungus from the dumping yards. And also now we are working on how indoor pollution, especially the bacteria from the bacteria and bacteria and fungi from the indoor air quality affecting the health of our human population. And also there is another project what we are studying is in the tiger reserve. We are working on addressing the uh, uh, antimicrobial resistance and also the disease prevalence. So this is what I explained. So they have monitored these. These are the landfill sites where they have collected the samples, air samples, and they isolated various pathogenic bacteria. So in tiger reserve, we have collected various environmental samples, and we are using environmental DNA and metagenomics approach to address to detect the various pathogens using sequencing. And then we are also looking at how the dishes are exchanging from livestock to wild animals and vice versa. And at the same time, we are also addressing, looking at the transmission of antimicrobial resistance from the livestock to domestic wild animals, and also the vice versa. So these are different steps to develop One Health surveillance systems. And these are the ethical principles guiding the One Health approach. And operational One Health actions, joint outbreak investigations with wild animal health and environmental teams should be done. Shared data platform and routine cross-sectional meetings. Then targeted rodent control and livestock vaccination wherever feasible. And then community engagement on safe water, sanitation, and protective gear. And these are the different surveillance strengthening programmatic steps. And these are the data, different nowadays data and digital tools are available to monitor the disease health. And these are the key recommendations, such as strengthening the regional molecular and serology labs network, implement the standardized case definition plus reporting, integrate animal and environmental surveillance, which is very important. The pre-monsoon clinician training and community awareness, regular screening of environmental places such as water sources, common playground for disease screening to mitigate the risk of disease emergence and the spread of the disease. Then validate and deploy rapid test with QA system, and then build digital dashboards with One Health data layers, and conduct joint One Health outbreak simulations periodically. And to embracing the complexity and uncertainty is the best done together in a multidisciplinary collaboration that include biologists, ecologists, and environmental scientists, fitting as One Health, which aims to serve as a unifying approach. Thank you.
Thank you, Dr. Sadanan sir, for discussing some of the modern technology for environment surveillance like eDNA and remote sensing and artificial intelligence. I'm sure that this will be useful for all of us. Since, sir, we have 3 more speakers before lunch, so my request would be that if you kindly agree to finish your presentation in 15 to 17 minutes, then we'll be able to have lunch. So next, I invite Dr. George M. Verghese. Sir is professor and head of Department of Infectious Disease at famous CMC Vellore. And sir is going to share his experiences of more than 25 years for scrub typhus, how this One Health approach was followed. Thank you, sir. Over to you, sir.
Thank you, sir, for your kind words. I can hear the stomach grumbling in all of you, and we are terribly behind the schedule. So what I am going to do is to summarize in 10 minutes. Although the chairperson has given us 15 minutes, I'll summarize it even shorter. Many of you may be aware of scrub typhus as a zoonotic disease, which is of public health importance, and therefore the One Health approach, the importance of it and how are we going to do it is what I would summarize. I will talk about 3 key aspects and just give you the learnings very briefly. First of all, the evolving epidemiology and expanding frontiers of the disease over the past couple of decades, advances in diagnosis and treatment, and also final part of it will be on prevention, control, and One Health roadmap ahead. In the year 2000, there was a group of patients with acute febrile illness with multiple organ involvement, most of them with hepatitis and transaminitis, and some of them with frank jaundice, some with pneumonitis to ARDS, aseptic meningitis, where we looked for common etiologies such as leptospirosis, falciparum malaria, dengue, typhoid, all were negative. And we knew that we were dealing with something, which we normally don't come across or look for. And we did a prospective evaluation after IRB approval of these patients who come with acute febrile illness and multiple organ involvement. And we, at that time, the rickets cell infection was on our top of our differential diagnosis when we considered this disease. And we had no tests available in India except for wheel Felix test, which is a protease antigen cross-reacting with this, and therefore it's neither sensitive nor specific. So what we did is the prospective samples, which were collected from about 45 patient samples, were sent to a WHO reference laboratory in Marseille, in France, where extensive evaluation was done for all the rickettsial agents and other etiologies, and we found that this was caused by Orientia sutsugamushi, one of the rickettsial pathogens in 28 out of 45 patient samples. So that we reported it in Annals of New York Academy of Sciences as an outbreak. We didn't know, we thought it is probably an outbreak, and this is in early 2000s. Then we started seeing increasing number of cases every year. We thought maybe we are looking for it. Subsequently, we got ELISA tests to make a diagnosis. And we thought maybe we have a diagnostic test, we are looking for it, and we are finding more. Till when we started looking at the community seroprevalence for past infection, initially small sample size in Vellore district, we looked at the seroprevalence of IgG in the community, asymptomatic individuals, and we found that the seroprevalence was around 4%. Close to about 10 years later, we repeated on a larger sample in the community, again, asymptomatic individuals. We saw that the seroprevalence had significantly increased to about 31%. And you can see the cutoff which we had used and all that. Eventually, we now know that this was a re-emerging infection with huge burden. Several years ago, at least 5 to 10 years ago, when we tried to estimate the burden, it was something like 1 million cases resulting in 150,000 deaths. In the geographic region called Sutsugamushi Triangle, you can see the darker areas in South and Southeast Asia, where India is also part of it, where the disease has been prevalent. And the mortality in severe disease was around 24%. And subsequently, very recent study which was published in NEJM, you can see this was a population-based cohort study encompassing 37 villages in Tamil Nadu, and among about 7,600 odd households were followed up for 2 years, looking for initial IgG seroprevalence, which was again more than 40%, symptomatic infection occurring in about 6.6 per 1,000 person years, and hospitalization about 30% of acute febrile illnesses, and the case fatality, you can see 1.5%, about 22% of them had clinical cases requiring hospitalization. Now, when you extrapolate this data from India alone, roughly more than 5 million cases occur annually, resulting in about 85%, 85,000 deaths. This is assuming our population 60 to 65% are in the rural areas. So the burden of the disease is much bigger than what we initially thought. That itself was huge. As you know, this is a mite-borne zoonotic disease transmitted by the trombiclid mite, what is called as chiggers, which is the larval stage of the mite, most commonly Leptotrombidium. In nature, the cycle is between the vector and the rodents, and humans are incidentally infected. The chigger takes a blood meal. The rest of the life of the mite, it feeds on vegetation. So the humans, when they get bitten by the insect, as you know, the larval stage of the mite is not even visible to the naked eye, and it's painless bite. people don't even recognize that they've been bitten. This infection, indefinitely continues between the rodents and the vector, which is the mite, and it is there in nature for indefinite period of time. And the burden, as I said, there's huge under recognition. I won't go into the details. And the picture, what you see is the normal habitat of the mite, the terrain between living area and the forest. And this is, if you really take, this is more than 60-70% of India. That is where the disease is much more common. And slowly you start seeing it in even in city parks and suburban region. And you also are probably aware of the seasonality, the relationship between the cooler period during the year. The chiga require cool and humid climate, and therefore monsoon and peri-monsoon time. And this has importance. The cyclical nature every year between July and February in different parts of the country. And as you know, it causes, majority of them may have milder disease, but there is a proportion who go on to develop severe disease with multi-organ dysfunction and eschar, which is, if you carefully search for the eschar, which is at the site of the bite, is a potential diagnostic clue, which may be present in about 60% of cases if you carefully search for it. And initial studies, what we looked at was the epidemiological aspects. Who is developing the disease, what are the risk factors for developing the disease, what are the predictors of mortality, how can you reduce the disease and the severity, and also try to understand the disease, both the cytokine storm which occurs in severe disease and the genetic predisposition. Subsequently, we did the genotype of the organism circulating in different parts of the country. Shimla and districts around in the north, Shillong and districts around in northeast, and Vellore and districts around in the south. You can see the variability in the genotype of the organism which is circulating. When you look at the severe disease, at least 1/3 go on to develop multi-organ dysfunction once they start manifesting disease and come to the hospital, and many of them go on to develop very severe disease and poor outcome. So initially what we try to do is increase awareness and early detection. As I said, we started off with an ELISA. Then we started, trying to improve the PCR. Earlier, it was a nested PCR which was used, standardizing a conventional PCR, which again became the standard diagnostic methodology, and subsequently real-time PCR with very simple tweaking of the techniques. When you look at, this particular study where we looked at the performance of molecular and serological diagnostic tests, looking at the PCR, if you see the PCR sensitivity, the conventional PCR has not been very high. It is modest, but the specificity is close to 100%. That used to be the reality. What we did was very simple technique. If you take the EDTA blood, spin it, and take the buffy coat and use that for extracting the DNA and do the PCR, you can improve the sensitivity quite a lot, and also working on some of the point of care diagnostic test. So after working on more than 10 years, we asked ourselves this question, did we manage to make any significant impact in the community or in the disease? When we started with 15% mortality in patients who get admitted in the early 2000s, by 2015, the mortality had come down to about 5 to 7%. Mortality had halved. Very simple intervention, increased awareness, and early detection. With whatever diagnostic test which you can promote, which was will wind up in a few minutes. Then our important study on treatment. This again was published in NEJM a few years ago, looking at severe scrub typhus. How can you improve the outcome? The mortality was around 24% in those who get admitted with severe disease. We looked at the monotherapy of either doxycycline or azithromycin versus a combination. We found that the combination therapy improved clinical outcome. Published in NEJM. Just to come down to the prevention and the One Health aspect, as all of us were talking about, the zoonotic disease, which is we hear the scrub typhus, an integrated approach involving human, animal, and environmental health is crucial. And how can we make the prevention more effective? Our initial strategy of early diagnosis and increased awareness did make a significant impact. And the next primary prevention interventions, including vector control, rodent control, environmental maintenance, and vaccination are the way to go. I won't go into the details of vector control and also the rodent control. These are two key important aspects, and the environmental management. We are on our way to work on a potential vaccine, and of course improved surveillance along with what ICMR, NCDC, and the government system is doing. We are trying to improve the surveillance as well. So to sum up, I hope I managed to impress upon you that the scrub typhus is a disease of public health significance, and it does have significant morbidity and mortality. Early diagnosis and increased awareness can improve the outcome, and also we have much better treatment modalities. Prevention and surveillance needs One Health approach with control measures of vectors, rodents, and environment, as well as surveillance and outbreak management to reduce the burden of disease. Thank you very much for your patient listening.
Thank you, sir. Thank you, Dr. Varghese, for sticking to the time. And we are really grateful to you. In fact, all of us are now made aware that scrub typhus is also important public health issue. Thank you, sir. Next speaker, we have Dr. Arup Debroy. Is he here? Dr. Arup Debroy? Please. Sir is project director in Jones Snow Institute, and he's going to discuss the role of human vaccination and how this can help us in One Health approach. Sir, please, time is 25 minutes. 15 to 20 minutes.
I'll finish before that, sir.
Thank you.
Thank you so much. So actually, I'm standing in for Dr. Pawan. He was supposed to make this presentation. Dr. Pawan is the Additional Commissioner, Ministry of Health and Family Welfare. Presently, he's traveling with the Health Minister, so he asked me, and just for less than 48 hours back. And you know, I come from a different world. I come from a world of field implementation, downstream work. So I was sitting at the back, soaking in the atmosphere. Took me back to my medical college days, 20 years back. completed my MD community medicine. Thank you for inviting me, accepting me as a substitute for Dr. Pawan. So don't worry about the time. I have only 9 slides because when I went through the agenda, which Professor Kapil sir shared with me, uh, I attended this workshop just more for learning than but I took this opportunity to share with you few of the strong points from the world I come from. So I come from the world of immunization. So I'll be talking on few of those things which are the foundational pillars of the immunization program of the country. Okay, so if you had asked me to summarize everything in one slide, I would have summarized in this slide. So this is where when you talk of integrated approach to disease prevention, I think in first presentation, Dr. Nivedita was talking of silos. I think that's one thing we have to break those silos if you're talking of One Health. I'm taking it forward. I was just listening to her in the morning. I think if you had made a word cloud of the words she used, silos would have been in big words. Okay, so that's the first thing that I'm looking forward to when you're talking of integrated disease approach to disease prevention. Now, when you talk of vaccination as a tool, so in One Health, I think the animal vaccination is your primary tool. But the human vaccination can also be your secondary tool for that. And since I come from that world, I'll blow it up in the next slides. So when I talk about human vaccination, as I said, I work with the ministry, although I'm not a government official. So in the government program, we have something called a universal immunization program. That's the India's official government program. As I said, I'll speak a few things about the scope and the scale of this program. So as you can see, the annual cohort is 2.57 crore infants. Just to put things in context, India adds 1 Sri Lanka every year. So there's a scale of the program, and to reach that population, we have almost close to 1.4 crore sessions that happens across the country. So when I said India adds 1 Sri Lanka every year, but you have to keep in mind the area of India is, I think, more than 30 times of Sri Lanka. So that's the other challenge of it. And trust me, I've worked in places where the sun rises first in India and in places where the sun sets last in India. And it's not an easy job for those vaccinators to travel with these vaccines to the remotest locations of this country to vaccinate those 2.57 crore infants. Right now in the program, we have 11 vaccines which protect against the 12 vaccine preventable diseases. And you know, this whole, the foundation of this program is based on a cold chain system. And this is the same cold chain system through which the COVID-19 vaccination campaign was rolled out. So we have now close to more than, in fact, 30,000 cold chain points across the country. And you know, right now, as I speak, from any cold chain point of this country, the furthest session site is less than 1 hour travel time. So that's the criteria government of India's kept, that no vaccine should travel more than 1 hour from the last cold chain point. So that's how extensive the network is. Just a brief glimpse of how things evolved over the years. I think as students of community medicine, we know about the program. It started way back in 85 with few vaccines. And right now we have, as I said, 11 vaccines to protect against 12 vaccine preventable diseases. Last 10 years have been good for the program. 6 new vaccines got added to the program, and these are all expensive vaccines. And which were available in the private sector before it rolled out in the program. But after it rolled out, I think the coverage has improved so many times. I'll be talking on just 3 aspects of the program, which I'd like to highlight to this audience, besides so many other things about this UIP. So when I said that we have 30,000 cold chain points, we vaccinate that many children. So how is that managed? How is the cold chain system managed? How the vaccine logistics managed? So if you look at the breakups of it, so we have absolutely a national, state level stores where the vaccines are kept. And finally, the last mile, that's where the majority of the cold chain depots are. And now everything, so sitting right here, Dr. Pawan can see how many vaccines of every antigen is present in each one of those 30,000 cold chain points sitting right here. That's how it is connected. And where even the temperature of each of those cold chain equipments. So right here, so not only him, the state immunization officer, the district immunization officer, everybody down the line can see and monitor the system. Trust me, it's one of the best in the world. The other thing, this is an offshoot of the COVID. So we all know we have vaccinated ourselves in COVID vaccination campaign. So UWIN is an offshoot of it. I think in One Health now you also have ZooWin. So UWIN is the world's largest name-based registry of immunization program. It's the world's largest. And where, for the first time, a child may get a first dose in maybe in a northeastern state, can get a second dose in southern state without losing data. So previously it was used to be the immunization card, which the parents may have carried along or may not. So now, right now we have a digital system which captures all of this and which is accessible across the country. I'm not going in details. These are all available in government of India websites. And so we have talked about vaccine logistic management. I have talked about the capture of the data. So the other thing which is equally important for a vaccination program is the safety of it. And happy to share with all of you that we also have the adverse event following immunization surveillance system in place, which is a very robust system that we have. And that also is digitized. We have something called a safe bag. So through which all records, everything can be uploaded. So that's how comprehensive this system is. So these are the 3 slides that I had on the robustness of the universal immunization program. So I'll continue with just few more slides where I'd like to connect now your human vaccination with One Health and disease prevention. So I could gather these things together in the last 2 days, how vaccination can play a pivotal role in One Health approach. So among all of this, I would just like to focus on one aspect of it, which is really emerging big time right now as we talk. That's on antimicrobial resistance. So 2 examples. We already have PCV, the pneumococcal conjugate vaccine in the program, and which has been scaled up, I think 2021 when it scaled up across the country. So now for the last 4 years, PCV vaccine is available in the program across the country. The other is, which is in the pipeline, maybe in very near future, it will be launched in the program, the typhoid conjugate vaccine. Just 2 examples, which actually has contributed, the vaccination, human vaccination has contributed to reducing antimicrobial resistance. My last slide. So when we reduce the burden of human disease through vaccination, I think that's as a ripple effect, a trade-off is there. So the other side, we have the complex intersectoral issues working that define One Health approach, and that frees up those space and the time for working on those aspects. The next part is that, as I mentioned about that in a program, we have robust surveillance, we have robust vaccine management, supply chain, we have public health campaigns, and all of these are essential even for your One Health approach. The third thing is that, which I wanted to discuss with, share with all of you, is that when we lower disease prevalence in the human population, it means there's an effect on the environmental health also, is less shedding of pathogens in the environment. And finally, human vaccination is actually a critical shield in the whole process of the triangle that we talked about since morning about animal health, human health, and environmental health. I think I've kept well within my time. We have still 6 minutes. Thank you so much. Thank you.
Thank you. Thank you so much, sir. And thank you for saving our time. And you deserve one more serving of dessert, sir, in the lunch. Thank you. Thank you so much. And especially you made us aware that India is now the largest manufacturer of a vaccine. And we have all the vaccine which you require are manufactured in India. And he also highlighted that India is one of the few countries which is using modern IT technology for logistic management as well as adverse nature. So many of the things were not known to us. Thank you so much, sir. Very interesting presentation. And now the last but not the least, very another important session we have from the Joint Secretary, Indian Veterinary Association, Dr. Sharbani. Are you here? Okay, thank you so much, madam. And she's going to discuss about the zoonotic intervention. Since morning, we have been hearing about health intervention, environmental intervention, and now this session is going to be very interesting, how this zoonotic intervention can help us in having One Health approach. Over to you, ma'am. Thank you so much.
Okay. Very good morning, one and all present here. The respectaries, my colleagues, and dear students. I'm Dr. Shravani Sabandika, scientist from the Department of Biotechnology, AIMS, New Delhi. Actually, 3 days before, I was asked by the General Secretary of Indian Veterinary Association, Dr. Bimal, to present on his behalf, as I am the Joint Secretary of Indian Veterinary Association. So, yes, leptospirosis, since morning we have been listening to it. So of course, it doesn't need much introduction as it is introduced by the speakers who spoke before me. But it is an important zoonotic disease caused by leptospira, which is a spirochete bacteria. It's not only the Leptospira interrogans species that is pathogenic to human and animals. What is more important is in leptospirosis, it has got more than 200 serologic variants. Now, the transmission, as talked by other speakers, it happens through direct contact with urine of infected animals or urine contaminated environment, like the urine contaminated water bodies. Yes, human to human transmission also occurs, but that is rare. Coming to clinical manifestations, it has got wide clinical manifestations, that is from mild illness to serious fatal disease. Initially, it manifests like flu-like symptoms, but within course of time, in certain individuals, it also leads to organ failure, like the renal failure or the liver failure, depending upon the site of predilection of the pathogen. So why this leptospirosis is a zoonotic disease of serious consequences? It is because of three reasons. First is the host range, that is, it has got a wide host range that includes the reservoir host as well as the incidental host. You all know that the reservoir host are the rodents and the incidental hosts are the livestock and human. But it is not restricted to livestock, human, but it also includes some of the wild animals. And as I said, it has got more than 100 species, out of which like around 46 species are pathogenic in nature. And in some literature says around other species, around 70 are also pathogenic. And each species has many serogroups and serowards. I'll be talking about it in my later slides. And the third important reason why it has serious consequences is its symptoms mimics other diseases, and also sometimes it is asymptomatic. Now, the ones where it is asymptomatic, it goes underdiagnosed, and where it shows symptoms also, as it mimics other diseases like influenza, dengue, and other viral hemorrhagic diseases, it becomes a challenge for correct diagnosis of the disease. So that therefore making correct diagnosis at an onset is important to prevent severity, primarily in outbreaks. So although it has been spoken till now about the One Health approach of leptospirosis, I will be mainly talking about the immediate actions that needs to be taken during a leptospirosis outbreak. So how does this leptospirosis outbreak happen? It happens mainly when there is a heavy rainfall, as you see here. There is heavy rainfall or flood, and there is poor sanitation and hygiene. And in both of the cases, what happens is there is rise in the rodent population. And we know that the rodents are the reservoir host for this leptospirosis. So what happens as there is increase in the reservoir host, then the leptospira in the urine of the rodents contaminates the water and soil, and subsequently the infection also is carried to the carrier animals like the livestock, dogs, and also to humans. So it is a cyclic process of transmission where more the number of carrier animals, again the infection spreads through the urine, contaminating water bodies or either directly infecting the animals and humans. So the high risk groups are here the agriculture workers, the veterinarians, and especially the sewer workers, drainage workers, and the rural residents of the area where there is the outbreak. Coming to the diversity in leptospiral species and its servers, a recent study has found that taking the samples from dog and human, it was found there were 46 pathogenic species, including clade P1 and P2, of which there were hundreds of serovers, which had the range of ability to infect and cause disease in several animal hosts. So this study listed the Leptospira species on the basis of sequence polymorphism of one gene, that is the IFB1 gene. This IFB1 gene is a gene that codes for putative adhesin, that is the fibronectin binding protein family. And this particular gene has shown to be congruent with the genomic species classification of pathogenic Leptospira strains. So as per the analysis of sequence polymorphism of IFB1 species, IFB1 gene, the study has identified eight pathogenic Leptospira that has 46 different Leptospira serogroups and each having several serovers. The 8 pathogenic Leptospira species were the Leptospira interrogans, Leptospira kirchnerii, Leptospira nogochi, Leptospira borgopeternerseni, Leptospira alexandri, Leptospira myotensi, Leptospira willi, and Leptospira santha rosei. So you can appreciate here the picture shows the phylogenetic relationship between the different Leptospira serovers. So this Leptospira species is enormously diverse. And this is the list of Leptospira species showing different serogroups and serostrains that are enlisted in the table. That is a very long table, which I have tried to capture in pieces that I have shown here. So coming to the epidemiological survey of leptospirosis, it has been found that globally over 1 million cases and 60,000 deaths is caused by leptospirosis annually in the tropical regions of the world. And India, being one of the tropical region, is the hotspot for this disease, where over 4,750 cases and 83 deaths per year have been reported. And all these cases are driven by factors like heavy rainfall, flooding, and the disease is particular to monsoon season, and it is also endemic in India in the coastal belt like Kerala, Maharashtra, Gujarat, and Tamil Nadu. So coming to the genetic interventions, as like other zoonotic diseases, here also we have 5 steps. First is the outbreak response measures. Then we need to break the transmission cycle, and then environmental measures, human behavior and protection measures, and then the social awareness. So, as I said, the transmission of the pathogen Leptospira, it is in a cyclic process impacting the reservoir host, involving the reservoir host, impacting the livestock, dogs, and also the humans. So whenever there is an outbreak for humans, those who are affected, it has to be taken care by the doctors, and for the maintenance or control of the animals that are infected, the care has to be taken by the veterinarians. And to know about the serovers that are present in the particular outbreak, the role of the scientist is most important. And now, last but not the least, the environmentalist is also plays an important role here by decluttering the affected areas and cleaning the water bodies, etc. So this is known as a One Health approach. Because it doesn't only include one sector, but it involves multi-sectors. So if there is involvement of multi-sectors, then the efforts should also come from all these sectors to combat the leptospirosis. So during outbreak response measures, what needs to be done is the medical fraternity should take care of rapid identification and treatment of suspected cases, while the environmentalist should educate the community on safe cleanup after floods. and especially for examining the water bodies and soils that are contaminated by the different servers, and sending the samples for detection of servers. And next, the veterinary doctors should go for the rodent control and animal reservoir management. Now, as I was talking of breaking the transmission cycle, the first step is to go for animal reservoir management, and next environmental controls, and then human behavior change. Because at every step, unless the cycle is broken, it is difficult to control leptospirosis. Not only the animal infected excreta, but also the environmental infected water bodies, and also by controlling the human behavior, taking protective measures, leptospirosis can be controlled and managed. So in animal reservoir management, the first step needs to taken by the veterinarians is to isolate the infected animals by examination of clinical symptoms and multifaceted tests like point of care test and serological test, and then treating the infected animals by antibiotics and supplements, and then vaccinating the uninfected animals using local serover strains in those affected areas, and also giving the booster dose in endemic areas, and going for prophylaxis for suspected animals. Now, in environmental measure, what should be looked for is the environmentalist should have check on the safe water bodies, that the water that the local people are drinking are safe, by examining the water bodies for contamination and sending the particular samples for examination. And there should be safe disposal of animal excreta so that it doesn't spreads into the environment. And the epidemiological study should be done, because we know in many cases it goes underdiagnosed, because there are many asymptomatic patients also there, and there are number of serowards also. So particularly during an outbreak, it has to be taken retrospectively, that in terms of developing projects, that what all serowards were contained in that particular outbreak, so that the antigenicity, the immunogenicity, and the virulence of each type of serovirus can be taken into account, and we can be prepared for the next epidemic. Now, last is the rodent control, that is sealing the entry points, decluttering, and maintaining outdoor debris is of utmost importance. In human behavior, we need to take protective measures like the personals who are at high risk, they should wear boots, gloves, and the public should avoid swimming in contaminated water. And prophylaxis using doxycycline for workers during high risk season, especially the ones who are working with the sewage system. And the diagnosis of asymptomatic patients by testing twice, once by the rapid screening test and then again by the serological test. Now, why it is important, I will tell in the next slide. Periodic assessment of bacterial load in infected patients and monitoring to prevent severity. The social awareness should be done through health education and campaigns to aware the risk personals for environmental cleanliness, to rodent control, and also test outbreaks, cleaning of water bodies, and animal waste disposal. So, as I said before, the management of leptospirosis is a big challenge, especially for the low-income populations living in tropical regions, both in urban as well as in rural environments. And second, the clinical manifestation of the disease because of its non-specific and variable symptoms resembling other diseases also. And sometimes as it evolves to life-threatening complications causing renal and respiratory failure and shock, it necessitates the intensive care also. So the management challenge which is of utmost importance, is the confirmation of leptospirosis through biological diagnosis. As I said, we need multifaceted laboratory test. So that is why to have a knowledge of the lactospirosis epidemiology is highly needed, which is lacking, like compiling information regarding reservoir and incidental hosts involved, leptospira strains circulating, outbreak in seasonal and geographical patterns, and endemic regions. So I said diagnosis is a major challenge because of the complex pathogenicity of leptospirosis. That is, here we see first in the acute period, the leptospira is present in the blood, and after the acute phase starts the immune phase when it comes into the urine, and it is during the immune phase that you can like detect the antibodies, and the leptospira from this immune phase then comes, it gets shed in the urine, and if there is recovery, if there is downfall of shedding in the urine, and if it predilects in some organ causing organ failure, then there is a persistent shedding, and then the antibody, there is rise in IgG titer. So because of this complexity, we need to have multifaceted tests, like during the phase when it is in blood, we can go for a blood culture or PCR. And if it is during the immune phase, then we can go for a rapid test. If the rapid test is negative, then also we can go for we should be going for repeat tests through the MAT. Rapid tests are the lateral flow devices that are the point to care test done through the IgM antibody ELISA and lateral flow devices. And if it is coming negative, then also after some days, the test should be conducted through MAT, that is microscopic agglutination test. And the titer should be monitored from time to time to know whether the patient is in convalescent state or it is still in the sickness stage. So the diagnostic approaches, here it is an overview. We all know there are two types of diagnostics, direct through antigen and indirect through antibody based. And technique wise, these are molecular, serological, culture, whole genome sequencing, and serotyping of cultured isolates. Molecular aspects, as I said, there are certain surface antigens that are present in certain serogroups. For that, we can do molecular test. And among the serogroups, there are particular antigens that are present that are confined to a serovar. So for serovars and serogroups, the molecular testing is very important. And in serological testing, we can go for IgM or IgG based ELISA. And for culture, it is a very difficult procedure because it needs leptospira culturing needs a complex media which is yet not standardized for all the serogroups. And next, whole genome sequencing is very important because whenever there is an outbreak, if we go for whole genome sequencing, we can have an idea about the antigenicity of the particular antigens present in the particular serovars. And serotyping of cultured isolates, this is also very important. That is we take the specimen, the sample from the outbreak area where there is an outbreak, and then we culture it, and then we go for serotyping. So the rapid testing of infection is done through the nucleic acid amplification test, that is through that needs to be done in the nearby primary centers, and it can also be done through lateral flow assays. NAT is a direct test that detects the antigen, while lateral flow assays are the serological test which can be done during the immune phase of the disease. So although there are many diagnostic techniques available, yet the diagnostic method is not standardized for all kinds of serovars. That is, we have to conduct a multifaceted test through a flow chart. Then only we can come into a conclusion that yes, there is confirmation of leptospirosis. For this reason, for development of new diagnostics, there is the role of scientists. And recently, one such this multiplex PCR-based system is available, known as BioFire Global Fever Panel. through which we can detect the leptospiral DNA. Yeah, there are also limitations of diagnostic tests. That is why I said there is need for multifaceted tests, because we cannot depend on a single test. So the Indian Veterinary Association has got wide initiatives in active initiatives in advocacy with government and other activities at a rural level, and also it promotes the alternative herbal medicine in veterinary science. So in short, the role of veterinarian in combating leptospirosis is very much important, as they are one of the key pillars in implementing One Health approach in surveillance, prevalence, and management of outbreaks. And thus, the collaboration is highly essential. Their collaboration needs to be with the human sector and also with the environmental sector to fight against leptospirosis. Thank you.
Thank you so much for telling us about the various veterinary intervention and the challenges. Thank you, madam. With this, we have finished the pre-lunch session. Any other speaker who is left? Okay, thank you so much. I thank all the distinguished speakers for sticking to the time. And we have finished this pre-lunch session on time, right, 1:15. And now I think we can break for the lunch, which is just outside this hall on the left side. And after lunch, please come to this auditorium at 2 o'clock. So thank you so much for being patient. Thank you so much.
Hey.
यहाँ से ले लो, यहाँ से ले लो, ऐसे बोला।
भैया कौन सा कर रहा था ये वाला? चेक कर रहा हूँ, चेक नहीं करो ये अभी भी आवाज चेक नहीं करो। हाँ check check hello yes
Check, hello. All are please requested to settle down. We'll start with the sessions now.
Again, welcome back to the session. In this session, the time for the speaker has been restricted to 10 minutes. So we please follow the time and maybe from 10 to 12, 13 minutes, but not more than that. Okay, so thank you so much for patient hearing in the first session. And in this session, basically, we are going to see the case studies and some practical experience of innovation for One Health program. We have different aims and they have the Center for Community Medicine and Family Medicine. And some of the senior faculty members and her department from these institutions are going to share their experiences on how the innovation in One Health program they have undertaken and what are the difficulties and the challenges they faced and what were the good points, successful learning points. So first we start with a video presentation which we have received from AIMS Rishikesh. Dr. Mahinder Singh could not come, but he has sent his video clip presentation, how some innovations were done in the Regional Center for One Health at AIMS Rishikesh. So please display that video.
Role of the second. Basically, One Health, as we know, is a concept which has emerged recently, and it has come from World Health Organization. And actually, it was felt after COVID that many diseases whose origin we really don't know. And for COVID also, we didn't know from which animal it had come into human race. And the whole control of the disease actually depends on the control of the secondary host and then we have so many other diseases which are prevalent in India. For example, we had malaria, which was a vector-borne disease. We had Kala-Azar, which was a vector disease. We have so many other vector-borne diseases, and along with that, we have brucellosis, which is carried by cattle. We have leptospira, which is again connected with cattle, and we have been getting cases of leptospirosis. And I would attribute to our very energetic team, which is led by Dr. Priyanka, who has been collecting samples from these various populations. especially the Gujar population near Haridwar. Those are the people where, there was some mystery fever which was going on and nobody knew what it was. It was just being reported in the press. And it was found that it was actually leptospirosis. So many of them came positive for leptospirosis. And since we are very close to water bodies, it is something which is common. And when the weather is quite humid here, some months. But there is a National One Health Institute which is there in Nagpur. Dr. Pragya is director there, and it's an ICMR institute. ICMR is working on One Health. And so try to collaborate with all those people. Look at the things which they are doing, new things which they are doing. Make a visit to that place. See what all they have. I congratulate you for continuing the project so well. And we would show full support for you and the department also, both the departments. Thank you very much. Jai Hind.
A very good afternoon. So this was a brief message from my Honorable Director Ma'am, Professor Meenu Singh, and my team. Dr. Mahendra is a nodal person along with Department of Microbiology and other departments which are collaborating as a regional center for One Health at AIIMS Rishikesh. The specific population which we are working upon is right now is a one Gujar that is acting as a transitional population, a link between the zoonotic disease and a human population. So we have to understand who is the actual link, and these are the people who keep on traveling from jungles to jungles, and with them the zoonotic disease keep on transmitting. So that is all from my institution. My apologies, Dr. Mahendra couldn't be over here because of some academic assignment, so I'm representing AIIMS Rishikesh over here. Thank you, everybody. Thank you.
Thank you so much. Now I invite Dr. K. Madan Gopal. Sir is Senior Advisor in National Health System Resource Center. And before that, sir has the experience of working in Niti Yog. So I think he's going to share all his experience at NHRC as well as the Niti Yog on another very important issue of bio safety and bio warfare and how this can be related with the One Health. Over to you, sir. Thank you so much.
Thank you, sir. So you would be all wondering what I would be talking about, because since morning you have been listening about leptospirosis, One Health. I'm not going to talk about that. I would be talking something which is very different, One Health, biosecurity and warfare, because this is the thing which at the apex level and the other level, the think tanks and other, they're thinking how we are better prepared if a warfare, biological weapon is used as a warfare. 20th century was the conventional warfare, but in the 21st century, it would be the microbes would be acting as a warfare. So we have to see that how we are prepared and how One Health can be contributing to that. You see that one of the interesting thing, our journey begins by defining the shared challenge which we are having. As I mentioned that the 21st century, most silent weapons are invisible microbes. We have seen how the progression has happened from SARS virus in 2003 to H5N1 in 2024. And the number increases, the number of virus increases. Man, animal, plants, and the environment interaction is going to increase with the international travel and the travel which we all would be undertaking in the coming years. So that the challenge is very, very, very immense. Unless we are prepared, there will be always a threat that how this can be used. All the countries, instead of fearing the atom bombs and other things, now they are fearing the biological weapons and other things. These are some of the terms that biosecurity, biothreat, and others, which I would be explaining. Biosecurity is nothing but measures to prevent, detect, respond to biological threats. It can be either natural, accidental, or deliberate. We have to understand because many of the things is happening. Biothreat is the intentional or unintentional release of agent with potential for public health crisis. The origin of COVID is still debatable, but the theories surrounding that is still lingering into our minds that what is that? Whether it was intentional release or it was unintentional release, we don't know. But these are natural threats, spillover, novel zoonosis crossing the specific barriers, COVID-19, Ebola, and others. Accidental threats, unintentional incident like escapes, unsafe specimen transport or farm outbreaks. Now you see that we are staring at a brucellosis threat, because that's quite common, and see that how we are going to handle that kind of thing. The interaction is increasing, and we have to be very alert in generating things so that we take care of that threat which is there. Deliberate or engineered threat, biowarfare, biological agents are used in conflict or terror consent. Usually, the uh, the the team has at least yesterday it was told that some resins and other things were detected. A catch was made. They were intended to use for poisoning so many people. That means you think of the consequences, which nowadays increasingly people are thinking about that. Unless we are alert, unless we prepare, so we would be staring at this kind of uh, catastrophes. Why One Health for biosecurity? Because we know that the zoonosis account for 60% of all human infectious disease, and 75% of the emerging disease are zoonotic. See that the potential of using zoonotic disease as a biological weapon is very immense. We see that the early warnings and effective outbreak containments are impossible without integrating human, animal, and environmental health sector. COVID has taught us how a one government approach concept is also there for the last 25 years now. It started in the late 90s, but still it is there. That has taught us that we should be having a one health approach, so that all these sectors, they can be sharing the data and doing things as it is required. The One Health approach is necessary to secure us against vulnerabilities exposed by pandemics and increasing threat of engineered or deliberate outbreaks. National One Health Mission, ICMR, these are all the things which have been talked about since morning. If you talk about One Health as a foundation for biosecurity, because it talks about multi-sectorial coordination, which is a core for stronger prevention, faster early detection. These are the pillars for integration. We do have all this mechanism in place, provided this mechanism, they talk to each other, and we have the sharing of the data on a constant basis. These pillars of integrations are integrated surveillance, shared data across human, animal, and environmental sector. This is still a challenge, but still a little bit maybe steps are happening in the direction. The movement, because genomic surveillance for COVID, it has taught us how the integrated mechanism can be a win-win for everybody. The joint risk assessment, unified evaluation of threat, integrated workforce, joint training and response capabilities is happening. Though we are having drills, emergency drills now and then, but this is more important that the integrated workforce would be there, who are jointly trained in understanding the threats of all these things. Because the ultimate objective is to strengthen the animal and the environmental surveillance. Unless and until we are able to identify these two aspects, we have not done our duty. Then the core capacities for any biosafety, biosecurity, and biothreat preparedness is integrated surveillance, whereas human, animal, and environment surveillance is to be focused on. Currently, either the animal husbandry, they would be focusing on the animal disease. And what are the zoonotic type of disease? We are still, that surveillance aspect, we have to see that how a integrated surveillance thing happens. Though the One Health Institute is there, that is more or less research into the zoonotic disease. But about the prevention, sharing of the data, taking a prompt action, what the national response should be there, that's an area of work where a lot of activities are happening and are planned to happen. Laboratory network with biorisk management protocols are to be there. We are creating a network of integrated public health laboratories. In all the districts, you will be having integrated public health laboratories. How these are integrated with the other mechanisms, the laboratory network of ICMR, NCDC, that's the work is in progress, and coming days you will be seeing a lot of things happening in that arena, and a protocol-wise management would be there. The early warning systems and joint risk assessment also, as I mentioned earlier, this is a very crucial area where things are moving in that direction. Rapid response teams are already there. The IDSP program is very strong, and it is already having the rapid response team, and yet more focus is there on interagency coordination, because rapid response teams are from the health side, but there has to be other agency. Agency means the veterinary department, the environmental department, other departments, so that the interagency coordination is also there. Then from spillover to safety, you have to talk about the pipeline. What this pipeline talks about, it talks about early detection, it talks about joint risk assessment, laboratory confirmation, triangulation, and rapid response and containment. I'm just repeating because at least the steps and other things, there would be a lot of repetition. And I believe that if I repeat some things which are very important, at least something would be absorbed. Then this is the sentinel surveillance site for zoonotic disease, which is our country's backbone. We are having a network of more than 80 to 100 sites under National One Health Program for prevention and control of zoonosis. The function of this sites is early detection, risk mapping, laboratory and field-based confirmation for 12 priority zoonotic disease, trend detection, early signal at human-animal interface, and it is linked to the national and international warning systems. Besides that, India is signatory to the Biological Weapon Convention and the conventions as well as the Universal Security Council Resolution 1540, where we are committed to share information about such kind of occurrences. These are the laboratory and the digital analytical capacity. The state of diagnostic laboratories are there. As I mentioned that we are having a network of integrated public health labs in all the districts, as well as the state-of-art laboratories in some of the medical colleges, identified medical college. Besides that, ICMR and NCDC, they are augmenting their capacities for having enhanced laboratory services. Integration with the animal and entomological food sector surveillance for threat triangulation. And remember, the key is the triangulation of all the data which we are receiving. Then human resources and crisis response teams, we are having nodal officers, clinicians, vets, lab techs, data managers, all are being trained for rapid risk assessment, triage, outbreak investigation. Simulation drips and SOPs for biorisk safety and response coordination is there. Emphasis on operational research and continuous workforce development. That's why this One Health Institute, they would be continuously doing the research and trying to find out how we can continuously evolve protocols and other things for management of these threats. These are the warning indicators. We are monitoring that how many number of trainings are there, but we have to delimit ourselves and take us beyond these KPIs so that the wider perception of this biological requirement can be taken care. Then other important thing is we are focusing on multi-sectoral coordination. That's why the Principal Scientific Advisor Office is coordinating with different ministries for spearheading this One Health program. And if you talk about the challenges in the lesson text, COVID has taught us that the siloed surveillance is not going to yield results and the desired response. So we have to see that how this siloed surveillance, the NCDC is doing their part, the ICMR is doing their part, the DBT is doing their part, and the animal husbandry is doing their part. That kind of siloed surveillance is not going to help. That's why a multi-sectorial coordination, other things are required. There is a fragmentation between the human and the animal data. Efforts are now being made in the One Health program to address this issue of this fragmentation. Limited coverage of remote and semi-rural areas, the need for greater integration of defense and security sector, because of biological warfare is now that even the colleagues from defense background, they would be understanding that they are also having a very close eye on this biological use of biological microbes as a biological weapon and other things. Then the sustained investment in capacity building and communication and digital infrastructure. These are capacities and challenges, though we do have in silos a little bit fragmented things, but a structured approach is now required for this. This is the way forward for this. We are expanding our surveillance network, and we are trying to take a technological leapfrog in the form of so that we can aggressively leverage the new technologies for faster detection and analysis. We are leapfrogging the technological aspect and trying to see that how we address the biosecurity aspect and foolproof all these things. Pathogen genomics for rapid mutation tracking. The genomic network which has been created with the as a consortium of the ICMR, DBT, and the NCDC. You see that how and the CSR laboratories that is yielding result, so that this kind of thing can also happen. The AI and the machine learning use in the surveillance is also helping us in environmental monitoring, so that the data which is coming from the environment that can be tracked and linked to some of the things which are happening in the human side. The launch of a national campaign among the PG students, practitioner, and the policymakers that I think the association should come forward and take it and see that how you can at least educate our PG students about the possible threat about this. These are the things we have to see, that the next war will not be fought with bombs, but with biology. One Health is our best defense. We have to remember that. And we have to see ourselves as champions of One Health biosecurity champion. We have to see the importance of cross-disciplinary teamwork. Every sector, clinician, vet, scientist, data analyst has a vital role. It's not that I alone can do it. We have to collaborate, cooperate, and coordinate with others so as to have a common thing. We are building a world-class surveillance and response model for the future. So we are all having all these things in place. I stop here. Thank you very much.
Thank you, sir, for covering this very important topic in a very comprehensive way and sharing all your experiences. Thank you so much. And you rightly said it is going to be a challenge in the future, and both for the civilian as well as the army personnel. And he also mentioned that one of the important issues is the coordination of various agencies. Thank you, sir. Next speaker, we have a very interesting presentation, best practices and innovation for regional centers. And we have Professor Rakesh Kakkar, sir, who is head of department of Center for Community Medicine and Family Medicine at AIIMS Bathinda. Over to you, sir.
So, very good afternoon to all. First of all, I would like to thank the organizers, Umesh Kapil sir, and the organizing team for inviting me for this session. So, from morning we are listening many challenges, and we have tried to do practically all those things. So, I'll not teach any theory. I'll show only the practical things which we have done. Wherever we are finding the gaps, we are trying to fill those gaps. So, initially, we have noticed that even in AIIMS Bathinda, the many fever cases were missed, and the cases remain undiagnosed as a fever. So we first initiated a training of our clinicians. So we 4 departments initially started: pediatrics, medicine, microbiology, and community medicine. Later we added neurology also to it. Then first our clinicians were trained, then followed by our microbiology team was strengthened. Now we are diagnosing many priority infections. Then we have strengthened our community surveillance part. So for community surveillance, we did training at all levels. At ground level, all ground level workers we have trained. Then we found that there is no module available for these ground level workers. So those things I will explain, that we have developed a module for that. Then we have trained laboratory technicians in Haryana, Punjab, Chandigarh. Then we have trained doctors, veterinarians. We conducted many panel discussion to find out the gaps. What are the gaps in? So some of the gaps can be dealt only at the policy level, but whatever we can try at our end, we try to actually, as per the One Health concept, we try to bring all the partners, all the key stakeholders together. So for integrated surveillance, actually, awareness should be there, capacity building to diagnose, that is there. So we have done MOU with other veterinary institutes, agricultural institutes, and to enhance the integrated surveillance, then capacity building at all levels. That is ground frontline workers, lab technicians, veterinary, and other doctors. For the priority diseases, so some priority diseases like leptospirosis, brucellosis, those are there in Punjab. And then now we are invited in many Kisan Melas for to interact with the farmers and to give them awareness. And on 13th, again, we are invited and will be going. So these are big Kisan Melas, and I'll show some of the photographs of that. Then we have developed some digital portals also. That is Nivaran and Saath that I'll show you. And for community outreach, we have conducted many camps to identify those gaps. So we are liaising with a local government, state government, and with at center with the NCDC. So we are doing this. You can see the Kisan Melas. So community outreach in Kisan Mela, and otherwise also we are going. We are liaising with our veterinary institutes, agricultural institutes. So this Saath initiative we have developed, that is a module basically for grassroots level workers. Then another is a Nivaran One Health helpline, which is actually an integrated helpline where all three sectors can call us. Though we are not capable sufficient to manage everything, so we have done some liaising with the veterinary and agricultural institute, and human part we can address very well. Otherwise, you will note, and we call back them, and we usually address those things. So we are getting many calls now and now we are revising and making it more modern as per the need. Then we have developed various advisories. During recent flood epidemics, we have developed some health education material and advisory for chikungunya, for dengue. So this is a Saath initiative. Saath stands for Sensitization and Awareness of ASHA, ANM, and Training of Health Workers. So this was, we have launched it at national level with many functionaries and involving many state IDSPs. And based on that, we have conducted many trainings. So you can see the glimpses of various trainings also. Recently on One Health Day also, we have conducted a training for laboratory technicians. So now this is the next Nivaran. Nivaran is the nodal initiative for vigilance, awareness, and response against notifiable diseases. So this is a app where anyone having usually we get a call for कि rabies का dog bite हो गई, animal bite हो गई, what to do, how much vaccines are required, कितनी लेनी नहीं लेनी. So rabies is the most common query we are encountering from our health professionals from the medical side, but from veterinary side also we are so people can respond directly if they are noticing some unusual changes. So that can also be captured in this Nivaran site. So here you can see that the teleconsultation calls we are getting in for rabies, for leptospirosis, for brucellosis, scrub typhus, and general query related to zoonotic diseases. So now we are expanding this Nivaran to that is people can note down what are the symptoms. So based on the symptoms, AI can suggest what are the probable things possible, and we note down the location is captured from where the call is received. Then it will also provide a website. So if person want to know the details about particular disease, what are the signs, symptoms, what are the risk factors, so those will be developed. So this is in a future stage that is will develop in it is in a developing phase only. Then another thing, it will be very useful for surveillance and for disease epidemic. So this is a kit which is containing all the formats for leptospirosis, for brucellosis, for scrub typhus and all. And this is having bottles for collecting samples This is having a PPE kit. So this can be kept at all PHC, CHC level, where if person is noticing some risk or some unusual things, so the samples can be collected. So all the necessary things are kept in this. So this is Arogyam One Health Kit. Then we are also focusing on research component. So recently we've undertook the brucellosis serosurveillance and risk assessment among veterinary handlers in Bathinda district. So it was a mixed method study. Results are not yet published. Then whatever data is coming to our center, we are doing all the epidemiological assessment. All the epidemiological indicators are being studied, ki male, female distribution, times, percent distribution, and what are the risk factor, so that if rise in any cases or unusual thing can be captured. So this leptospirosis cases, we have done it for all leptospirosis, brucellosis, though I am presenting it for leptospirosis only here. So we have seen the cases reported from Bathinda, Mansa, Muktsar, Firozpur, Fazilka, Gidarba, and Kotkapura. So this was in August and October after this rainy season and flood, recent flood in Punjab. Then regarding the environmental health, we have started one study on incidence of coronary artery disease, worsening event in patient exposed to indoor and ambient air pollution, a prospective cohort study from 2 districts of Punjab. So this is to enhance the capacity and to do, since nowadays Punjab is having all type of exposure, air pollution is there, soil pollution is there, so pesticides and all those things are there. So it is very pertinent to take such studies. So these are the problem I have already discussed, that is underdiagnosing, underreporting, limited laboratory surveillance, low awareness, environmental and occupational exposure to these hazards. So we have taken all the steps to cover these things. We have developed some specific health material in all 3 languages, English, Hindi, and Punjabi, for post-flood threats. In recent floods in Punjab, so these material were used. And for dengue also we have developed material. So overall, with our Saath initiative, we have conducted more than 500 frontline health workers. Teleconsultation with the Nivaran we are doing efficiently. Then we are releasing regional advisories. We are doing collaborative surveillance with other stakeholders. We are developing health education material, and we are doing enhanced coordination between different sectors. So these are the glimpses of all what we have done. Thank you.
Thank you, sir. Thank you for giving us, I think, lot of idea to all of us who are working in the community medicine department. I think this is one of the way we can prove ourselves by developing regional center for One Health. And sir has given, I think, lot of idea to all of us, and I'm sure some of us are going to take it back home. Thank you so much, sir. Next, we have a speaker from ICMR. I will request Dr. Gaurav Tomar. He is having more than a decade experience of public health, and right now he's working in One Health unit of ICMR. He also has worked with the state departments of Uttar Pradesh, Jharkhand, and Bihar, as well as the National Health Authority. Dr. Gaurav is going to tell us about the surveillance for One Health and how we can integrate human, animal, and environment interface. That again is very important, how we can combine them. Over to you, sir. Please come.
Hi, good afternoon, all of you. I guess a bit of a technical issue here. So till the presentation is up, I'll be going to speaking about the surveillance which we are doing in One Health currently, and I'll also show the glimpse of the surveillance which are currently on the ground, and some of the surveillance are recently launched, and okay, fine, the slides are here. Some of the surveillance are recently launched, but three of them are currently going on ground. We have some of the significant findings on those surveillance systems, and I'll be taking you along for that. Just quick data. Now, since after COVID, we all are quite vigilant that we can be affected to the zoonotic diseases. But in a decade, almost, we have seen a 60% fold increase in the zoonotic diseases, and on the expectation side, it's going to increase if we are not countering it right away. A very good graphical representation where we are showing that how wildlife, domestic animals, humans are related to the health. If you see the first graph, where you can see a huge spike of a red pyramid structure, and where the spillover is not addressed, and the alerts are not addressed in a way they could have been. But in the second graph, if you see, if we detect the early sign through the surveillance system, we can reduce the zoonotic spillover over the humans and the animals as well. Connecting that, I already told that few of the surveillance are already going on the ground. I'll take you to the three surveillance which we are doing over the bird sanctuary, slaughterhouses, and zoo surveillance systems. For the bird sanctuary, we had an aim to build the real-time surveillance model. In fact, for all the three surveillance, we had that aim to build a real-time surveillance model where we are actually detecting symptomatic illness in the humans and taking the animal samples and the environmental samples also. We usually take the periodic consistency for all the samples in all the sites is usually a week in the humans. In environment, as in when we get the chance to take the sample for the migrated bird, like in bird surveillance, we do that surveillance, and in environmental, we are taking it once a month. For the bird surveillance, we are doing it majorly into two sites currently, Sikkim and Maharashtra. It is going ahead with 2 states and into the 9 sites, multiple sites for the surveillance. The study for the human is a longitudinal study where we take the samples from all the symptomatic individuals. The samples can be of blood, urine, swab, and we don't have a particular sample size right now for this surveillance, but we generally try to capture all the humans who are in connect or contact with the migratory birds into the bird sanctuary. And showing some of the symptoms, we usually capture their samples. For the birds, the arrival times of the birds is currently we are going ahead with the arrival time here in the October and November month, and we try to capture the samples, take a swab from the birds, how much and to the extent we can get it. So we try to get maximum species which we can in the bird surveillance. And during the environmental surveillance, we usually collect the droppings of the birds and through the soil and some of the from the trees, we do get the samples collected. For these, the bird surveillance, currently we don't have, since it has recently started, so we don't have a significant findings out of it. But in slaughterhouses surveillance, we do have some of the findings where we can have the connection between the environmental animal and the human, where the samples have shown a similar kind of a trend. Also, I forgot to mention in the bird surveillance and all the three surveillance, we are also going ahead with the next generation sequencing to find out more connections between the spillover. So the slaughterhouse surveillance is going ahead with three major states, Punjab, Telangana, and Assam. We are collecting samples of the humans which are showing the symptoms in the slaughterhouses, who work in the slaughterhouses. We try to capture most of them. Again, the primary objective for this surveillance is also to build a realistic and a realistic surveillance model on a real-time basis and to cover all the symptomatic individuals. For the slaughterhouse surveillance, we are collecting the animal and the human samples on a weekly basis. In fact, on the environmental also, we are collecting it on a weekly basis for this, and we are trying to capture the spillover in these surveillance. The common pathogen which I can tell in the slaughterhouses surveillance, which we found was Brucella, Leptospira, and Toxoplasma. And we have currently seen the spillover also, and two incidences also for the Brucella and the Leptospira. This is one of the recent launches, and the last month only we have done an official launch for this zoo surveillance with the aim of early detection and monitoring. The primary objective for this is also to enhance the NGS capacity and to monitor the pathogen trends in the zoo animals. And the study sites are the multiple sites here covering from Maharashtra, Madhya Pradesh, Telangana, Kerala, and Assam. The study methodology is going to be the same for the animal component. We are doing the cross-sectional study. For the environmental, we are again repeating the cross-sectional study, and the human component, we are trying to find out the spillover between all the three sectors. In fact, some of the findings I would like to tell that now with these type of surveillance, we are already doing some of including more sites. In the bird, we are increasing from 9 sites to going ahead to the 15 sites. And since the findings, we are already doing a next generation sequencing, there are lot many pathogens which will be published in our annual report, including the Leptospira, are coming into the picture where we have already seen the spillover. With this, I will like to end our presentation. I hope just in a quick section, I'll try to give you a glimpse what we are doing with a One Health surveillance on ground. Thank you so much. Yeah.
Thank you, Dr. Tomar, for a very crisp and very nice presentation. Many of the things we were not aware, especially the ICMR activities for surveillance of birds and all those things. Thank you so much.
डॉक्टर साहब, एक छोटा सा क्वेश्चन बताइए, ये वन हेल्थ क्यों जरूरी है? हिंदी में लेमन के लिए बताइए कि वन हेल्थ क्यों जरूरी है? आइए।
सर, मैं इसको ना सर्वेलेंस नहीं बोलता, मैं इसको बोलता हूँ कि सेफ गार्ड। इनफैक्ट वन हेल्थ इसलिए जरूरी है टू डिटेक्ट द अर्ली अलार्मिंग साइंस, जो कि हम लोग सब लोग मिस कर जाते हैं। लाइक कोविड स्पिलओवर हुआ था हमारा, अगर उस टाइम पे अगर एनिमल सर्वेलेंस होता तो वी कुड हैव आइडेंटिफाइड the causative organism earlier, and we could have addressed it in the humans. So to detect the early signs, One Health is very essential.
नहीं दूसरा ये बताइए ना, जैसे एनवायरनमेंट की बात करते हो आप, तो एनवायरनमेंट का क्या रोल है? हाउ द वी टॉक अबाउट मैन, एनिमल, एनवायरनमेंट, तो इसमें एनवायरनमेंट कहाँ से आ गया? कोई एग्जांपल देके बताओ ठोस कि हाँ ये एनवायरनमेंट का ये रोल है।
सर सबसे ज्यादा ठोस एग्जांपल तो आजकल हम देख ही रहे हैं दिल्ली में with the air pollution. I guess maybe like 50% of us are having symptoms with the air pollution. So environment is also affecting our human health. This is a classical example which we are seeing.
पर इसमें इन्फेक्शन एनिमल कहाँ से इन्वॉल्व हो गया? मतलब वन हेल्थ में तो तीनों चीज इन्वॉल्व होनी चाहिए ना, तो इसमें एनिमल कहाँ है एनवायरनमेंट के अंदर?
सर को एक्चुअली एनिमल के सिम्टम्स ठीक है, बट राइट नाउ बिकॉज द सर्वेलेंस सिस्टम्स आर नॉट दैट advanced in currently we are not including the air pollution and detecting that into all the three, but in fact the household animals are usually getting affected with this also, air pollution, like ma'am already said, the pet animals like dogs are, in fact मेरे घर में ही एक pet animal है who is currently being affected with this. So with the air pollution all the three will get affected.
Okay. I just like to make, I am Dr. Umesh Kapil. I just like to make a small request to all of you. One Health has this much of my funds, this much of funds. I can't stretch my hands. Okay. You must apply for the one grant in research grant in One Health. Okay. लेप्टोस्पायरोसिस, ब्रूसेलोसिस, जो भी आपको मिलता है आप प्लीज अप्लाई करिएगा. एंड वी हैव आवर एनसीडीसी बिग बॉस. सर खड़े हो जाइए. आपका नाम सर? डॉक्टर नवीन गुप्ता फ्रॉम एनसीडीसी. ये मालिक हैं इस देश के, ठीक है. आप लोग अप्लाई करिएगा फंड्स के लिए, बहुत फंड है, ठीक है. छोटे छोटे प्रोजेक्ट करिएगा और प्लीज डू राइट टू मी इफ यू आर इंटरेस्टेड इन बिकमिंग पार्ट ऑफ द वन हेल्थ नेटवर्क. ओके, आई एम नॉट गोइंग टू डू एनीथिंग. I am going to make that list and give it to ICMR, to NCDC, and then you can get communicated with them. Okay, so please utilize this opportunity. गुप्ता सर से मिलिएगा, इनको मत छोड़िएगा, ठीक है. निवेदिता आई थी सुबह, ठीक है. They are the big bosses and they are the one who are managing the One Health. 20-21 नवंबर को, सॉरी
नहीं सर,
20-21 नवंबर को एक बहुत बड़ा सम्मेलन हो रहा है वन हेल्थ के ऊपर. वो है भारत मंडपम में. उसमें प्राइम मिनिस्टर आ रहे हैं. You know, once Modi ji comes, that means every department starts working. So he's giving a very big boost to the One Health. मैं आप सब लोगों से लिंक शेयर करूंगा, आप भी उसमें कोशिश करिएगा आने की, ठीक है. यूज academic is basically once you are active, be active in academics. Okay, please. Thank you very much.
Thank you, sir. Now I invite another very distinguished speaker from the state of Gujarat, and Gujarat is known for its innovation. So we have Dr. Kurup Joshi from AIMS Rajkot, and he's going to share his ideas about One Health, what experiments and innovation they have done in Gujarat. Welcome, sir. Over to you.
Thank you, sir. Thank you, Umesh Kapil, sir, for giving me the opportunity to present actual scenario of my state. Hello, everyone. Myself, Dr. Krupal. I am from AIMS Rajkot, and This PPT on behalf of Government of Gujarat, Health and Family Welfare Department and SHSRC Gujarat. So we have one public health expert who is Executive Director, A.M. Kadri sir, and he is leading this One Health State Committee. And what we are doing, let's discuss. Now, what we are actually doing, we have proper state level convergence committee on One Health and AMR. So the main key stakeholder is chief secretary. When the chief secretary is involved, so all the department, all the 13 departments are on board. So the key members are the additional chief secretary, principal secretaries and secretaries from the Ministry of Health and Family Welfare, Government of Gujarat, Ministry of Animal Husbandry, Agriculture Department, and along with the Department of Science and Technology and GPCB, Gujarat Pollution Control Board. So as we all know, the keys when we are talking about the human, animal and environment. So the Ministry of Health, Ministry of Animal Husbandry and Ministry of Agriculture is most important, along with Department of Science and Technology and others. The main aim is committees to provide the guidance and develop the action, state level action plan to ensuring the interdepartmental coordination, research, policy making, any intervention and monitoring of the One Health related activities at state of the Gujarat. And below that, we have a proper district level zoonosis committee in which the head of this district collector, when the rural area is concerned, and when we have a 33 district and 8 corporation. So we have a municipal commissioner where the corporation is there. So the head of this committee is district magistrate and municipal commissioner. Sometimes what happen, we have a Sankalan meeting, so in which they are taking the agenda of this our zoonosis disease committee meeting. Same way, the key stakeholder from the nodal from the each district level department. And same is to prioritize the zoonotic disease, assessing the local disease burden. As we all know, the maternal disease is very crucial. We are focusing on NCD and maternal death. So nowadays, the collector is also and district magistrate and commissioner is also focusing on zoonotic disease surveillance and how we can prevent it. So we are focusing on the primary and secondary level prevention, and then we move on to the primordial prevention. Now, what happened in first meeting was held in 6 June 2024 in the state of Gujarat, and there under the chairmanship of chief secretary, there they make proper department and key action taken plan, what department can do what type of activities. So here the agriculture, farmer and welfare department along with cooperation department, those who are dealing with dairy and all these things, they have to take the responsibilities of the training, educational awareness activities, veterinary doctors, dairy operators and farmers. Then yearly rotation advisory for the pesticides use, establishment of the lab for chemical free certification fruits and vegetable, collaborative with dairies for residues testing, and conduct the awareness of the driver on harmful effect of the growth hormones. Now we have a Gujarat Biotechnology Research Center, which is very important, and I'll share what we have. Okay, they are doing the surveillance of the milk for antibiotic residues, AMR pathogen surveillance, pesticide residue testing in water, environment, and food commodities, dumping site surveillance for AMR, biological loads and residues, and they are testing of soil, water near pharma hubs of microbial load and AMR. So it is very important. Then we are talking about the AMR in human, but AMR in animal is also equally important. Now we have a GPCB. Now, as we all know, the environment, we are talking about the environment. And as I come here, I saw that the air quality index is very poor, something around 328, just like saw in the dashboard. So what GPCB does, they are develop the limit of the pharmaceutical efficiency for the antibiotic, monitor the effluent discharge and emphasize zero discharge outside the premises. That is the main concern for this or One Health Committee. Then we have a Food and Drug Control Administration. They have to track the antibiotic and prophylaxis across the supply chain. That is the most important, crucial. Monitor and enforce the Schedule H drug OTC scale compliance, pilot behavior changes strategy on OTC scale and Schedule H drugs. Test the milk for antibiotic, growth hormone, which is very important. Propose labeling to FSSI. They are emphasizing the proposed labeling for this FSSI and expand the food testing lab networks across the Gujarat. So we are developing these activities. And nowadays, after this meeting, some key action taken point has been already taken up. Now, for our department, health department, they have to provide the IEC, self-medication and antibiotic overuse. We are doing very excellently. We have a AMR specific committee in district level and in medical college also. We are strengthening the hospital labs for culture and sensitivity testing to guide the antibiotic use based on the drug susceptibility and benchmark and track AMR case monthly. Now, what the key decision taken? The second meeting was held on 1st July 2025, in which 2 state level reports were launched. First is a state AMR surveillance report, and second is annual antibiotic consumption study. So by this, we found that this committee is expand the one, then this committee is converted into the one head committee by after this meeting, and district-wise AMR dashboard to be made publicly available so that the one can, as we are talking that the data transfer is most important when the animal husbandry department is there, our department and agriculture and forest and environment department for this. So we have a proper dashboard that we can make proper surveillance and we can prevent it. Then milk supply cluster-wise antimicrobial testing and unified one strategy to be developed. So by this meeting, we are the pioneer to make this possible. Now, those few of the diseases which are very priority in our district, as we know that the CCHF outbreak is endemic, specifically in Ahmedabad and South North Gujarat region. So we are endemic since 2011. Our focus is in CCHF, leptospirosis. As you know, Chandipura virus cases are also in 2024. We have a specific outbreak of the Chandipura virus. 164 suspected cases out of then the 61 are confirmed cases. ICMR is also doing study in our state for the Chandipura continuous surveillance. Then we have a CCHF, then brucellosis, rabies, zoonotic influenza, and anthrax. Now, what we are doing for prevention and control of this disease, the main is to joint outbreak investigation. That is most important. When I'm talking about the outbreak investigation, then we have to, there's already sir is mentioned that we have to involve the animal husbandry department and environmental surveillance. So the joint outbreak investigation, zoonotic disease monitoring, and capacity building. For the capacity building, we have to aware all the actual what is one else, what we are planning to prevent it. Then the key output is the 3 medical college laboratory upgraded as a sentinel site. Out of there till now, when I come here, 2 sites is completely functional and 1 is under approval. Then the main key action taken point are the district epidemic medical officer informed about these activities, and they are actually part of this team for that committee, district level committee. At the district level, coordinator response is initiated and joint action undertaken by the coordination between the all the 3 departments: health, animal, forest, environment, and agriculture. Yes, that is the few are the data in financial year 2024 and 2025. Leptospirosis, 298 cases were tested. Out of them, 12 were positive. For brucellosis, 245, 58 were positive. And scrub typhus, out of 180, 13 were positive. So the main we found that the specifically in Ahmedabad and Bharuch region. So why this is important? What we are doing now, we have a focus area that where cases arrive, what are the cluster when we have to do the surveillance for animal and human. So now what we are doing for the strengthening of the infrastructure, that is very important for us. Gujarat Biotechnology Research Center, Department of Science and Technology, successfully conducted the whole genome sequencing of SARS-CoV-2 and Chandipura virus. That is very important. It is only the second institute in India after NIV Pune, that is very proud for Gujarat state, to achieve this landmark in the genomic surveillance, publishing complete genome sequence of SARS-CoV-2. Now, upcoming, we have a proper BSL-4 laboratory with ABSL-3 facility. So same thing, it is done by the Gujarat Biotechnology Research Center, and this will serve as a hub of infectious disease research for vaccine development. Now, what networks of the antimicrobial drug programs and superbugs, the main strategy is to tracking the resistance patterns across the sector of the human, animal, and environmental. And main we are proposing the main outcome of the common resistance genes and high-risk clones were early identified, so that we can take proper action. Evidence are being used to developing the state level policy, so we can focus on district specific. Then we have an environment surveillance activity. Main we are doing the surveillance activity at soil, river, water. Yes, what is most important for Gujarat is a area in which we are dense forest area, we have a desert area, and we are a large seashore area. So we are environment surveillance is play a crucial role, because we have all 3 environment are there, along with human, animal, and environment. We are also living there. So this is most crucial thing. So we have all 33 districts are involved for this surveillance, and all 8 core persons. So all the state of Gujarat includes, and for our region center, we are also doing surveillance in the union territory of Diu, Daman, and Dadra Nagar Haveli along with Silvassa. Okay, the main outcome we want that establish the system to benchmark the measure and monitor burden of AMR to generate the evidence of targeted One Health intervention. That is the one of the key point that we want in future. Okay, now what the forest and environment? Now we have a proper active forest and environment department, and that is our it's very good for us that the forester minister itself involved in One Health activity. So it is very good for us that the cabinet minister from the Department of the Forest and Environment are involving and actively is taking the regular update about these activities by his department. So these I am not going into detail, but yes, these are the work that already done by the forest department. Now we have a state action plan for containment of AMR. That plan was officially adopted on June 13, 2024 by making the Gujarat is the sixth state to implement such as a program. The main outlines of the programs are same to AMR containment established in 94 government hospital, AMR surveillance network in 21 medical college. We have selected one district pilot and 3 high-end equipment provided with this 3, I already mentioned in 3 medical college along with 35 tertiary care hospitals. So the main output is AMR digital dashboard that we can develop, and it is easily available in all these 33 district, and DM and commissioner can see all the actual data. Now these are the main the pathogen we are focusing for the surveillance. And now what AIS epidemic management we are doing, also AIS epidemic management, and the health minister, cabinet health minister is also actively doing these activities and monitoring at the state level. So it is very important, it is very good for us that forest minister and health minister are both are taking active step to prevent this zoonosis infection and zoonosis disease. Now, this is also the program for prevention of leptospirosis, but yes, due to lack of time, this is my last slide. What we are suggesting and what we are planning to do in the future, that is the nodal officer to be identified from the each department at district level. Now we are proposing, the state is the only policy making division, but we are focusing on the district level, each department which is the head and who are handling all these things, and rapidly in data transferring can happen so that we can prevent the early infection. We can cut the mode of transmission of that infection. One is strategy document to be prepared, policy level strategy document, region wise. A joint meeting of the nodal officer can be done at each quarter. Information sharing between all the department, and one is dashboard should be created at district and state level. Thank you.
Thank you, Dr. Joshi, for telling us convergence, how we can ensure convergence at medical college level. I think a lot of lessons from our presentation. Thank you so much. So with this, we finished the second part of this today proceeding. Now we are starting with another interesting topic. That is Dr. Supreet is here. Okay, fine. Thank you. So this is actually about food system transformation, how these food systems are improving or they are not improving and affecting our health status. The studies have shown that we have annual food production in 2023-24 more than 330 million tons. And per capita monthly consumption of cereal has been decreasing over the year. In 19, I think Madam will cover more details. The cereal consumption we are decreasing, and we are more going for fast foods, especially in the urban areas. You will find fast food and all those things that has repercussion on health. Another issue is related to filter water. Instead of ROs, we are using RO water. And that again, I think a lot of things are going to happen. And I welcome Dr. Supreet Kaur. She is Senior Policy Advisor, Global Alliance for Improved Nutrition. And she has 20 minutes, madam, with you, and kindly cover this topic. I know it is difficult, but I'm sure you'll be able to do that. Food system transformation leading to impact amongst poorest families and communities in India, amongst how it is going to affect health. Thank you so much. Over to you.
So much.
Thank you. Thank you so much. Very good afternoon, everyone. And I know, first of all, I would like to thank the organizers for putting this topic up front, because this is the need of an hour. And I really would like to congratulate the organizers for getting all of us to discuss what actually is important to make our India Viksit Bharat by 2047. So before I start, I would like you to just have a broad glimpse what are the global nutrition challenge. And I would like to mention that epidemiology is not complete if we do not discuss the nutritional challenges. And nutrition challenges are like Pandora box, and we have been struggling to get this puzzle resolved. And decades of hard work has already been gone, but the success is still what we are waiting for. So if we talk about global nutrition challenges, it's very well known that 1 in 3 people worldwide are malnourished. 1 in 5 deaths worldwide are linked to poor diets. So if we talk about micronutrient deficiencies, for preschool children, nearly 50% of preschool children are suffering from at least one micronutrient deficiency. And this proportion is way higher in women of reproductive age, like they have 2 in 3 women are suffering from at least one micronutrient deficiency. If I talk about globally, you can see the India's picture that 9 in 10 women are having at least one micronutrient deficiency, whereas as compared to 1 in 3 in US. And 2 in 5 women are suffering from iron deficiency, which is anemia in other words, if we can say. So this is, you can see that how India is posed when we talk about micronutrient deficiencies. Now, again, globally, if we see, we are talking a lot about SDG indicators, and governments are working very hard to, to be upfront to resolve and come up with the numbers which show that progress in terms of SDGs. So 56 SDG indicators are really highly relevant to nutrition. World Health Organization has also set the global targets for 2025. So 6 global nutrition targets have to be met by 2025. So these are like 6 targets for which each country has to show the progress by the end of this year. So why it is important? Nutrition is important for a wide range of development goals, as we have seen. So we can say that it's not just the marker of progress, it is the maker of progress. If we have to put India upfront, and vision of the government is to have the Viksit Bharat by 2047. And I don't think that that vision is going to be fulfilled until unless we are there on the right trajectory to meet the nutritional targets and show our population is doing well in terms of nutrition and its indicators. So before understanding that, what can be the causes of it? The poor diet and nutrition is the basic denominator of all type of nutrition related indicators. Malnutrition is and the disease burdens have the massive social and economic impact. If I talk about at the global levels, 2.8 billion people cannot afford so-called healthy diet. The various research institutes are posing that one needs to have right amount of carbs, fruits, vegetables, pulses, meat, fish, egg, whatnot. And if I would have to say that nearly 3 billion people are not going to afford that, so one needs to look into that where the issue is and how we are going to resolve it. And 1 in 5 lives could be saved if we just improve the diets of the people. So I would like you to take, 4 aspects from India to consider that where is the problem and how we are going to resolve it. If we see the malnutrition numbers, all of us are coming from the epidemiology background and are very well versed with, how the nutritional indicators are getting improved, somewhat stagnant over the decades. The data from NFHS is showcasing that we are doing average when we are talking about malnutrition. This can be undernutrition, overnutrition, or micronutrient deficiency. So I would say that we are doing fairly okay types as far as nutritional indicators are going. The second aspect is the coverage of nutrition and health programs. We are doing tremendous in this. In all the health programs and all the nutritional programs, had it been Anganwadi centers coverage or immunizations, or for that matter, deworm tablets, IFH supplementations, and so on and so forth. In all the programs, we have been seeing the significant improvement from NFHS 4 to NFHS 5. And this is like a trend for past so many decades. So this is the second aspect. Now, the third aspect, the sir is also mentioning that we are showing the bumper record production as far as India is concerned. I have figure from 23-24, which shows that we have averaged around 6.5% increase in the food grain production, which is like more than 350 million metric tons. So we have enough food for us. If we say about only staples, we have enough food for us. So there also we are doing okay. Now, the fourth aspect, when we see the minimum diversity score, or when we see for the women or the children below 2 years, the data is available, the picture is really very gloomy. nearly 23% children and are receiving minimum diet diversity score, and around 11% are only getting the minimal acceptable diet. So this is the worrisome area for us. So now we have seen the 4 aspects. We are doing strongly, fairly well in agricultural production. We are showing somewhat okay mixed type of performance and nutritional interventions and outcomes. And we have a strong improvement in our nutrition and health program coverage. So where is the problem? The problem is the missing middle. It is the food system. One needs to work on each and every aspect of food system, and it should move in a coherence so that we can moving towards the goal to achieve the nutritional security by 2047. So what is the key challenges posed for the food systems? First is, as I already mentioned, the unaffordability. Near 3 billion people cannot afford what we call as the healthy diets. Healthy foods are often less desirable, and food environments often feature and promote energy dense and nutrient deficient diets. I'm very sure for past so many days, I mean, we are just past the festival of Diwali, our newspapers are flooded with the advertisements of high salt, high fat, high sugar diets. And if you just flip the pages, they are becoming so desirable that you, oh, it's 1+1 free. It's like buy 2, get 2 free. So it's like, you know, they are becoming more and more desirable, the energy dense foods, or we can call it high salt, high fat, high sugar food. But we have not seen an advertisement which says that you have to eat 3 servings of vegetables or 2 servings of fruits a day. No such advertisement is there. So desirability for healthy food is completely missing. Sometimes healthy foods are not accessible. If I'm talking about the person who is at the last mile of our country, he might not have the accessibility to get the healthy food. There can be some inadequacy. I mean, in the present time, so much climate crisis is going on. Somewhere it's flood, somewhere it's drought. So there can be food supply issue. One needs to work on that as well. And revamping the complete food system is the need of an hour. This is like the punchline we need to consider if we want to work towards the better health and nutrition systems in India. So I know this is a bit busy slide, but I would like to take few minutes to make you understand what actually food system is. So there are 4 broad buckets which talks about food systems, and finally it's going to influence our diets. So first one is food supply chain. How it is affected, that we need to work on this. The food storage and distribution is such that it should aim for the healthy diets. Processing and packaging should also be in that sense, and whatever is retailed and market should also be in line with the definitions of healthy diets. Then comes the food environments. Again, I talk about the availability, affordability, product prices, vendor property, and food messaging. Whatever we are hearing from the advertisements target kids and children from of the school age group. So all those things make those food products very attractive. Then comes the individual factors of economics, cognitive, the understanding about the food, aspirational, and also the situation. So all these things are going to influence the consumer behavior, that how the meal is being prepared, how the food is being stored, and finally it is reaching to the people, and it's going to influence the diet. So these are like, this looks very simple that, we need to work on these buckets, but this is also influenced by the external drivers. External drivers like environment and biophysical factors like climate, biodiversity, and soil health affects the food system immensely. Cultural factors, that what people think is desirable depends upon type of upbringing you have, the gender norms of the culture you are belonging to, who cooks the food for you, who buys the food for you. So all these things are affecting our food systems. Again, then infrastructure to transport the healthy food, to store the healthy food, and to distribute the healthy food. Demographics can be, we are moving toward the urbanization, the smaller families. People don't have time to cook. They are just ordering. The online apps are there, or even your, even in the slum areas, you have seen the small shops selling Cokes, the chips, which is like, in a pack of 5 rupees, which is very easy. Mother gave 5 rupee to a child and he is eating those stuff. But they do not have the awareness that on the similar price, you can get a guava or another healthy fruit, which can help to build the immunity of the child. Then, of course, the political and economic factors, we are grappling through the wars all across the world, the price surge as per the tariffs, the whatever is happening all across the world is going to affect our food system. So if I talk a bit more about affordability, as per the analysis, it's shown that around 55.6% of our population, as per the SOFI figures, cannot afford the healthy diet. So average cost of a healthy diet is around 280 rupees. You can it is per person per day. So it is like, if it is a family of 4 or 5, so you can say that how much it's going to cost for a day and then for a month, and you can see that average income of the household and how much of us can actually afford what is the healthy diet. So this is again a new version from which I would like to support, that how our food system is going to revamp, what for each and every pillar, what needs to be taken care of to make our food systems more respondent to the needs of the population. One needs to rebalance the agriculture, more research and development needs to be put towards the nutritious food. We should aim to reduce the food loss. A third of our production for fruits and vegetable is lost every year. So this is humongous loss. One needs to think very creatively through the creative ideas with low energy requirement, low cost intensive ideas which can be there with the people so that food loss can be reduced. Another one can be the fortification, biofortification and reformulation of the food. Through the food environments, it's important that food SMEs like small medium enterprises should be encouraged at the local level so that the carbon footprinting can be reduced. Food price subsidies and taxes should be considered for unhealthy foods. Implement workforce nutrition program, because one third of our time goes to where we are working. So how our work place is also going to influence our diet habits is also a matter to dwell through. Next is, of course, the clear food labeling. I'm hearing, I think for past 3-4 years, that we are coming up with some sort of labels to distinguish that what is the healthy food and what is not the healthy food. There are going to be star ratings, or I don't know what is happening there. So that area also needs to be taken care at early as possible. Individual factors that one needs to, the platforms like social medias, youth are too much engaged into the social media, so it has to be coming up as a big wave of information which should be there upfront to encourage eating healthy diets and what are the advantages and how we can make our healthy food accessible and more desirable. More advertisement for the aspirational, that makes the healthy food more aspirational. And of course, all these things are going to affect the consumer behavior. That should start from the school. Technology should be made easily available to the people who would like to invest in this area. And all these things, when we work together, can influence our diets and will have an influence of health and nutritional indicators. So what can be the recommendation to strengthen food system is one needs to have a consumer and food environment focused food system approach for the sustainable healthy diets. Markets for the better diet should be available. End-to-end approaches for key nutrient-rich food should be there, and leveraging other systems of equitable diet and nutritional impact should be encouraged. And at the end, of course, it's the issue of policy and governance, that how government can take the leadership to amplify the knowledge and the awareness around the healthy diets. So again, I would like to conclude my whole presentation by making is that India has made a very impressive progress in some dimensions for nutritional indicators. Stunting is reducing, nutritional program coverage is improving both for ICDS and health programs. Agriculture productivity, as always, remains high, but the diet diversity is low for women and infant, and healthy diet is expensive for all. So what crux here is that food system have the potential to do much for nutrition, and there has to be a plan which should be strong enough to create the pathways for policy makers, for state governments, for even for the SMEs to follow and get more and more into the aspirational food system. And there is no silver bullet within the food system, but a range of action that is required, because it has to be a sequenced and the coordinated way of how we are moving ahead. Not all pieces should work in their own sweet pace and progress, but it has to move like, orchestra, so that a melodious tune for healthy nutrition and our country can be made. And we are proud to be working closely with Government of India to take the strong pathways for food system transformation forward. So this is again a busy slide. I think I have discussed all these aspects in my presentation. So thank you, and open for the presentations. Thank you, sir.
Thank you so much, Dr. Supreet, for giving us an overview of various food system in the country and what are the challenges and how to meet them. There is slightly change in the program. We are going to cover this session on accelerating universal health coverage through implementation of research first, and then we'll cover to the other session which was planned. So as you know, that health system is a dynamic system, constantly changing. And for that, we require constant research inputs, and research, especially in the health system, is very, very important for our policy planners and managers. We have with us Lieutenant Major General Atul Kotwal, sir. Currently, he is the president of the Indian Association of Preventive and Social Medicine. Earlier, sir has been the executive director of National Health System Resource Center. And we are proud to say that he is also NAMS fellow also. So sir is going to talk about evidence to action, prioritizing research in shaping the reforms towards universal health coverage. So over to you, sir. Sir, you have 15 minutes, sir. 15 minutes, sir.
Thank you, Dr. Sood, sir, for that introduction. Good afternoon, everyone. Since I've got only 15 minutes, and I think I'll just quickly go through my presentation. What is important is to understand the, we all, I think all of us sitting here know the importance of universal health coverage and also implementation research. Anyone who's not exposed to universal health implementation research, I'll cover a little bit of that. UHC, I think everyone is aware. I'm not going to repeat that. So before I start, I must thank the organizers for giving me this opportunity to be here. The EFICON, Dr. Umesh Kapil sir, and also the ICMR, Dr. Ashu Grover and her team, who asked me to be part of this panel. So this we all know, a full range, access to full range of quality health services. So basically, if you break down into words, accessibility, affordability, acceptability, availability of quality and safe services with equity. That's what universal health coverage is. Definitions and all, I think we all can see later on. But the key aspects are basically the three pillars: population and service coverage, and also financial protection. This covers all that what I have mentioned just now, and it covers the universal health coverage. There's another word, universal health care. I'm not going into details of that because our aspirations somehow have now only up to universal health coverage. Care, I think, will come in later on, which is much tougher to achieve. So three pillars I've mentioned, key aspects again, which again I have covered: the comprehensive services, equity and access, financial protection, primary health. And how do we achieve that? So strengthen the entire health system. And health system, the building blocks, WHO 6 building blocks, everyone knows. I headed NHSRC for 4.5 years till about 2 months ago. And what we added from NHSRC, and the paper is still under publication, is the 7th pillar of community processes. Because without the community processes, without the communitization processes, we won't be able to strengthen the health systems overall. And also separately, I have mentioned integrating care. That is how to integrate the traditional systems, the Ayush systems in our in our health systems to make them stronger. And what does implementation research bring to the table, which helps in universal health coverage? It identifies the enablers and barriers. The policy making is there, which happens in the state capitals and the national capital. But on ground implementation, that is where the challenges come in. That's where the various factors of infrastructure, the governance, the administration, the actual financial effective and efficient utilization of finances, the human resources for health, their numbers as well as the skills which they have, all those factors, and also the socio-cultural, political, and economic determinants which are there on ground. Those all come into play. That leads to various factors which may help in implementing a policy or a program, or may be act as barriers in that. That's what implementation research does in a nutshell, to identify those and also co-develop along with the local teams the programs which are modifications of the existing ones based on the identifiers which we have identified, the enablers and barriers, and implement those to a trial, maybe comparative arm or without comparative arm. We can do pre and post, those various methods and all. I'm not going to details of that, and come up with certain solutions which are much better implementing as compared to the earlier one. That's what the implementation research is. And the definitions only, but if you look at this, that how strategies are optimally designed and put into practice to increase access to quality and safe care, which contextual factors are most important to consider, because each state is unique in our country. Within state also, each district is many times each district also different with intrastate as well as interstate variations. So that context also differs. Why and how countries decide to invest in scaling up implement strategies, again at a larger scale. Sustainability of interventions, again that is very important. I was reviewing one of the IR projects yesterday and day before yesterday, where I realized that whatever they are doing, they're pumping in a lot of money while co-developing. So my first comment was this only, that sustainability. That when we talk of implementation research, when we think of co-developing something which is already existing and coming up with a refined implementation strategy, we have to look at the financial kitty as such overall. Of course, increasing financial allocation is part of the health system strengthening, but we have to look at what current is available and what would be available over next 5 years or 10 years. When I joined NHRC in March 2021, we established the IRHSS, Implement Research Health and Strengthening Platform, with dedicated funding from the Government of India. These are the few of the studies which helped subsequently the Government of India as well as the states. So I'm just giving these few examples, not going into theory of IR or UHC, which I have already alluded to a little bit. So we analyzed mobile medical units, Pradhan Mantri Ujjwala Yojana, role of Ashas, and evaluation mainstreaming Ayush. We also looked at assessment of ability and quality of CHOs as a new, that's an innovation, a new mid-level healthcare provider. There were questions being raised about their the skill change which has taken place after that 6 months of bridge course. So we said, okay, let's have a tool also to which can look at, just like IPHS 2022. There's a self-assessment tool. Similarly, we worked with an organization and did this research. Again, the factors influencing implementation adoption of technology. It's very easy to say that, okay, we'll develop that portal or we'll make an app, but how will the healthcare workers utilize this technology? How adapt they are, and how will the community also accept the technology? So we have to look at those factors too. Again, why ambulatory care patients bypass the primary care and reach secondary and tertiary? Again, a very important study. And treatment adherence for hypertension and diabetes. There's a culture of victim blaming that, people are not taking hypertension and diabetes medicine or chronic medicines. People don't take medicines and all. Our study clearly showed more than 94-95% are very happy that, okay, yes, with this medicine, it will be under control. The problem is availability. So that's where the free drugs services and free diagnosis services comes in. I'll show you that. And another one was your free initiative in reducing out-of-pocket expenditure. Again, financial protection is very important. The catastrophic health expenditure prevention is very important. It's all linked to SDG 3, or all subset of SDG 3 point. One of that is also the reducing the catastrophic health expenditure. Assessment of current workload of ASHAs, because they said ASHAs are being overworked, but this study clearly showed that no, it is not the case. And assessment of quality of care among CHOs, not only the capacity, also the quality. Just few studies I'll share with you. Ujjwala Yojana clearly showed that the improvement was there in general health of the primary person who was making food, was cooking. 40% of these LP showed improvement, and 55% had fewer episodes of respiratory illnesses after getting PMUY connections, PM Ujjwala Yojana. Significant improvement in quality of life. Even the young girls said that, okay, now we have more time to study, because earlier we had to fetch more water and also spend more time in washing utensils along with our mothers. That all reduced because that instead of biomass fuel, it was a cleaner fuel, not affecting the utensils that much. Again, bottlenecks were there about their cost of this and also distance for refueling. Based on this, the scheme was modified by the government of India and implemented in the entire country after this. Out-of-pocket expenditure on medicines, the consumables and medicines, again, look at it 42 plus 19 and diagnostics. So this is very important. So that's what we need to, that's why DBDMS now is also, we have added one arm of diagnostics. So DBDMS early only had drugs and vaccines. It's now we've added diagnostics, complete management of that based on the studies findings. Again, utilization of ASHAs. And if you see down below, I have mentioned also what all we are looking at it specifically. If you look at Ujjwala availability is there, people would definitely be using it. Affordability, again, out-of-pocket expenditure. Here it covers availability, the ASHAs, acceptability, because ASHAs are there from them only, amongst them only. They are not healthcare workers. They are voluntary workers. And community processes strengthening. They're involving the community, and they can be successfully trained. The training part is required, and that's where the NCD app and all the other apps, a fresh retraining was done for all ASHAs how to use it, including the offline application. Ayush services co-location. We said, okay, Ayush service will be co-located, but when we went on ground and analyzed this scientifically, we saw that people were very keen for this, but there were challenges in availability of Ayush person for dispensing the medicine. There was only one person. Secondly, cross referrals were not there. So that kind of culture has to be brought in if you want to really, if you want this to succeed for the integration of Ayush into the health system. The people have a choice. There is no mixopathy, and there are cross referrals amongst Ayush and allopathic practitioners. And based on this, changes are taking place in the entire the drug management of the Ayush, and also they are planning for having one more person along with the Ayush practitioner at the co-located PHCs and sub-centers and PHCs and CHCs and district hospitals. Various mobile medical units, because this is talking about accessibility, availability, and affordability. In remote areas, that's where the accessibility comes in. So governance, government-operated model, outsourced model, and hybrid model. All three had their positives and negatives. So looking at that, similarly, we also analyzed all PPP projects under NHM since 2007 onwards, and combined knowledge also gained. So we modified, improved upon the MOUs which take place between the government and the private providers. This is what I mentioned earlier. Assessment, which a tool has already been created, which can be used very easily. Factors of treatment, again, I mentioned this earlier very clearly, that it's the availability which is there. And Ayushman Arogya Mandir are fully able to conduct the NCD program for diabetes and hypertension. And also ASHA program was found to contribute very significantly to this. So its main is the supply chain management, ensuring that the diagnostics and drugs, as per the numbers for every arm as per the IPHS, should be made available by the state. Why they were bypassing? Again, if you look at this, the second part, qualitative findings, scarcity of HR, absence of female doctors, lack of skilled lab technicians, and of course, diagnostic and medicine shortage, lack of referral services, infrastructure inadequacies. So again, the population coverage and service coverage, both are covered in this. And how to strengthen that? That's where the ambulance services, the amount was increased in the NHM, that okay, more money has to be given to states so that more number of ambulances are there. And the population norms for that, we also recommended for that also, so that more number of BLS and ALS ambulances and patient transport vehicles are there for transportation. And drug diagnosis, I already mentioned earlier. These are various factors influencing implementation and adoption of technology in diagnostics and treatment of NCDs. Again, enablers is perceived value, but there are a lot of barriers, lack of infrastructure, HRH, weak governance mechanisms, inadequate incentives. Governance and administration is something which we generally don't talk much, but those are very, very important factors. And a lot of our IR has clearly shown it, that it's the local administrators and the state administrators, their role, and wherever that is better, it definitely improves. Again, free diagnosis service initiative, it is definitely reduces the out-of-pocket expenditure. And evaluations, MCTF, mother and child tracking. Again, this is where a population coverage comes in. 23 states, 7 languages, but only 43% of parameter number of calls defined as per contract. So again, a major issue. Again, this was totally revamped based on the findings of the study. Similarly, same thing on Kilkari. The beneficiaries said that they made behavioral changes, but there's a fewer uptake of this, and the state functionary is totally unaware of what is happening. So intersectoral coordination as well as center and state coordination was also, which was very important. Mobile Academy again was part of this evaluation only, where they useful for ASHAs for refresher, but again their timings at what time they were called, and also the availability of phone with them. Utilization of telemedicine e-Sanjeevani. We always say that okay, leverage technology for ensuring the specialist services in remote mode, or even medical officers availability at the Ayushman Arogya Mandir, where we have a community health officer. 92% of those are nurses, 8% of Ayush background. So, but same, although more than half of healthcare providers had received training, but less than 20% opted for e-Sanjeevani. E-Sanjeevani, you know, it's got two models. One is direct from any individual. Second is assisted from the Ayushman Arogya Mandir at sub-center or PHC. That's where the role of healthcare providers comes in. If they are not convinced, they are not keen to this, the public will also not take it. Whereas 40% preferred in person only, and rest, of course, 40% were they were non-committal as such. And non-availability of specialists and MOs at the hubs. And many times one PHCMO is looking after all the arm under Ayushman Arogya Mandir sub-center under him or her. So the amount of time one can spend on that and availability of that was also important. Again, in UPHCs, expenditure state estimates on healthcare, the level of facility and patients at UP6 states, we did that. So those who were non-utilizers had much more out-of-pocket expenditure as compared to the utilizers. DH converted to medical college. So although I know there's a government policy to convert all DH into medical college, but our study clearly showed that there's a loss of public health functions whenever a DH is converted to medical college. That's where the service coverage gets impacted very, very severely. We recommended that only with 20 lakh population should be converted first. But of course, this was overruled and a decision was taken. Similarly, RBSK clearly showed governance is what is more important in RBSK. That only can improve the RBSK. Otherwise, all other things are in place. That governance will only improve the DEICs. It will improve the referral mechanism. It will reduce the out-of-pocket expenditure, which is more of opportunity cost as compared to the systems which are already there. So last two slides. Thus, we need high quality IR for course correction, for bringing voices from the field, evidence-based policy making, achieving UHC. But there are challenges, and that's why I think the other three speakers would be probably talking about more of challenges also. At the different schools of thought, some say, what is this IR? We had not heard about it. We had heard about, descriptive and only RCTs and all other kind of research. So IR has certainly come in. It's got qualitative methods also. We don't have much faith on that. But yes, we need to make it strong. And to make it strong, we need theory-driven research. It's not that you just say, okay, I'm doing IR. I'll just do a mixed method research. That's all. There has to be a theory-driven. People doing RR should be very well conversant about behavioral theories of transdisciplinary, or even starting from Bandura's theory of health behavior, and also heuristics, how people make choices. So one need to read all that and understand and also see on the ground. Again, research and design and methodology, quality assurance at all levels, collaborations, interdisciplinary research, capacity building of the investigator team, and also adherence to highest ethical standards. These are a few priority areas I had just listed in. I think in view of paucity of time, I'll leave it. As you all are aware of the health system, which all block what all IR is needed. And a lot of work has been done by ICMR and also NHSRC on the implementation research, helping towards universal health coverage. Thank you very much. Thank you.
Thank you, sir. Thank you, Major General Atul Kotwal, sir. In fact, he has given very important input when he was Executive Director at National Health System Resource Center to the Ministry, especially for the National Health Mission. And especially for the PG students who are sitting behind, it is, I think, better if you go to the website of National Health System Resource Center. It is the best. You have policy papers over there, and you will learn how to monitor and evaluate various programs. So thank you so much, sir, for your time and inputs. Now it is my great privilege to introduce, I think most of you know, Professor Dr. Sunila Garg, ma'am. She had been earlier the Director Professor Department of Community Medicine at Maulana Azad Medical College. She also served in the capacity of sub-dean. And you all know she was the former president of Indian Academy of Indian Association of Preventive and Social Medicine. And recently she has been honored with Emeritus Professor from National Academy of Medical Sciences. She has several awards and she has headed several important committees in the ministry for deafness program, I remember, and for adolescent health. So over to you, ma'am, and we are eager to listen to your experiences scaling evidence-based intervention across the diverse health setting.
Thank
Over
you
to
so much. Thank you. First of all, thank you to Epidemiology Foundation of India, Dr. Umesh Kapil. Finally, the day has come. You've been really working hard along with the team. And it's really, I feel that the conference has started with a big bang and it will end with the big bang. Now, coming to my topic is on implementation research. And I'll be talking, first I'll give you a little background about implementation research. Dr. Ashu, I'll take you back to 1986 when I was doing a project on cervical cancer that was led by Dr. Usha Luthra, and we worked on feasibility of involving existing infrastructure in earlier detection of cancerous lesion of uterine cervix. Imagine at that time, we only thought of, okay, this project is of 3 years, it will come to an end and the money is over and the project will come to an end. So that is where over a period of time. Now, under your guidance and under guidance of ICMR, now we have started talking of something which is sustainable. And I'll give you an example of few days back, a few months back, when ICMR had started talking about integrating of non-communicable diseases along with mental health. And Dr. Sonu is here, and I'll tell you that when they started with this, the whole component revolved around involving only psychiatry departments so that we can, integrate non-communicable diseases with mental health without realizing that who is there at Ayushman Arogya Mandir, who has gotten access to PHCs, CHCs and all. It's where the Department of Community Medicines are there. So over a period of time, we really brainstormed over the session, and then we felt that, when community medicine and, the Department of Psychiatry will come together, right from Ayushman Arogya Mandir to district hospital, and Dr. Kotwal made a mention of apps, so to and fro apps were there, and we really decided that let this be a sustainable option. So this is different from our basic studies, research studies, KPV study. This is where, we need to look at the sustainability of the project after its life is over. And that is where we are involving a government person. So please raise your hands if anybody is involved in implementation research, because Dr. Kotwal gave you a very exhaustive view of, how evaluation of implementation research has been done. So we need to look at now implementation research is the need of the hour, because it is a systematic approach to understand and address the barriers to effective implementation of health interventions, strategies, and policies. The goal of IR is to improve healthcare delivery. We are looking at sustainable improvement. It's not that today we have given one diet, as we were looking earlier to the nutrition session, and then it is over. So we are thinking that today ICMR or any other funding agency will give us some fund, and over a period of time, the system will take over. It's not that we are giving some money and that money comes over and you just stop it over. So that's where we have to think of whether we talk of stunting, whether we talk of malnutrition, whether we talk of NCDs. So we have to think of a sustainable option. So we have to look at, basically examining implementation processes outcomes by engaging communities of interest, the topics of interest, the researchers, and who are the implementers. So that is where implementers have to come from the systems. And continuously we have to examine the factors which influence the programs and policies, such as system provider, community, and individual factors. So it can be in form of, as was mentioned by Dr. Kotwal also, it can be in form of randomized controlled trial, can be quasi-experimental design, can be in form of formative research. It can be mixed methods. When we are looking at Janani Suraksha Yojana, we are looking at only the delivery part. Have we looked at the quality part? So that is where our mixed method research, that means qualitative and quantitative both will come into picture. Another thing is we can do it in form of systematic reviews, generate the evidence and put that whole research in form of a research, and subsequently it will be continued by the system. So we need to look at the implementation research and what are the barriers in implementing, because nothing is easier. As I was talking about 1986 project about cervical cancer, I went and talked to systems people, and remember medical officer is telling me, madam, आप हमारे speculum use करोगे, उसमें cancer cell लग जाएंगे and all that. So this is where preparedness of system is very, very important when we talk of implementation research. Now, how implementation research works is basically when we are looking at, number one point is that we have to look at the context and setting. We have got now 12 task forces at Ayushman Arogya Mandirs. Now RMNCHA, pehle hum khali MCH hi bolte the. Over a period of time, why we have started talking of reproductive health? Because we realized through research it is very closely related to maternal health. Then again, child health becomes a part of health, newborn health. And then again, there's a continuum of care in form of adolescent health, and overarching part is nutrition. Everything will come from research and observation. That is important. So we have to have the context setting in form of local culture, resources and existing practices. We need to have who are going to be the relevant stakeholders. Important relevant stakeholder is going to be the practitioner of medicine for that system, the policy maker. Most important is, unless your community is with you, nothing is going to be there with you. When Dr. Kotwal mentioned about Ujjwala Yojana and all that, this is where it benefited the community. People voluntarily gave up their cylinders. That day I was listening to PM's talk. He said we had to do nothing. People came forward and voluntarily gave their cylinders without taking any subsidy also. That is how it became sustainable. The third part is government officials are integral part of it. Then there are barriers and facilitators which are important, and they hinder the implementation, and facilitators are specific for the disease and work settings. And also we have to look at the theoretical framework, which is a consolidated framework for implementation research and also for EM framework. And then we have to look at the adaptation and fidelity. Basically, we have to look at exploring how interventions, one intervention will not fit all. If we are looking at intervention which will fit one of the settings of Gujarat, may not necessarily fit of Madhya Pradesh and not necessarily of Delhi. When we are talking of, different kinds of infrastructure, different kinds of places, different kinds of settings. So this is where it is important. But ultimately, we have to talk about evaluation and outcomes in terms of assessing the effectiveness and implementation strategies and their impact on health outcomes, service delivery, and system level challenges. So when we talk of the study organization of implementation research, the teams and responsibilities, the overall role, as I said, first think of Ministry of Health, because when we talk of continuity of program, this is where the government comes into picture, which will help us in decision making and implementation. And research groups are going to provide for that particular period of time the support for implementation, whether it is quantitative research or qualitative research. Then teams can be comprising of our program managers and implementers who are going to be there for that period of time. Afterwards, whether our CHO takes over, PSC officer takes over, district level officer takes over, that's another part. Then we have also got to have formative research and program learning team, for which, from where our own teams, they learn how to carry the program forward. Then there is an implementation support team and outcome measurement team. And activities are pre-decided. That means, and we refine as we go ahead. It is not something which is sacrosanct. So as we go ahead, we look at the activities and we implement the model. And then second part is in the research group. Formative research will develop the initial model. As I said, that initial model in integrating NCDs and mental health was only psychiatrists will be involved. Later on, we realized that last mile pe kaun jayega? Last mile pe it is the public health. It is the system people who will be going at. So that part is very important. And then also, we have to look at continued program learning. Every day there is a lesson from the thing. So whenever we are launching into implementation research, please don't see that आज project शुरू हो गया कल खत्म हो जाएगा. Every day there is a new lesson and we have to apply that, and we have to monitor process outcomes. And implementation support team is also going to provide support to the program to implement the model and contribute to refining and optimizing the model. And ultimately, we are going to measure the outcomes with the help of quantitative and qualitative data. And we will see that what is going to work for the system in long run. That is important. So we are looking at the formative research, program learning team, we are looking at implementation support team, and ultimately we are looking at outcome measurement team. That is very, very important. So what are do's and don'ts of writing an implementation research proposal? So first of all, in any research, and much more true for implementation research, why? Because this is going to continue and be a part of our system. We must be very clear about our problem statement and what intervention we are going to do. It should be realistic implementation plan with clear strategies and sustainability beyond the project. Commitment to collaboration with relevant stakeholders, including community members and state government. Strength of research team and collaborators should be very well known to us. Demonstrated understanding of local context and how it affects, basically the implementation. There has got to be strong framework, rigorous methodology, and clear plan for sharing the results. And in don'ts, we talk of lack of clear rationale for the research or insufficient evidence of problems significance, failure to demonstrate an understanding of local context or how it impacts implementation. If there is a weak research design, data collection method, that is going to be bothering us. Unrealistic implementation plan is not going to be helpful because that is going to fizzle out. Limited or absence of stakeholder involvement or inadequate representation of diverse perspective, and lack of clear strategies for disseminating findings. Because whenever you finish that project, it is very important that when we are talking of look at Asha's involvement in filling the community behavior assessment checklist, we also have to see कि वो उस performa में से निकल के क्या आया है, so that we can disseminate it forward. So let me tell you one of the examples of implementation research to improve institutional deliveries under GSY in Rajasthan Janani Suraksha Yojana. We all know maternal mortality has been a major public health challenge in India, and GSY was launched in 2005 under National Health Mission, which was aimed to reduce maternal and neonatal mortality, to promote institutional deliveries through conditional cash transfers to pregnant women. Despite the nationwide rollout in states like Rajasthan, which had low baseline institutional delivery rates and high maternal mortality, we faced implementation barriers such as, why were the implementation barriers? क्योंकि हम पेमेंट नहीं करते थे. हमने कहा आपको पेमेंट मिलेगी डिलीवरी के बाद. पुअर क्वालिटी ऑफ केयर एंड देयर वर गैप इन कम्युनिटी अवेयरनेस. So basically, although institutional deliveries they increased after GSY, qualitative assessments revealed persistent challenges. Many women still they preferred, home deliveries due to cultural beliefs or poor facility condition, and delay in cash incentive payments reduced community trust in the scheme. Overburdened healthcare workers were there, and inadequate monitoring mechanism limited effective implementation. Now, the objectives of the implementation research were to identify, as I said, barriers and facilitators to effective implementation of GSY in rural Rajasthan. And we wanted to test what is going to be locally feasible strategy to improve service delivery, beneficiary satisfaction, and uptake institutional delivery, and to strengthen the linkages between community health workers, primary health centers, and district hospital. So we had used a mixed method implementation research, and we chose, some districts of Rajasthan, and participants were pregnant women, ASHAs, ANMs, medical officers, and district officials. Remember, the government people were part of this program, and data collection was quantitative and qualitative through FGDs and all the key informant interviews. And we tested the interventions, and we digitalized the payment so that they can get faster payments. And we also realized that quality improvement initiatives at service delivery points, like clean labor rooms, etc., should be there. So what were the key findings we identified? We identified the barriers, which were administrative delays in fund disbursement, poor communication between ASHA and health facilities, lack of awareness among beneficiaries about the eligibility and entitlement, and poor quality of care at the government facilities. And then also we has said that what were the successful interventions? We introduced a real-time monitoring dashboard to see that payment is being made, and by the tune of, we increased the payment timeliness by the tune of 40%. And then capacity building workshops were held for ASHAs, increased their confidence and community outreach, and facility level quality assurance committees enhanced staff accountability and patient satisfaction. So ultimately what our outcomes were: institutional deliveries increased from 68% to 82%, time taken to receive cash incentives reduced from 45 days to 15 days. तो ये हमारे आगे के लिए मॉडल बन गया. And qualitative feedback showed that there is improved community trust in the public health facilities. So lesson learned were implementation research bridges the gap between policy and practice by identifying contextual barriers and locally adopted solutions. Digital systems for monitoring and payments enhance transparency and efficiency. Empowering frontline workers is the key to improving maternal health outcomes, and continuous feedback, remember this is the buzzword, and local adaptations are vital for any program. So last slide, from policy implications, we have to integrate implementation research findings into state level maternal health policies, which can guide scalable improvements in GSY delivery. And Rajasthan experience highlights the importance of evidence-based program adjustments within NHM to have sustainable gains in maternal health. So to conclude, implementation research in Rajasthan demonstrated that addressing operational challenges, strengthening frontline capacity, and ensuring timely benefits can substantially improve effectiveness of GSY. The model has potential for replication in other states, which is already being shown with a similar socio-demographic context. Thank you so much. Thank you.
Thank you, Professor Garg, for sharing your experience of so many years with us. We are really grateful to you. Next session, we have 2 more sessions, but due to time constraint, we have requested them to reduce the presentation to 5 minutes, and they have kindly agreed. We appreciate that. Thank you so much. So we start with the I welcome Dr. Rupa Shiv Shankar. She is a senior scientist E at ICMR headquarters, and she is going to discuss about continuum of care for control of non-communicable disease. Over to you.
Thank you so much, sir. I'll definitely try and stick to the 5 minutes. So I'm going to talk about Dr. Sunila Garg, ma'am, has set a stage for implementation research. I don't have to go into the details of what is an implementation research and how to do it. I'm just going to talk about how do we use that for control of NCDs in the country. So these are the various dimensions of continuum of care in health. It could be a continuum of care at life course or place of residence, sector, disease, type, systems, levels. However, in this presentation, and what we try to focus are the disease continuum of care, that is diagnosis, treatment, and control and cure, or the levels of care, that is primary to secondary to tertiary, referrals and back referrals. That's what we want to work on. So I don't think I need to tell this audience how big a problem is non-communicable disease now. 2/3 of our mortality is due to NCDs, and that's even more prominent when we look at the premature mortality in the 40 to 69 years of age. So this is the various web of causation for NCDs. There are different levels. Again, I'm not going into details of this various levels of web of causation. However, what we have to remember from the public health point of view are these 5 diseases and these 5 risk factors are the key issues related to non-communicable diseases, CVDs, chronic respiratory disease, cancers, diabetes, and mental health. And the risk factors such as unhealthy diet, tobacco use, harmful use of alcohol, physical inactivity, and air pollution. My colleague Neha will be talking about mental health disorder, while I'll be focusing only on the CVD and diabetes. So the major burden of common NCDs in our country, we know 1 in 4 to 1 in 3% has got high blood pressure, and 1 in 7 to 1 in 8% has got diabetes. And this is what the cascade of care looks like. Only about 30% are aware of their condition, and 16% are on treatment, and 12% are under control for hypertension. And a very similar manner, For diabetes, about 16% are under control. So to bridge these gaps, so why there is so much of this gaps in the continuum of care for hypertension? So there is a variable quality of care across the different levels of healthcare facilities. There is physician inertia. There was no up titration. There was a lack of drug forecasting for chronic disease care in our public healthcare system, overburdened healthcare provider, patients' long travel time, and lack of cohort monitoring. All this together in our program was leading to gaps in continuum of care for hypertension. For that, we designed a project called India Hypertension Control Initiative, along with Ministry of Health and Family Welfare, State Health Department, and World Health Organization, and came up with 5 core strategies: standard drug and dose specific treatment protocol, uninterrupted supply of medication using a good forecasting tool, team-based care and task sharing, patient-centered care at the subcenter or Ayushman Arogya Mandirs, and also using a good information system for cohort monitoring. So we were able to implement this project over the 5 years across 157 districts, and 51 lakh patients with hypertension were enrolled with on an average 45% clinical hypertension control rate. We also measured what happened in the population by doing a baseline survey in 10 districts in 2018 and repeated that survey in 2024 to see what was the changes. As you can see, there was a relative 40% increase in aware, treated, and controlled patient, while there was a relative 13% reduction in patients who were unaware of hypertension. This population level changes we could make only working through the public healthcare system, while we all know more than 70% of our patients takes treatment from the private sectors. Therefore, based on this success, the ICMR created this, decided to do implementation research in other aspects of NCDs as well. To do so, we had a brainstorming meeting with the national expert and curated several research questions, which were voted by researchers and administrators. And top 3 research questions were selected and converted into a national health priority research. I'm not going into the detail due to the lack of time. These are the ongoing projects, the STAR NCD, STEPS India, and DigiCare. And thank you all. I'm happy to answer any of your questions. If you can write to an email or call me, because due to the lack of time, I'm not going into the details of these projects. Thank you.
Thank you so much, madam, for your cooperation, and very grateful to you for your question. Thank you so much. Now I invite Dr. Neha Daya. She's a scientist D in ICMR, and she's going to discuss about integrated approach to mental health and NCD care. Over to you, ma'am.
Thank you, sir. And good evening, everyone. So I'll be talking about the integrated approaches to mental health and NCD care, that is opportunities for improved access and outcome. So because of the crunch of time, I'll not go into the details. We all know that the burden of NCDs as well as the common mental disorder is rising, and the treatment gap for mental disorders is somewhere between 70 to 92, and it affects the dailies, and which leads to the economic loss as well. So what is the need for integration? As we all know that these common mental disorders and the NCDs, they often occur with the chronic conditions like CVDs and the diabetes, and there is a high comorbidity. So someone having NCD, they are 2 to more times more prone to have depression and anxiety, and they worsen the prognosis and increase the mortality. And so what does integration mean? It is basically a single care pathway which address both mental health and NCDs, task sharing, use of standardized tools for the screening and management, and the proper referral linkage. So these are the current gaps in care that we don't have. Both the mental health and the NCD programs, they work in silos. There is low detection due to stigma, fragmented service delivery, and poor follow-up and medication adherence. So there are a lot of evidence which supports that integration is possible. And so I'll talk about the step which ICMR has taken to integrate the mental health in the NCDs. So we have one project on the implementation research study on integration of screening and management of mental disorders with other NCDs, where we are developing an implementation model with the aim to achieve 70% of coverage for screening, linkage to care and management, assess its feasibility and determine the implementation cost as well. And so we did before starting the project, we did the situational analysis, and we found that we have shortage of mental health specialists, and the CHO are also not very competent in delivering mental health services, and there is no user-friendly or easy protocol available to guide CHOs through this thing. And so from there, the thought of developing a workflow came. And then we followed a whole comprehensive process for the development of mental health workflows, which can be used by CHOs. And we did the pilot testing for these workflows. Then in these 6 sites, and this is the workflow. And we have also translated the CHO workflows in 6 regional languages. And these are the associated management cards. And we also found, we also did the pre and post evaluations of the CHO knowledge after this, applying this workflow. And we got very good suggestions, like if the language can be made simpler, if hands-on training can be given, and if these can be digitalized. So, secondly, for the medical officers, we use the ICMR standard treatment workflows to ensure uniform and practical guidance for MOs across implementation sites. So based on the feedback, we made one clinical decision support system. And the USP is that it is a digital screening and assessment tool, and clinical decision support is available for the non-specialist. From there, follow-up and referral is also possible. And there is an offline functionality, and the regional language support is also there. And we have real-time dashboards for the timely intervention and insights for the policy makers. And this is the intervention package. So one, we have the integrated tools for management, which can be used by CHO, then for the MOs, then the capacity building exercises, our CDSS system, and patient education and engagement. So these are the findings so far. Till now, we have trained 81. So we have implemented in 7 blocks across 7 districts in 7 states. So till now we have trained MOs and CHOs around 80%, 85% of ASHAs in these blocks have been trained till now. And 72% of facilities, they have started screening. ICE is available in 66% of facilities. And we conducted some awareness sessions as well. And till now, we have screened around 16% of the people in these blocks, and the proportion who came out to be screened positive are 51%. So these are the learnings till now. This is an ongoing work. So one is that this CDSS, this reduces our decision-making errors. And okay, so these are the learnings. So, and these are a few photographs from the project. And thank you. And these are some of the publications of our work. If you want to know the details of the work, please go through these publications. And if there is any query, you can please write it to me. Thank you.
Thank you, Dr. Neha, for adjusting the time. And in 5 minutes, you have really given a very comprehensive overview, and we are really grateful to you. Thank you, the ICMR team, for adjusting with us. Once again, we are really grateful to you. And next session, which we had actually postponed, is again very interesting session on standard treatment workflows. As you know that in order to ensure quality, as well as accountability and evidence-based medicine, development of the standard treatment workflow is very important. And Dr. Ashu Grover, she is one of the key person from ICMR. She has been working on that. And ICMR, in collaboration with the institution, has developed this workflow. And we are really fortunate to have you here to share your experiences. And in this session, Dr. Ashu Grover, as you know, she is scientist G and heading the delivery research in ICMR headquarters. Earlier, she was at PGI Chandigarh, I remember that. And she is going to discuss about standard treatment protocol for standard of care. And jointly, Dr. Pulkit Verma, who is IT expert and scientist D, and he's also joining her in this combined session. You can have 10 minutes. Okay, sir. So you can also come, and he's going to discuss about the digitalization for the standard treatment protocol and how it is going to make a difference. Thank you so much, sir.
Good evening, everyone. I think we're coming to the end of the day, but still it is not the end. Many things are still to come up on the way. And this is a session which was dedicated to the last two sessions from ICMR, which was one on implementation research and another was on standard treatment workflow. Both are directed towards having some kind of mainstreaming the universal health care and improving and goals toward the standard treatment workflow towards the sustainable development goals. So in the previous session, you heard about the experiences being undertaken by the Indian Council of Medical Research, along with the experts, Dr. Sunila and Dr. Atul Kotwal, along with two other eminent scientists from ICMR who are really part of the implementation research journey for non-communicable diseases, for hypertension, diabetes, and mental health primarily. But there are other initiatives which are ongoing with ICMR. So another initiative from ICMR, from the Ministry of Health, is again to have a standards of care, is the standard treatment workflow, which was started in 2018 with the flagship program in order to have the standards of care. Why do you need to have a standards of care? And I think we are representing the various organizations in this hall. Somebody is from AIMS, Delhi, other AIMS, we have the PGI, and we have the other institutions, associations. They come across various kinds of pathways of their treatment. They want to prescribe, they want to have a different kind of a diagnostic procedures. There are, little bit of maybe similarity, but variations as well across the different institutions and across the different physicians. Public prescribe the medication, the diagnostic in a different way. Similarly, the other private practitioner also, they want to have their own way of handling the patients in their own perspective. Other way is that there is inconsistency in maintaining the standards. Sometimes there is over-diagnosis, under-diagnosis, over-treatment, under-treatment, what dosages to be given, when to increase the dose. You've seen a very excellent example of India Hypertension Control Initiative where we need to adhere to the standard treatment. That was the one thing which was started. Apart from that, it is not only the scenario for the our country, in other countries, internationally also, there are, variations across various treatment providing agencies. Apart from that, we have the lengthy guidelines, like for example, from even World Health Organization. That's a huge booklets which going to come up, but we try to put it up into a single small, concise kind of a document. So that was the whole aim of strengthening and empowering the primary, secondary, and tertiary level doctors and the surgeons at the peripheral, at the public and the private healthcare facilities, so that they can make a quick clinical decision at the outdoor patient department as well as in the indoor patient department. And definitely it will help, and it's still helping the Ayushman Bharat, the Pradhan Mantri Jan Arogya Suraksha Yojana scheme at the various levels of facilities. So with that aim, we initiated the process of development of simplified approach, algorithmic approach for that standard treatment workflow. So this is the whole pathway, how we start with the topic prioritization, how do we get the topic vetted from the ministry and Nirman Bhavan and Director General Health Services, along with the other officials from NHSRC, from Niti Aayog, from NHA, and other international partners as well. And all the experts, they sit together along with their experiences, and they dig out the evidences which are available into the public domain. There are around many number of meetings which go across before finalizing the content of the standard treatment workflow. We have the graphic designer and we conceptualize all the content. Before it is made into the public domain, it goes to the kind of availability of the content validation and editing from the external and the internal agencies. After that, it is made available onto the public domain. So this is what is available right now. And all those three booklets in the online form are available on the ISMAR website, and again it's another website which is totally dedicated to the standard treatment workflow. So right now, if you want to know that how many we have developed, because this is a very lengthy process, one standard treatment workflow takes around 3 to 4 months before it is become finalization, and that depends upon availability of the evidence and availability of the experts in that particular discipline. So we have prepared 157 such workflows. Others are also in the pathway. So this is how that we are collaborating with the experts, the NITI Aayog, the DGHS, the WHO, and other relevant officials for that. And we released this last volume, and there is a letter from Dr. Apurv Chandraji for its wider dissemination to the primary and secondary healthcare facilities as well. You can see that on a specific day of the celebration, when we have to do the the rare disease and the sickle cell disease, on that day also these specific standard treatment workflows, they were released on that day. So yesterday we had an MOU again finalized and renewed the MOU with the National Health Authority to have the formulation of the standard treatment workflow as a part of the clinical and healthcare decision making. And those MOUs are going to have the implementation of the standard treatment workflow for its further dissemination. The NMC has also put up the STW as one of the mandatorily activity that need to be incorporated into not only into the curriculum, but into the practice of the medical colleges faculty as well. So the efforts are going on for its dissemination and its vibrancy. So the key feature, as Dr. Neha also shown you, the mental health STW. So it's a one pager, it's one in all, it's app based, it's only for the physicians, and it is image based, and it is being disseminated through various meetings like yours, like in the EFICON, the previous EFICON, and many more meetings. We have deliberated about the standard treatment workflow, and this is now in the phase that the whole country is going to be, we are not mandated it, but yet through various national and association and private agencies, the standard treatment workflow are really getting a more and more vibrancy, and it's more and more utility and going to be beneficial at various places. We have published the 4 papers also, they're available into the PubMed. So how the whole process has make the difference in various specialties, be it a dermatology, be it a universal healthcare, be it a neonatology. So there are the speakers after me that we will talk about with specific reference to gynecology, obstetrics, and neonatology and pediatrics, who will more talk about that how these have to be making the difference. And this is just a prize that the parliament is also noticing. This is a document which has been developed. So the whole aim is that we need to incorporate the standards of care in the private as well as into the public healthcare physicians, in order to have their kind of some uniformity across the management. And the aim is not only to have the standards of care, but also to reduce out-of-pocket expenditure as well, which the National Health Authority has incorporated into their guidelines, and they are continuously monitoring it. So the things are ongoing, and we have started working on newer conditions also on the request of the Government of India. We have started working on emergency, snake bite, rehabilitation, other cancerous conditions. And with this, I think quite possible that we will be able to incorporate the standards and uniformity across various care conditions, be it a surgical, be it a medical, or a public health perspective as well. So thank you for giving me the time. And now I invite Dr. Pulkit that how this website is going to be, how this you can download into your app, and what are the methods and how it has been developed. So Dr. Pulkit, and thank you. We are all available to you for answering any questions or any topic you wish to be taken up by ICMR.
So I have less than 1 minute. So Ashu ma'am has already set the context for the STWs. So I don't have much to add here, considering we have time paucity. The concern is that once the STWs were finalized, initially they were published in a form of booklets. So the major contention was how to make them available at point of care at the primary health center. And these are live documents, so these are dynamic. So once you publish something in printed hard copy, there's always an issue of how you refine them, how you make the latest copy available to the last mile healthcare worker. So once we were trying to digitize it, the whole STWs, the major concern was whether to go in a form of CDSS, like Dr. Neha has told, in clinical decision support system, or a ready referral sort of e-reference thing, because it is supposed for the physician. He is a specialist worker. So we chose the option to go for a specialist worker in a form of e-reference manual, and we digitized the STWs in form of mobile application. So that mobile app is now available on the Play Store and the Google App Store. So these all four things were there. And one important aspect was that they were supposed to be part of a reimbursement package of PMJ. So they need to be very dynamic because somebody's reimbursement is based on those STWs. So we digitize the same through digital application. This already explained how the things were there. So now this is the mobile application which is available on the Android App Store and the Apple Play Store as well. So these are the analytics which we had from the app, the usage analytics of STWs, their STW-wise trends also are there, broadly how they fall into picture, and that's all. Thank you.
Thank you, Dr. Pulkit. You're really IT expert. In 2 minutes, you explained everything. We are grateful to you. Thank you so much, Dr. Ashu, for adjusting the time. Now I request Dr. A.G. Radhika. She is the director in the Directorate of Family Welfare, Government of NCT Delhi, and she's going to tell us about the standard treatment workflows for OBG. Over to you, ma'am.
Thank you so much. So good afternoon all, and I thank the organizers, Dr. Grover, for inviting me here today. I just came to know that I have only 5 minutes to speak, so I am going to be very quick.
You can have 8 minutes.
Oh, okay, so 8 minutes. Thank you so much. So, so the background is there is a huge disparity in our health system in India. So there is a vast variable expertise as well as experience, and of course there is always the HR problem, and therefore the inconsistencies in clinical practice have also been noted in the rural and urban settings. Advantages of STWs have already been highlighted. They are concise, standardized care. They promote equity, quality, and rational use. Strengthen the referral systems. They improve the provider confidence, and of course the training and monitoring. So the importance and the need in our country was highlighted by this publication in IGMR 2017. The very first priority within the MCH domain was development and validation of algorithms for prevention of early detection and management of severe acute maternal morbidities and near miss events in the maternal health. So taking this forward, the ICMR along with AIMS, FOXY, and the organizations which were already highlighted. So in 2019, the first set of STWs on the 5 conditions were published, and these have been recently updated in 2025. And these are basically the antenatal. These are common conditions which were identified by the experts: antenatal management, PPH, dilatation and curettage, fibroids, heavy menstrual bleeding, and hysterectomy. So this is just an idea of what it looks like. Very simple, easy to follow. And the revisions in 2025 included the recent evidence which was available in terms of management of PPH, which specifically meant the newer Utrotonics, tranexamic acid, which is a hemostatic agent. And the algorithm was also changed as per the evidence that is available. So what is the advantage? Was it really worth it? Yes, the global experience shows that the standard maternal standardized care are of great importance in improving the maternal and neonatal outcomes, and this was highlighted by the WHO publication in 2016. And the models replicated in Sri Lanka and Thailand. Sri Lanka showed that by having the national obstetric protocols, there was an emphasis on the early detection of hypertension and anemia, and the near miss audits integrated with the protocols. Thereby, their mortality rate is amongst the lowest in the world, actually. And Thailand also showed that there was a 30% improvement in the timely management of obstetric emergencies. Similar models were replicated in Rwanda, and they found that the maternal mortality ratio, it was brought down from 203 to 145 per 100,000 live births in 2022. Of course, this model was also seen in the high-income countries, and this resulted in a 15% decrease in the preventable maternal mortalities. And now we also have the emergency care. ICMR is working on the standard treatment workflows on emergencies, and we have had very good results from emergency medicine, cardiology, neonatology, and the lessons learned was audit-driven adherence ensures sustainability. Now, this is a recent publication which highlighted the need for these standard treatment workflows as recent as 2025 by Indian authors. This was a cross-sectional prospective study where they had webinars followed by in-session quizzes and later also the survey questionnaires. And what they found was there was a great variation in the clinical decision making as well as the practices. And even though here you find in the maternal and child health domain the average number of right answers maybe were about 41, but there was a large variation. Here you can see the confidence interval of 95% among the gynecologists on the various treatment modalities. But the amazing part was this was the lowest, the variability was the lowest in gynae, and as you can see in other specialties, this was much higher. So when the clinicians were asked what they thought about these STWs, that they said that the availability of guidelines and the STWs was an important factor in their clinical decision making. And the perceived factor for adopting these STWs was the availability. So therefore, it also means that it is not only to have to be working on them, it is important to disseminate and make them easily available and user friendly to the users. And the barriers for adapting, one of the major reasons, up to 35 to 40% people said that they are not aware of the availability of SDGs. So therefore, it is important for us to today focus on dissemination other than publication. So this is our own experience. So PPH continues to be a major reason for maternal mortality in our country. So in Delhi, we did an anonymous survey of the physicians working at district level 200, at the tertiary and the district level, about 100 people there, 100 physicians. And when we gave the questions regarding management of PPH without STWs and after seeing giving them training on STWs. So the number of incorrect answers were to the tune of 97 out of these 200 among the medical officers versus 26% amongst the tertiary. This came as a surprise to us that PPH management among the postgraduate is one of the most often talked about subjects. Yet there were incorrect answers in 26%. Up to 30% of these postgraduates did not, really give the right steps of managing. However, with exposure to STWs, the number of incorrect answers fell. So there was a definite improvement in the correct answers rising. Out of 300, 240 people gave the right answers following the use of STWs, and the incorrect answers fell down to 60. So this certainly shows that it has got a definite use, in terms of the improvement of clinical management in our country. However, there are challenges. There is variable awareness. This was also highlighted in the earlier study that I had just projected. There is limited digital access in the rural scenario. So this is something that is to be really kept in mind. And documentation fatigue could be a reason. There is a definite need for periodic updating of these documents. Important to have feedback loops and supervision adapting to the local context, and of course engaging the provider along with an integration of the feedback system. And the solutions that we could identify and implemented also was to have these very easily visible, have it on the Android system as was it was projected in the earlier talk, and also have these available in the hard copy so that people are able to refer to them as and when to be able to, especially the newcomers, the new people who have joined the system. Importantly, linking this with Lakshya and Suman could probably be an important aspect to improving the implementation as well as the standardization of care. And simulation-based training are also an important aspect to see that these are implemented. So the key takeaways are: it is important to have these STWs as a bridge to gap between the guidelines and the bedside practice. Improve accountability, clinical confidence, as well as they are important sources of training for the basic care physicians also. And integration into national health programs, especially in the quality improvement services, improves the sustainability of these. and they expectedly would reduce the healthcare costs while facilitating equity of access to everybody, the quality care. Thank you so much for your patient hearing. Thank you.
Thank you so much, Dr. Radhika, for sharing your experiences on implementation of STWs for OBG. Now I invite Dr. Asima Dabba. She's a senior professor, Department of Pediatrics at Maulana Azad Medical College. And she's going to share, she's here? Okay, thank you. So she's going to share her experience related to the implementation of standard treatment workflow for pediatric patients. Over to you, madam. Thank you.
Thank you to the entire ICMR team and Ashu ma'am for this opportunity. So I will mainly take you briefly through the need and the way the standard treatment workflow would be operational in pediatrics. So as Radhika ma'am and Dr. Ashu have already given a very good overview of why this is needed and how this has been shown to be effective. But I think what we need to understand how children would be very different or little different, and why did we need a separate STWs when different aspects of pediatric care. So we are going to talk of something which are very commonly seen and some common errors that we come up when they are implementing STWs. So before we begin STWs, I think the very going back to something which has always been there as part of Government of India program has been the IMNCI training. And the very first few questions of classifying a sick child as per the IMNCI protocol talks of how non-specific and how general these complaints could be. So this I just put up to show you that something which can be very simple, like not able to feed, drink, vomiting everything, lethargy, unconscious, or convulsions in a child. So something which has to be simple, can be understood by a layman, if not a specialist pediatrician, and is objective enough and is also high on predictive value in terms of sickness. So with that framework, we understand that in pediatrics, history is unreliable. There may be multiple non-specific signs, and those signs may mean anything from, say, a URI to an hypothermia to something very sinister like a pneumonia or a sepsis. Presentations are different from adult disease. So when I'm talking of pediatric pneumonia, the presentation will not be sputum cough. The present could be just decreased feeding. The presentation may not even have fever for all that matter. Again, the progression and the complications are very different from adult disease. So progression in terms of when we are seeing pneumonia, we may not even understand that when is it that the child now developed a ARDS or has gone into a complication. So when we are reading and understanding of trying to follow up an STW, this is what we should keep in mind, that at the end of the day, this document can serve these purposes. That A, identify a sick child. Second, tell me, give me a direction of syndromic management, which can be useful, can predict and give me a flow chart where I'm able to predict a complication early and manage the same early. Also, what pediatric STWs has done beautifully is talking of diagnostic stewardship. So remember, in adults, most of the information the patient would be telling us when they are coming. In pediatrics, a lot is dependent on observation, a lot is dependent on your third sense in which you are diagnosing a child. So diagnosis cannot be generic and generalized for all. We are going to draw samples, we are going to subject small little babies to different sorts of tests. So we have to be very wise in choosing the right test. The right test, interpreting the test in terms of cutoffs for age. So the cutoffs are very different for simple things like calcium, hemoglobin, CRP, thyroid stimulating hormone. Again, the sample, what sample are we going to choose for my STW to work and to follow? For example, sputum cannot be drawn in any child less than 7 or 10 years of age. So when I'm making a recommendation or when I'm trying to implement a standard treatment guideline for diagnosis of pneumonia and differentiating from tuberculosis, how do I do it differently? Third is timing. Taking fasting samples, taking clean catch urine samples may not be very easy. So is there something else that I can detect and treat those patients early? And fourth is again treatment choice. So is my test going to guide me in terms of my treatment choice? Has to be thought of when we are looking at STWs. So the next 2-3 minutes, I will just be giving an overview of how these common illnesses. So yes, the pediatric burden of disease still very much covers and talks of fever, diarrhea, cough, and seizures, even though we've had a whole lot of national programs around it. But how can we detect those who need more specialized care earlier? So this is just an example of how an acute diarrhea STW would look like. So we would be starting with something which can define objectively diarrhea in children. So this has been very beautifully done here. And again, something that can be asked for or can be examined by a layperson. So when we are asking, we are always going to emphasize two things. One is, how has the child been behaving in daily activities, including his feeding pattern, his sleeping pattern, and his play activity? Has there been anything more objective which the mother can tell us? And then the examination has to be something which is standardized. So malnutrition is something that can help categorize risk for many, many conditions for us. And then some simple examination skills. So the skin pinch test works very, very well in determining the degree of dehydration and the need for referral. And then finally, if I was to look at management protocols, the management has also been very clearly classified. So if the signs are correctly picked up, again, these signs are not very labor intensive and do not need any specialist training. But once the signs are there, then the protocolized management as per the STWs would be guiding us on fluid management and monitoring. This would also somewhere incorporate. So as the diarial STG has very beautifully also mentioned, when is the child going to be monitored? If we are sending the child home in the first plan A, when are we going to call the child back for any of these complaints? If we are going to monitor the child with IV fluids, what are we going to admit and what are we going to follow? So as I was talking of diagnostic stewardship, things which are very finely interwoven in this STW is talking of when do we order a CBC, when do we order an electrolyte, and what are preferable. So some are essential, some are preferable. So for this learned audience, I would just reiterate that each and every word and every line of the pediatric SDGs has to be followed. There is a reason and there is a science to it why it has been written. So the next is fever. So again, fever, very, very common problem. And again, something which is very simple to ask and is replicable in terms of treatment and diagnosis options, right? So I think I just put these up to show. The last slide that I would want to show is sepsis and septic shock, because very frequently we do get children where they have missed treating sepsis, and the golden hour of sepsis management has a lot of implications on improving outcomes. So again, the STW would help us guide identifying a child who is at risk and when to suspect. So if you read when to suspect, these are all very generalized signs, but then each sign should not be missed. So I will just finish here and would just want to mention that in addition to these STWs, kindly retain cognizance of whatever the mother has told you in terms of symptom. For us, we may not be able to understand that to start with, but there might be a reason why that mother feels that so-and-so symptom has developed. Thank you so much for your time. Thank you, sir.
Thank you, Dr. Ashima, for sharing your experiences. It was really nice. In fact, it is very challenging to develop, Dr. Ashu, to develop these guidelines as well as to implement is more difficult, because they say the expert, they don't agree on anything. That is why they are expert. Thank you so much, ICMR team. Now we have another very interesting session related to Health Data Science Center. And for this, I invite Chairperson Dr. Ranjana Singh on the dais. Dr. Ranjana Singh, please come. And Dr. Anku Moni Sekya. Dr. Anku. The speaker is Dr. Jayanti Semwal. Please come. So this session is for 15 minutes. So I will request the chairperson. It is difficult, but I think you can do it, because ladies are more efficient than men.
Thank you.
Start. Okay. Thank you, sir. In a rapidly evolving world where data is one of the most valuable resources, the ability to harness it for meaningful insights has never been more important. So good evening, distinguished chairperson, respected seniors, and dear colleagues. As community physician and public health experts and researchers, we share a common mission to transform health research and healthcare delivery for a better tomorrow. And I am happy to share the initiative on Center for Epidemiology and Health Data Science by the Department of Community Medicine, Himalayan Institute Medical Sciences, Dehradun. It is a visionary initiative that aims to integrate science, technology, and public health for evidence-based policy and impactful research to improve healthcare services. Through the Epidemiology Data Center, we will try to bridge the gap between traditional health research methodologies and the powerful modern tools provided by the data science. This center won't just be a hub for cutting-edge research. It will be a vibrant place for learning, collaboration, and innovation by integrating advanced technology such as artificial intelligence, machine learning, and big data analytics into health research. And regarding overview, the center is basically conceptualized as a multidisciplinary platform that unites epidemiologists, data scientists, clinicians, and public health experts. Its scope encompasses for 4 key dimensions: interdisciplinary research, capacity building, policy impact, and collaboration. And through the center, we foster collaboration across diverse fields to create innovative data-driven solutions for all healthcare ailments. And recognizing the current skill gap in health data analytics, the center will organize specialized workshops, certificate programs, short courses to train researchers and health professionals in data management, modeling, and analytical tools. And through targeted interventions in underserved and high priority regions, the center aims to bridge the gap between research and real world health improvements, contributing directly to evidence-based policy making. And center will foster partnership with research institutions, universities, and global organizations to enhance data quality, research diversity, and the exchange of the expertise. And what is the role of AI in this Epidemiology Health Data Science Center? The role is basically within the center is pivotal. By analyzing large data sets from hospital records, community surveys, environmental sources, etc., the AI tool can identify hidden patterns that inform proactive health strategies. And AI-driven predictive models enable early disease prediction, disease trend analysis, and surveillance. And it also supports precision public health and enabling tailored interventions, timely and more targeted. However, with such technological advancement comes the responsibility to ensure data protection, ethical governance, and IT collaboration. So the center is committed to maintaining robust data privacy framework, ethical governance, adopting standards for data security, and building a strong IT partnership for secure data storage and sharing. And robust data protection framework will ensure that technological advancement proceeds hand in hand with ethical responsibility. And one of our major steps has been the introduction of an app-based real-time data collection system. And these initiatives allow us to gather real-time, reliable community-level data directly from the our field practice area and ensuring that health needs are identified promptly and accurately. Beyond research, the center's long-term goal is to foster a data-driven culture within the research ecosystem. So through the sustained mentorship program, ID training, and technological integration, the center aspires to build a new generation. And in conclusion, the Epidemiology and Health Data Science Center, it represents a forward-looking step towards integrated, data-driven, and ethically sound health research. Through collaboration, capacity building and technological innovation. It seeks to transform data into insight, insight into policy, and policy into measurable impact on communities. So, I would like to sincere thanks everyone, and especially for my Sunila ma'am for your enforcement man, and Umesh Kapil sir for giving me this opportunity, and also a big thanks to all organizing team. And now I would invite to my co-partner, Dr. Asha Chandola. She will highlight the activities undertaken under this center. Thank you, everyone.
Thank you, Doctor, for the nice presentation. Okay, good. Okay. Oh, lovely. Oh, la la. Oh, la la. That's sweet. आप सभी को नमस्कार. And thank you very much, the organizers, for giving us this opportunity to be here. Initially, I had planned to show you some hardcore science with databases, but because of the shortage of time, as Dr. Jayanti said, I'll briefly just touch upon the history, a little bit of history and rationale, and whatever little we have been able to achieve so far. Uttarakhand, you know, is in remote interior, but it's a treasure trove of biodiversity, and the strongest asset is its human resource. It's I think now second or third in literacy, you know, but they lack exposure. That's the problem. And I think in that context, the center plays a very important role. Okay, maybe how do I? Oh, good. Okay. Dr. Jayanti has already said that this center was not born just one day. It's been conceptualized over years, you know, and a bit of history. It was launched as a joint initiative way back some 10 years ago by Health Secretary. And initially, the joint initiative functioned virtually, but now culminating into the current center a few years ago with base at SRHU. And these are the collaborators. Excuse me, SRHU, Jolly Grant Uttarakhand, APJ Satya Group, Medanta, Max, Parul Trust, Nottingham Trent University. Almost all of these partners, except perhaps the second last, have been very active, and already we've got MOUs and things going for internship of students and all. And especially recently, earlier this year, we were able to set up an AI and data analytics center at APJ School of Management, Dwarka, Delhi. So it's doing good. So this was just the launch. You can see the, you know, Katoch. Yeah, I can see Dr. Katoch there. People from SRHU and different partners. And okay, Dr. Jayanti already explained to you that data-driven quality research for informed decision-making. This is the idea, to develop an effective research ecosystem, you know, using data science technology to pave way to Indian guidelines and policy development, especially in the remote area. And second is capacity building to cater to the cross-disciplinary skill crunch that Dr. Jayanti mentioned. Well, just a word about the rationale. You know, the data processing technologies, there has been such a massive advancement, you know, and as all of us know, application to health and biological problems would provide better insights, and especially for medical people, you know, identification of risk factors and biomarkers. And another thing is that informed decisions driven from indigenous databases. And I was very happy to see this ICMR initiative on standard treatment workflows and protocols, because this is exactly what we need. I mean, it's very sad that the average Indian citizen continues to be treated by guidelines which have been evolved overseas on the basis of a handful of population, mostly United States. So that is very, very important. And in recent times, you have fantastic databases coming up, beautiful data sets in health sector, life sciences, but unfortunately, these remain under or unutilized. Mostly, either people are not aware or for the lack of want of cross-disciplinary expertise. This lacuna, our center addresses very beautifully. Okay, so apart from research, capacity building, supported periodically by our Uttarakhand councils and Indian science academies for the conduct of workshops, etc. We have been able to, it is basically for linkages with local colleges, learn while serve outreach programs, periodic workshops, training programs, national, international symposia. And the team comprises enthusiastic young researchers, faculty and PG postgraduate students, and renowned Indian and overseas scientists. Some of the experienced data scientists and who are biologists also are Graham Ball, an internationally renowned data scientist, applying AI and ML tools to problems in biology and medicine. And then we have another associate, Dr. Dongling Tong, a very young person, bioinformatics, and she's using AI ML techniques for detection of cancer, etc. And she's a visiting scholar also. And Graham is a visiting professor. And recently, Ian Baker from Derby University has also joined our group. He's a data mining statistician, and Professor Sanjeev Srivastava, he has always been there with the IITB. So we have our expertise-wise good. And then we have our local strong people. You have one expert epidemiologist there. Okay, yeah. All right. And PG students, they are very important. There's one sitting here. Kahan hai? Sabko shakal dikhao apna. Anjali, she's one of the postgraduate students. These are people who are contributing, and activities. Just quickly, I shall summarize that in the short span, let's say last 4 or 5 years, we have been able to identify and establish linkages. This is the most important thing, among researchers, academics, and practitioners in epidemiology, healthcare, data science, from both academia and industry, India and abroad, with a view to develop and explore Indian population-specific databases. I hope that all the scientists who are ICMR scientists who are involved in this STWs, developing universal protocols, they also, I'm sure, they keep into mind the population-specific responses to diseases and the treatments of people. Anyway, so, and also the center team has presented epidemiological researches involving big data in scientific meetings, seminars in India, as well as overseas. Last one was, I think, in Athens, Cambridge, UK, Milan. We're dealing with maternal child health, alcohol abuse, adolescence, and iodine malnutrition. The center has published full-length paper. This is only very recent, in the last 4 years, okay, with high-impact journals, and which is quite high, 1.8, and trained dozens of joint Indian Science Academies summer research fellows from all over India who come to us to be trained in research methods and data science tools. And we have also been successful.
Excuse me.
Yeah.
May I request you to wind up because it.
Are you asking me? Oh, sorry, excuse me. You are sitting there, beautiful chairman. But sorry, I didn't know we had a chairperson. Okay. Yes, please, I'll wind up. You're asking me to wind up, isn't it? Yeah. Okay. And we have equipped cross-disciplinary skills leading to plump placements, organized international symposia. I just give you a list of these. The last one we did was in biology and medicine AI era, about 4 Indian and 15 overseas reputed scientists. Again, this is here a list you can see. And this is not national conferences. These are symposia where we get experts targeting our Uttarakhand college teachers. And these are basically, sorry, they are basically in the form of panel discussions so that everybody can participate, from college teachers to the experts. Thank you very much.
Thank you. Thank you for the beautiful and detailed deliberation of the functions of Health Data Science Center. Thank you very much. And I declare the session in.
Thank you so much, Chairpersons, Dr. Ranjana, Dr. Ankut, and the speaker, Dr. Jayanti and Dr. Asha. So thank you so much for giving this concept in a very brief period of time and sticking to the time. Now we have the last session of the day, and I hope we have the speaker, Dr. Saira. She is here. And I will request the chairperson, Dr. Sonu and Dr. Anil to join on the stage, please. Let's give them big hand. This is the last session, but very important session on artificial intelligence, evidence-based analysis of artificial intelligence application for MCH in vulnerable population. Over to you, ma'am.
I request Dr. Saira to please stick to the time, because even though you're the last speaker, probably we have audiences who probably we are sitting between their going home and your speech. So thank you.
Thank you so much. I try my best to be in time. So it's a transition between good evening and good afternoon. So, respected Chairperson, Madam, today we are going to discuss about a very important topic, the present relevant topic about evidence-based analysis of artificial intelligence-based applications for maternal and child healthcare access in vulnerable populations. I am Dr. Saira Manaz. I am a professor of community medicine at Jawaharlal Nehru Medical College, AMU, Aligarh. So, with the background that there are around 287,000 maternal deaths which are happening annually, and 94% of them are within the low resource settings. 5 million deaths of under 5 children yearly. Among the vulnerable groups like the poor, the rurals, the migrants, and the ethnic minorities, we face multiple barriers for their health seeking and cure. According to WHO, each year, this image shows how poverty, poor access, and low healthcare use lead to adverse outcomes for mother and children. The blue arrow on the right, it shows, sorry, can somebody, some IT person help me with this? This is not going back and forth correctly. Thank you so much. Thank you so much. So the blue arrow on the right, it shows and signifies AI interventions and represents how technology can disrupt this cycle by improving early detection, decision making, and continuity of care. In short, AI can bridge the gap between limited resources and quality healthcare access. Artificial intelligence can bridge major gaps in healthcare equity. By using tools like mobile phones and smart systems, AI brings advanced healthcare support even to remote and low resource settings. It helps standardize care and provide real-time decision support and reduce costs, especially for non-specialist workers in underserved communities. Ultimately, AI offers a scalable and sustainable solution to deliver quality healthcare for everyone, regardless of geography or income. Our objectives in this were first to review how AI is being used in maternal and child health, second, to evaluate the evidence and key challenges in its implementation, and third, to recommend practical, equitable frameworks for sustainable AI deployment in vulnerable settings. To provide a comprehensive evidence-based analysis of AI applications, specifically targeting maternal and child healthcare access in vulnerable populations. We examine current implementations, evaluate their effectiveness through available evidence, identify implementation challenges, and propose frameworks for future development and deployment. We conducted a systematic literature review covering publications from 2018 to 2024. Databases included PubMed, Google Scholar, and health informatics repositories. We included studies that specifically used AI in maternal and child health, focused on vulnerable populations, and reported implementation outcomes, and were published in peer reviewed journals to ensure data quality and credibility. We applied modified grade criteria to evaluate evidence quality, considering factors including study design, sample size, outcome measurement validity, and potential for bias. Given the emerging nature of this field, we included high quality pilot studies and implementation research alongside randomized control trials and observational studies. AI applications in maternal and child health can be grouped into 5 domains: remote monitoring, diagnostics, predictive analysis, decision support, and workflow optimization. Together, these technologies created an integrated ecosystem that supported both providers and patients, even in low resource environments. AI powered mobile health applications represent one of the most extensively studied domains for improving maternal and child healthcare access. These applications typically combine smartphone based data collection with machine learning algorithms to provide personalized health recommendations, risk assessment, and care coordination, increasing antenatal attendance by 23% and skilled birth attendance by 31%. The Safe Delivery app used in African countries reduced perinatal mortality by 38%. The tools use AI for personalized advice, triage, and reminders, often functioning on basic smartphones. Wearable devices and Internet of Things sensors enable continuous physiological monitoring with AI driven analysis for early warning systems. In India, the Mamta study, AI assist fetal monitoring reduced emergency C sections by 42% and NICU admissions by 28%. Edge computing allows real time analysis even when internet connectivity is limited. AI powered computer vision applications enable sophisticated diagnostic capabilities in settings lacking specialized radiologists or sonographers. These applications show particular promise for prenatal screening and pediatric diagnostic imaging. They have a 94% sensitivity and 89% specificity in detecting fetal anomalies. Like the Mom Connect program of South Africa utilizes AI powered chatbots for pregnancy related symptom assessment. Voice pattern analysis using machine learning algorithms shows emerging promise for detecting postpartum depression and child development delays. Machine learning algorithms analyze multiple data sources, can identify high risk pregnancies earlier and more accurately than traditional risk assessment tools. For example, study in rural Bangladesh found that AI models using only basic demographic and clinical variables achieved AUC values of 0.81 for predicting birth complication. The Growth AI study in Kenya demonstrated that community health workers using these tools identified 34% more cases of stunting and wasting compared to standard visual assessment methods. Similarly, machine learning models analyzing child behavior videos identified autism risk with 85% sensitivity and 79% specificity, enabling early developmental screening where specialist access is limited. AI driven platforms help non specialist providers make accurate clinical decisions. The SMART platform provides AI powered clinical decision support for community health workers in sub Saharan Africa. The Adapt Learn platform improved training efficiency, achieving 40% faster learning and 35% better knowledge retention among healthcare workers. Despite progress made, several challenges remain. The digital divide represents a fundamental barrier to AI implementation in vulnerable populations. Along with this, limited digital literacy among targeted population affects both adoption and effective utilization of AI powered health interventions. Vulnerable populations may face heightened risks from data breaches or inappropriate data use. AI applications must integrate seamlessly while existing healthcare workflows. A meta-analysis of 23 studies examining AI-powered antenatal care interventions found significant improvements across multiple outcomes. 31% increase in recommended antenatal care visits, 28% improvement in pregnancy complication detection, and 22% reduction in maternal mortality rates. These improvements reflect AI's real-world impact in vulnerable populations. AI tools for rural areas work effectively even offline, maintaining 89% functionality, and simulation based training boosts provider competency to 85% compared to 61% with traditional methods. For minority groups, algorithm bias remains a concern with 15 to 30% lower accuracy through culturally adapted designs improve engagement by 68%. In refugee settings, mobile AI clinics reached 78% coverage, improving birth preparedness, and mental health AI achieved 84% accuracy in detecting mental abnormalities. From an economic perspective, AI interventions save between $89 and $267 per pregnancy. Most achieve a return on investment within 18 to 36 months. In community terms, every dollar invested yields an estimated $3.4 in benefit, a strong case for scalability. To ensure fairness, AI systems now use multiple fairness metrics rather than one, improving equity across diverse groups. Community co-design greatly enhances trust. Privacy is protected through federal learning and differential privacy, keeping data secure while maintaining performance. Community-led data governance ensures transparency and fair use. Finally, shared benefits and stakeholder oversight help build long-term trust and sustainability in AI-driven healthcare. AI in maternal and child health is rapidly advancing. Next generation models like GPT show 92% accuracy in obstetric decision making. Edge and federated learning allows secure offline and collaborative AI use in low resource areas. Integrating AI with social services enhances outcomes by 28 to 35%. Finally, regulatory sandboxes and global cooperation are helping scale innovations 45% faster, ensuring safer and broader adoptions. Involving diverse teams cuts bias by 67% and raises user acceptance by 23%. Iterative development speeds up impact by 34% and improves satisfaction by 28%. Early adopters enable 45% faster rollout, and transparent communication increases trust. Continuous tracking detects 89% of issues early, and regular feedback raises user satisfaction for 34%. Public private partnerships strengthen long term programs, improving fiber sustainability by 78%. Regulatory sandboxes enable 45% faster, safer innovation. Across diverse settings, AI has shown major impact in sub-Saharan Africa, urban refugees settlements among the indigenous communities. Together, these examples highlight AI's global potential for equity, efficiency, and cultural inclusivity in healthcare. Most AI studies in maternal and child health are short term and small scale, limiting confidence in long term impact. Selection bias and weak control designs often overstate results. Many programs fail due to low community engagement, technical issue, or unsustainable funding. Finally, risks like provider skill loss, digital inequality, and cultural disruption highlight the need for ongoing monitoring and balanced implementation. AI implementation costs range from $250,000 to $2.3 million, but scaling reduces costs by 67%. Public-private partnerships extend sustainability.
Dr. Saira, you have a little over a minute.
Yes. Revenue through cross subsidies, government funding, and value based contracts improve sustainability. We need long term and comparative studies to assess AI's real impact. Future research should focus on scaling, integration, and community engagement. Strong evaluation methods and ethical, inclusive frameworks are vital for sustainable, equitable AI use. In conclusion, AI has immense potential to transform maternal and child healthcare access. If implemented responsibly with ethical safeguards, inclusivity, and strong community participation, it could prevent up to quarter of all avoidable maternal and child deaths globally. AI's true value lies not in technology itself, but in empowering equitable and sustainable healthcare delivery. Thank you. In the end, I'll like to say that humans in the loop isn't optional. It's always that used to that AI stays safe, fair, and useful. Thank you so much.
Thank you, Dr. Saira Manas. That was a beautiful presentation. Perfect timing.
Thank you.
And, yeah, actually, since morning we've been hearing how there is so much as gap in the health system in our country, whether it's expertise, whether it's infrastructure or the training and manpower. And AI is the answer to many of those. It may not be panacea for all ills, but it is answer. And with your systematic review, you have actually brought up very beautifully how you can use AI, what are the advantages, and how you can avoid and any potholes. So that was very good. And I think, sir, it is too late for questions. We'll let it go. Yeah, I think maybe hoga questions. Nahi to abhi tak heart uth jata. Thank you so much. Okay.
Thank you. Thank you so much. Thank you, everybody, for listening.
Thank you, Dr. Sonu, for chairing the session, and a special thanks to Dr. Saira. Very nice presentation. Although it was the last presentation, but we always remember desert is always in the end of the meal. So it was the desert. Thank you so much. And thank you so much for patient hearing. We have some audience sitting right from the 9 o'clock till 5:15. So thank you so much. And tomorrow we'll again start at 9 o'clock. Okay, thank you. All the best.